Well, welcome everyone. My name is Chris Hayward. I'm a cardiologist from St Vincent's here in Sydney. It's my great pleasure to welcome you also to University of New South Wales hosting our symposium. Before we start, I'd like to acknowledge the traditional custodians of the lands on which we meet, the Bidjigal people. They've been here a lot longer than we have. I pay my respects to their ancestors, past and present, and anyone here who from those peoples who may be here today. SARI, which is hosting this symposium, is born out of a need for increased awareness of sarcoidosis as a condition that's quite difficult to diagnose, treat, manage, adjust therapies across a whole range of organs and conditions. And so it's great we've got a sprinkling of different speakers from different areas, different specialties, and hopefully you'll appreciate the difficulties that we have as doctors, and then we'll have the opportunity later on in the day to hear the difficulties that you have as patients. So thank you very much for participating in this our symposium. This is really our first sort of outreach, first effort to connect with the sarcoidosis community. Branko, who'll come up in a second, has been instrumental in driving this symposium, but also getting together interested parties, forming databases, forming some kind of network that we can work with to hopefully generate funds for research, collaborations in the future. So I'll hand over now to Branko, who's our convener, and he's got some logistics to update you with. Over to you, Branko.
Thank you, Chris, and thank you very much for coming on this lovely Saturday morning. Most of you, I'm sure, could be doing something else, but so it's particularly good that we've had so many people turn up. About 110 have actually registered, so we'll see who will ultimately arrive. Just very simple logistics. Bathrooms are downstairs, so if you need to use the bathrooms, please go around and take the lift down, or take the lift or walk down the stairs. There will be a morning tea, a lunch and an afternoon tea, so there's plenty of time in between to chat and to build relationships. One of the important parts of this symposium is not only the fact that you'll be getting the latest knowledge available on both diagnosis, management and cure, if such a thing exists, of sarcoidosis, but we are desperate to try and make a bit more noise in the community, because we know there's about 25,000 patients in Australia based on data from Denmark, because we actually don't have any data in Australia about how many patients have got sarcoidosis. We think based on Danish data it's about 25,000, and we need to make some more noise. So please stay till the end, because we plan to set up a patient forum that will make some noise in the future. So we have all the clinicians involved in SARI here presenting, some that are not involved in SARI directly but have offered to present, so I thank them profusely for having devoted their time today, and I hope that you enjoy it. I have asked them to present their slides, but also to try to explain to you as clearly as they can what the slides actually mean, and I'm sure they will do that. So again, enjoy the morning, and please stay around till later in the afternoon, and we'll have a very interesting patient session. We've got 5 very interesting patient speakers, all of them with their own particular perspective on the condition, how they've managed it. We have at least one patient who's been managed out of Taiwan, which is really fascinating, how different it is from how we're looking after our sarcoidosis patients here. Because sarcoidosis is an international disease. The incidence and prevalence is biggest in Scandinavian countries, Denmark, Sweden, all the Nordic countries, as well as Japan. It's more prevalent amongst black people than white people in the US. So it's a very anomalous, unusual condition, and it'll be very interesting to see what sense we can make out of it. So enjoy the day, and thank you very much again for coming. Maybe I can ask Paul Thomas, who'll be giving us a plenary, which will be both an overview of sarcoidosis, but also then focusing on respiratory or pulmonary sarcoidosis, which is his specialty. Thank you, Paul.
Thank you, Branko, but particularly thank you, Branko, for organising everything, both organising SARI and as well as the symposium today. And, oh goodness, I'm being recorded as I speak. It's a bit creepy. Perhaps I'll say nothing. So this is me, and this next slide is that I don't have any particular conflicts of interest, but I would prefer to say that I had funding for sarcoidosis research, but we don't. I am peripherally involved in a NHMRC grant through Melbourne University, which is looking more at epidemiology of long-term airway function. Two companies probably have approached me probably because of SARI itself, with the view to perhaps doing clinical trials here at Prince of Wales or Scientia, clinical research up on the corner of High Street, which is good news because it's Australia is usually at the bottom of the list of places to try and do clinical research. Those discussions are ongoing, as they say. A bit of history. It's always good to start with background. And Jonathan Hutchinson was probably the first person to describe cutaneous sarcoidosis in the UK in a 58-year-old policeman who had a number of skin lesions. He didn't give it a name, but he just called it, or described it as the skin having dark patches of dark purple colour. As Branko mentioned, the Scandinavians really have seen much more of sarcoidosis. And it wasn't until César Buch described it, who's a Norwegian dermatologist, and he was the one who coined the name sarcoid. The reason for that was that it was a fleshy growth, and we now talk about sarcomas as being malignant fleshy growths, but he called it a benign sarcoid of the skin. So he was the one, he's the one there on the top left, that's Jonathan Hutchinson there. More Scandinavians describe different syndromes, and the Hereford-Waldenstrom syndrome, characterized by uveitis, enlargement of the parotid gland, and sometimes palsy of the facial nerves were described. And then Löfgren here described bilateral hilar lymph nodes, so that's the lymph nodes in the middle of the chest, along with arthritis and fever, and that's him over there. And I worked for these two gentlemen. Donald Mitchell was at the Royal Brompton, had an interest in sarcoidosis for a long time. And Jerry James at the Royal Free and at the Royal Northern Hospital actually looked after his sarcoidosis clinic when he retired. But I didn't let him retire. I used to call him up and say, would you kindly come in and see this rather troublesome sort of condition in one of your patients? And Jerry would come in and chat to them, and he had an encyclopedic memory of their background, right down to their occupations, and say, are you still running the chip shop? And things like that. He also founded WASOG, which is the World Association of Sarcoidosis and Other Granulomatous Disorders. Mainly for clinicians. It still exists. It's meeting in Istanbul in June, I think, and now Athol Wells, I think, is the president. That's the background. So what is sarcoidosis? As you probably realize, we don't entirely know. It's a sort of pattern of disease, and oops, wrong button again. It's a pattern of disease, and I've written that it's a non-infectious inflammatory disease, which will probably annoy Branko, but it's characterized by an overactive immune system and typically what we call non-caseating, and forgive me if I drop into sort of clinical speak, but non-caseating means it doesn't look like cheese under the microscope. Caseous granulomatous disease is more typical of tuberculosis, and so we define it as being not like TB, with clusters of lymphocytes, so white cells, and no evidence of microorganisms. And if you can see this, this is the inside of the bronchi seen at a bronchoscopy, and it should be all smooth and pink, but there are little nodules here, white nodules, that I hope you can see. I have no control over the lights, so it may, unless Mr. AV controller is listening, it would be nice if we could turn the lights down a little bit. But there are little nodules here which shouldn't be there. If you biopsy them, this is what they look like. And you can see these rounded areas with a sort of central pink part. And these are the granulomas. Here's a well-formed granuloma here. And the dark blue bits are the blood cells or lymphocytes. And the middle bit is more comprised of what we call macrophages and histiocytes. And they're the cells that go around gobbling up foreign material. And so they are reacting to something, but we don't know what. And as respiratory physicians, we think that sarcoidosis is important to us because probably of all patients with sarcoidosis, the lung is affected in maybe 70% of patients. We don't, which leads on to the question, why do people get it? So if everyone's exposed to something, if they're breathing it in, and then there's a postulated antigen or protein or something that's causing the reaction, why does it affect parts of the body and not other parts? And we think and Elisa will probably go into this a bit more detail, but we think there's probably exaggerated inflammation at the disease site, but elsewhere there's a lack of inflammation. In fact, it's actually suppressed. And the idea is that locally at the site of the inflammation, there are lots of T cells, those are lymphocytes or T helper cells, and they predominate, whereas those T cells that regulate the behavior of the other cells are in the minority, whereas away from the site of inflammation, the reverse occurs. And to some extent, that might be supported by the fact that in the peripheral blood, if you actually look at the lymphocyte counts, in patients with active sarcoidosis, the number of lymphocytes is lower than predicted. So you often see that there's a little star, red star by the lymphocyte count in people's blood counts, and meaning that the lymphocyte count is low. Sometimes that excites general practitioners to send the patient off to people. Excites the requesting doctor to send the patient off to a hematologist. So there are many theories as to how sarcoidosis occurs, but there's a real paucity of studies looking at the immunology and the way that the cells are regulated and dysregulated. The cause of sarcoidosis is very complex. The genetics are complex in that it's more common in siblings, but it's much more common in dissimilar twins, as you can see, sevenfold up there. And in identical twins, it's 80 times more common than expected. But it does also occur more commonly than expected in a spouse. And assuming that spouses aren't related, then that does suggest that it's not just the genetics, there's also an environmental factor. And this rather technical stuff here is the human leukocyte antigen types on chromosome 6. And so there are a number of these different sort of hieroglyphic type genotypes that are associated with sarcoidosis. And some are associated with a better prognosis, and some are associated with more prolonged disease. And so particularly this one here is associated with Löfgren's disease and has a good prognosis. We don't routinely look for those, or we don't request those genetic analyses, simply because it wouldn't really affect how we treat patients. And as Branko mentioned, racial groups are differentially affected. It's more common in Afro-Americans with more severe disease, and you tend to read on the internet more severe disease in those groups who not surprisingly are concerned about the diagnosis. It's also more common in Scandinavians and Northern Europeans, and to some extent in the Japanese too. A number of studies have tried to look at the etiology, the factors that actually cause sarcoidosis. One of the larger ones, over 700 patients, was the Access study in about 20 years ago. And they showed that probably agriculture, soil, and moisture-laden conditions were associated with sarcoidosis. And a few smaller studies have actually looked at other environmental events. And this one, which I have highlighted here, was an episode where a building caught fire, then the inhabitants, I think it was an office, moved back in, and then a large number of the individuals in that office developed sarcoidosis. And it was thought that the fire damage, along with the water damage secondary to the firefighting, probably caused more fungal growth before it had dried out, and then the people were exposed to it. And that's perhaps true of other events, such as the World Trade Center disaster, where firefighters developed more cases of sarcoidosis were found in firefighters than you would expect from the general community. Whether that was due to some of the dusts, whether it was due to anything else is unclear. But certainly sarcoidosis and a sarcoidosis-like reaction is seen in people exposed to mineral dusts. So all of those minerals, particularly silica, but also beryllium used in aircraft manufacture, are associated with the development of sarcoidosis. There was a sort of smallish outbreak of sarcoidosis in the crew of US Navy aircraft carriers. It wasn't clear why that was, but they did routinely grind down the decks of the aircraft carriers to get better traction, and it's possible they were exposed to either silica or other minerals in that process. I mentioned in the previous slide that we try to distinguish very carefully whether somebody has sarcoidosis versus tuberculosis, because the treatments are very different. If a patient has tuberculosis, they usually have 6 to 12 months of treatment with antimicrobial agents. But there is an interesting connection between sarcoidosis and mycobacteria, other bacteria that can cause disease in addition to TB. And there is an increased response in sarcoidosis patients to TB antigens if you take their blood and react them outside the body. But if you actually inject people with TB antigens, the patients with sarcoidosis have less response than expected to that antigen, which perhaps reflects what I was saying earlier about that sort of seesaw mechanism, that in one place in the body, people with sarcoidosis react to TB, in another they don't. The interferon gamma release assay is a test for TB, and it doesn't show any difference between sarcoidosis patients and non-sarcoidosis patients in countries where TB is common, suggesting that there's probably not a connection with the TB disease itself and sarcoidosis. So from that slide, you can gather that it's fairly unclear as to what causes sarcoidosis. And as many of you know, particularly if you're here, it can be a very insidious disease. It can take months to years to actually diagnose. Occasionally with particular syndromes, it can be quite an easy diagnosis to make, but it's often mistaken for other diseases, and a number of you will probably have heard that or experienced that you've had some radiology and it's been said that you've probably got a lymphoma. And in a way, fortunately, it's been sarcoidosis rather than lymphoma. But nonetheless, it's a concern at the time. And fatigue, arthritis, dry cough is quite a common presentation for our respiratory patients. Often the radiology has been done for another reason, but it may be that some symptoms have provoked either a chest X-ray or some other radiological investigation. And it can affect virtually any organ. It used to be that immigration chest X-rays were a great source of finding people with sarcoidosis, and probably the only study that I'm aware of in Australia was Roger Allen looked at people who were having routine surveillance for tuberculosis. So they used to have mass chest X-rays, and they'd go around X-raying people and looking for people who might potentially have tuberculosis, because it could be more or less a silent disease and did have public health issues. And he looked at that, and he estimated, I think it was somewhere around 7 per 100,000 people perhaps had sarcoidosis in Australia, which would be an underestimate because it's only looking at chest X-rays, but that would fit with some of the other sort of northern European countries. This is, if a particular syndrome, as I mentioned very early in the talk on the history of sarcoidosis, these are sort of relatively easier presentations to identify. Erythema nodosum just means red and a nodule, and typically occurs early in the disease as a presentation. It occurs usually over the legs, and these little round, mildly tender lesions appear and last about 2 weeks and then fade with a sort of bruise. And it's in association with bilateral hilar lymphadenopathy. This is the heart here on a chest X-ray, the lungs in black. And these round blobby bits shouldn't be there. Those are lymph nodes around the middle of the chest. And that's associated with fever and Löfgren's syndrome, which usually doesn't require any treatment. It does require follow-up, but it usually doesn't require any intervention. And as I mentioned earlier, the Herford-Ordensstrom syndrome is associated with parotid enlargement. And as you perhaps can see in this patient, and you wouldn't know whether they've got uveitis because somebody's kindly covered the eyes with a large black rectangle. As I mentioned, sarcoidosis can affect virtually any organ, including quite rarely, fortunately, the brain. These areas of increased activity on a cerebral MRI are suggestive of active disease, and these round bits in the spleen and some less obvious ones in the liver are actually suggestive of sarcoidosis. It can affect the bones. You can get cysts in the bones, which you won't be able to see, I don't think, but that can sometimes provoke anxiety as to what the lesion might be. And it has a predilection for the face, scalp, and around the ears, and also particularly the eyebrows here, as you can see in this patient, and also around the nose, particularly in Afro-Caribbean patients. And that's sort of the purplish color of lupus pernio. And how do we make a diagnosis? It's usually a composite diagnosis with a clinical pattern and the exclusion of other diseases. So we want to exclude tuberculosis in particular. We want to make sure that it's obviously not a lymphoma if that question has been raised, and whether there are the appropriate symptoms and signs. And usually we resort to chest X-rays, but more commonly now CT scans. PET scans are very useful, but more difficult to obtain. And we do still use the angiotensin converting enzyme as a way of of looking to increase the likelihood of the disease being present. And as I mentioned, peripheral blood lymphopenia, or lack of a low level of lymphocytes in the peripheral blood, is helpful. But what we do really need is a bit of tissue to make sure that we are absolutely certain that this is the disease we're dealing with. And a biopsy either of a lymph node that's been identified, or what we now call a EBUS, or endobronchial ultrasound-guided biopsy of one of those lymph nodes, such as here, can be done. And although it's tricky to do, most large hospitals now can do that, a fine needle aspiration of those lymph nodes. We usually do bronchoalveolar lavages because there's a particular pattern of lymphocytes, but it's suggestive but not diagnostic. So we prefer an actual biopsy or an EBUS sample from a lymph node in respiratory medicine. Obviously, if there are large lymph nodes that are easily accessible, we would prefer to biopsy those and do something more, something invasive like a bronchoscopy. In terms of the blood tests, the angiotensin-converting enzyme has a reasonable positive predictive value, but it depends on the background of the patient. It can be higher in patients with silicosis, and we think that the enzyme itself is generated in those granulomas that I showed you earlier. That enzyme is then released into the blood, and then you can measure it. So any other disease that has granulomas will actually have an elevated ACE level. And as I've said, it's reasonably specific, not terribly sensitive, and it's less good in early stages of the disease or in people who only have things like Löfgren syndrome. As I mentioned, it probably reflects total body granuloma burden, and if you're treated with drugs for hypertension, ACE inhibitors are used, and so therefore the level can be low. But you can actually get around that with some laboratories offering the total protein instead of the activity of the enzyme. I've put in the Covine test, but it's no longer used. It was a homogenate of human sarcoidosis spleen. And what we used to do is inject into the forearm that homogenate and to biopsy it again 6 weeks later. If it was positive, a little nodule would appear, and also under the microscope, those granulomas would be seen. And so it was useful in those days, but it's obviously getting human spleens is not a common practice anymore. In terms of angiotensin-converting enzyme and disease activity, there's a sort of approximate connection and relationship between the ACE levels and the intensity of disease. This is measuring the intensity of a radiotracer taken up into the lung, and these are the levels of the ACE. And there's an approximate relationship you can see here, quite old data, and hopefully it will be repeated with more modern imaging such as the PET scan. Another way of looking at markers in the blood is to look at the receiver-operator curve analysis. And in these analyses, specificity is on the x-axis, sensitivity on the y. And if the test achieves that line there, then it's not a very good test. But if it achieves a line that goes up and then across like that, then that is a better and more sensitive and more specific test. And you can see that the angiotensin-converting enzyme has a reasonable appearance on that plot, but a more recent addition to blood tests, which is the serum interleukin-2 receptor, has a better profile. It's early days for the interleukin-2 receptor blood test. It's not commonly available. And it is thought to also be made in the granulomas and to be released into the peripheral blood. And nowadays, some of the clinical trials are beginning to add that to their assessments of patients' response to treatments. So there is some progress. Another marker which is made in the granuloma is chitotriostase. It's, again, has similar characteristics, but hasn't really caught on and is not commonly available from commercial laboratories. The radiological stages for pulmonary sarcoidosis are divided into 4, where 0 is normal. And stage 1, wrong button, is where you see those hilar lymph nodes that I showed you earlier. Stage 2 is the hilar lymph nodes with infiltrates into the lung fields. And stage 3 is then where the infiltrates are present, and stage 4 is where fibrotic changes occur with cysts in the lungs. And the stages were all described prior to CT scanning, and they probably don't really, CT scans have too much diversity to be able to sort of classify people in a similar way. So in a way, the stages still remain a sort of useful way of looking at things. But the CT scans, of course, pick up much more detail, and so you find tiny nodules in the lungs, and so you would argue, is that stage 1, 2, or and are the lymph nodes still there? And you can still see small lymph nodes, and the definitions for lymphadenopathy aren't necessarily agreed upon. And although they're called stages, patients don't necessarily progress through stages. They don't go from 0 to 1 to 2, 3 to 4. The disease can regress and the patient can improve and never go through, for example, stages 2, 3 or 4. So stage is probably not the best name. These are the chest X-ray appearances of sarcoidosis. You see these large lymph nodes which shouldn't be here. And in this one, still large lymph nodes, but there are starting to be changes in the lung fields here. So this would be stage 1, stage 2. And as the annotation says there, this is stage 3, where the lymph nodes have gone back more or less to normal, and likewise there, but there are now infiltrates in the lung fields. Sorry. And in this one, you can see that there are changes down here and sort of cystic changes down in the base of the right lung there.
What do you mean by infiltrates?
Oh, sorry. Infiltrates just mean they're white bits which should be black. So the lungs should be black because they're full of air. And so the infiltrates are what we mean is sort of white areas. And by using the word infiltrate, we're sort of trying to say that we don't know whether it's infection, whether it's fibrosis, or whether it's some other process. We're trying to use a bland name that doesn't assign a particular pathological process. Does that make sense? Yeah. Sorry, I tend to lapse into medical speak. On CT scan, probably not the best image, you can see things like nodules here in the lung fields, which shouldn't be there. And one of the characteristics of the appearance on CT scan of sarcoidosis are these little nodules which run along the lung fissures, so that the fissures are the bits between different parts of the lung. And we think that those are probably granulomas in the lymph nodes that exist along those fissures. And that's quite a characteristic of sarcoidosis. As I mentioned, we used to use gallium scanning, a radionuclide 67 gallium scan. the isotope is more difficult to obtain these days, and so it's largely been superseded, but the descriptions of sarcoidosis still apply, in that in sarcoidosis, this is a human, not a panda. These are the parotid glands, this nose, and the eyes, and so you can see how the tracer is picked up in those particular areas where the disease locates. And so it's often known as the panda sign. And because of the lymph nodes in the chest being affected, which are broader at the base than higher up in the chest, creating a lambda appearance, it was known as the panda lambda sign, which trips off the tongue very nicely. And it's useful in showing a particular pattern, and it can be useful in demonstrating the places where a biopsy could be performed. So it's been superseded by PET, positron emission tomography, using 18-fluorodeoxyglucose, which gives a similar appearance to the gallium, but probably a bit better imaging. And you can actually do a CT at about the same time and then put the two images together, which I'll show you in a tick. In terms of Australia, it's not, the PET scans aren't indicated for sarcoidosis, whereas gallium scans are, but we can actually use a Medicare number pointing out that gallium is not available, therefore can we have a PET, please? That will change. Apparently the nuclear medicine fraternity are looking at expanding the indications for PET scans. This is a PET scan. This is the scan itself, and you see the black bits are areas of increased activity, so the glucose has been taken up there. And then this is the CT scan corresponding to that same image, and you can see little areas of white abnormality within the lung fields. And then if you, that's the coronal views, and then if you look at the views in the other direction, you can see that on the CT scan there's an area here, there's an increase in the opacity or infiltrate there, and this is the corresponding part of the PET scan with these rather black blobs, which are then converted into false color and superimposed on the CT scan, and you can see that then they co-locate here, here, and here. There is increased uptake in the left ventricle, but that's probably physiological because this is an old scan. So it helps you identify where there is active disease. Turn now to the treatments and who should have treatment and which drugs should we use. And I've quoted John Gibson, who wrote that comment after one of the BTS studies on steroids. What they did in that study was they took everybody and then they said, we'll watch you for 6 months and then randomize you into either treatment or with steroids or not. But if you did need treatment in the meantime, then we would give it to you. And what he and the other co-authors found was that a number of people did actually spontaneously get better, which does emphasize the importance of having placebos in the studies. And the best data that we have are for corticosteroids, or prednisone, prednisolone. And the other drugs that we do have and we use are methotrexate, mycophenolate, azathioprine, and some newer biological drugs, which I'll come to. Non-steroidal anti-inflammatory drugs are used for the arthritis and the aching and the other sort of systemic symptoms of sarcoidosis. And I'll just say that methotrexate was not very popular with respiratory physicians because in the literature, probably 30 or 40 years ago, there was a fair amount of opinion that methotrexate could cause pulmonary fibrosis. That data has been reviewed many times and is probably not that strong. The other concern is that it can cause liver dysfunction. And our rheumatology colleagues are much happier using methotrexate. They use it a lot for rheumatoid arthritis. And over the years, probably the concern about the drug causing pulmonary problems has receded. But nonetheless, I tend to prefer mycophenolate because it seems to have fewer side effects than methotrexate. But no, the data for mycophenolate are even less good than for methotrexate. This exciting sort of looking plot is really a way that people try to amalgamate lots of trials together and then come up with a sort of view that whether the conglomerate information helps you decide that one treatment is better than another. These are the sort of Cochrane reviews known as the Cochrane database of systematic reviews. The last one that I was involved in took 11 years to publish, and I said I'd never do another one again. They look at all the studies that are out there, and then they go through them carefully and then try and work out which ones have the best data. And they have to reject quite a number if they're not randomized, placebo-controlled. And often they come up, even though there may be, I think in this one, 13 studies, they ended up only with 2 here. And the overall effect that they could measure was that corticosteroids were probably better than placebo. And that's looking at chest X-ray, again, a conglomerate global outcome of chest X-ray clinical information and spirometry. This is another table of a group of studies. They weren't included in that previous slide because of usually the lack of placebos or randomization. The important thing to take away here is that we've got 4 studies here looking at the effect of steroids. And the main outcome which the reviewers were trying to look at was the vital capacity. That's the amount of breath that you can blow out as a maximum effort. And they showed that steroids probably had somewhere around a 10% improvement in that ability to blow out air. So the lungs were a little bit bigger than before they started the prednisolone. It's just that the steroids do work. Again, you do need placebos to be entirely sure that that's the case, but it is very suggestive. And these are the best data that we have for any drug in sarcoidosis. What has also become clear in the last 2 or 3 years is that in the past, too large a dose of prednisone has been used. And this is a study published in 2023, which just simply compared, compared 20 milligrams of prednisolone with 40 and showed that by the end of the 2 years, 18 months, there was no difference in the outcome in terms of a relapse or treatment failure. And so we probably have been using too high doses. I tend to use 25 milligrams of prednisolone myself. Another study that's emerged recently, 2025, in the New England Journal, was studying methotrexate versus prednisolone in sarcoid affecting the lungs. And as you can see, at the end of 6 months, there was no difference in the improvement in the vital capacity, the amount we can breathe out. Both achieved about 6% improvement. which is not large, but comparable with those other studies that we saw earlier. The methotrexate does seem to take longer to achieve that improvement, and the prednisolone or prednisone probably has a faster onset of action. What we can sort of conclude from that study is that we should probably start a drug such as methotrexate earlier, maybe in conjunction with steroids to get a rapid onset of improvement if we decide to treat the patient. There is a case for watching and seeing whether the disease is stable or is improving it without medication, but certainly this helps us change the way that we treat patients, and we shouldn't be giving people prednisolone for prolonged periods of time. And it wasn't uncommon for people to be on steroids for many, many years, as I'm sure some of you know. Other drugs, azathioprine, we do use occasionally. There are no randomized controlled trials. It's mostly case series. I'm looking at the wrong slide. And it does help to reduce the dose of steroids. Methotrexate, again, no randomized controlled trials versus placebo. The table on the right is really looking at the number of people who responded to methotrexate, so who improved, and these are the percentage of people who improved there. And leflunomide and mycophenolate really have only minimal data to support their use. Hydroxychloroquine actually has probably some of the best data. We and the rheumatologists still use hydroxychloroquine for patients. Peter McCluskey will talk later about the eyes, but he needs to monitor patients who are on that drug because it can have effects on the retina. Cyclosporine probably doesn't have a role. And I've written down minor drugs which are actually antibiotics. And there are mostly case reports and a few studies. Particularly this one was interesting in Black Americans by Wanda Drake. And she showed that more than half of her patients with cutaneous, difficult-to-treat sarcoidosis improved on anti-tuberculous drugs. And it raises the question again whether there can be a link with unusual mycobacteria and sarcoidosis, certainly in some patients. TNF inhibitors, so tumor necrosis factor alpha, is made in granulomas, and there's been a lot of interest in actually giving antagonists to that mediator. And these drugs here actually do inhibit TNF but aren't used in sarcoidosis. And infliximab has been probably the best studied, and I'll show you another plot from the Cochrane as to its efficacy. But very occasionally, some of these drugs, which are proteins made and injected because they're monoclonal antibodies made outside the person and then injected, can even be associated with the development of sarcoidosis, so it's quite a confusing area. Rituximab is anti-CD20, and there are some newer case reports coming out that suggest other inhibitors might be useful. I should talk a little bit more about antifibrotic drugs. We're using them now for people with pulmonary fibrosis, but only of a particular type. They haven't been studied very well in sarcoidosis, but the rationale is that it slows down the fibrosis that occurs in the lung. And they are available on the PBS, but the nintedanib, or it is available on the PBS, but the nintedanib does have significant side effects, particularly gastrointestinal, which a number of people find not very acceptable. But it doesn't reverse fibrosis, it just slows it down. This is a plot of the effects of infliximab, anti-TNF, And basically it showed that people who were had more symptoms at baseline improved on the infliximab. Again, it was only a small improvement, reasonable number of patients. It was over 100, and their lung function improved a modest 2 or 3%. So it does have an effect, but it was not large. What's the management plan? The best way is to, if somebody comes, is to make sure they've got a definitive diagnosis, and ideally you want a typical pattern of disease plus a biopsy. The biopsies or the granulomas usually disappear once you start treatment with steroids, and so it's really important to get a biopsy first before you decide to embark on treatment. As Peter will approve, all need an ophthalmological assessment and should carry on having that assessment on a yearly basis because sarcoid can affect the eyes and your vision is very important. ECGs with or without echoes and a Holter monitor, Chris will address. Pulmonary function tests should be complete with estimations of the diffusing capacity, and radiology and peripheral blood, as we sort of mentioned earlier. The treatment should be monitored, obviously. The recommendations from a number of different bodies relating to sarcoidosis are that probably for stage 1 disease and who don't require treatment should actually be followed up for 5 years, which is quite a long time for somebody with no symptoms. I don't know that that's always adhered to. But if stage 3 and 4 is present, then it probably is lifelong review. Stage 2, perhaps not, but the recommendations are that perhaps it should be. I've mentioned the other organs, and sort of slightly mischievously writing the extended role of the respiratory physician here, because we don't normally organize all these tests, but I try to nag patients into having them done. And I have to keep a little checklist to see what's been done. Chris will talk more about cardiac sarcoidosis, so I won't touch on that. As I've mentioned, stage 1, probably observe and maybe discharged if stable, and then consider treatment for stages 2 and 3, particularly if the disease appears to be progressing with prednisolone plus or minus methotrexate or mycophenolate. Stage 4 is often burnt out. It means that the disease is inactive, but it's caused scarring. But that scarring can cause complications. Probably we should consider antifibrotics at this stage, such as nintedanib. I usually do pulmonary function tests, sort of intermittent radiology and blood tests for calcium and for angiotensin converting enzyme and full blood count for lymphopenia. The calcium can be elevated in people with sarcoidosis because vitamin D is made in the granulomas. But you do need to be aware that you may be looking at something that isn't sarcoidosis. Could it actually be tuberculosis? And so you need to keep that in mind when you're looking after the patients, particularly if you're immunosuppressing them and therefore their immune system may not be able to fight off something like TB. Could it be occupational? You do need to take an occupational history, looking for things like silica exposure or other sort of mineral dusts. And a disease called extrinsic allergic alveolitis or hypersensitivity pneumonitis can actually look very like sarcoidosis and have granulomas. And that's associated with occupational exposures to vegetable and microbial dusts, and also to pets. So if they keep a parrot and they look like they've got sarcoidosis, you might not be dealing with sarcoidosis at all. What's next? We hope that we'll get some better timing of interventions and when to intervene, and it would be nice if we could do PET scans and perhaps get a conglomerate measure, and maybe people like Branko will be able to get those PET scans analysed so that you could have an overall marker of the total disease burden in the body. We need a better understanding of the pathogenesis, and we need better understanding at sort of basic level of the ways, of the pathways that can be targeted, and Alicia will probably touch on that. I've sort of mentioned the other things here already. It would be nice to be able to predict or anticipate who is going to get fibrosis in their lungs a little earlier. Some of the pro-fibrotic agents, such as TGF-beta and neopterin, would be candidates, and we did actually do a little study on exhaled breath, and we were able to see in sarcoidosis there was a tendency, although there's an outlier here which skews the statistics, that they had more TGF-beta in their exhaled breath, suggesting that perhaps we could measure things in the future that indicated which patients would need antifibrotics, and who needs immunosuppression. And there are plenty of targets now identified in the cascade with all these unpronounceable monoclonal antibodies. And there have been some newer studies recently, the one with efzofitimod and namilumab, which were intended to show you could taper off long-term prednisolone. This one was a little bit more successful than this one in that there were some indicators that perhaps there was an effect. The namilumab was less convincing. So the future, hopefully there are some promising new therapies coming along. We now know that lower doses of prednisone can be used, and perhaps earlier use of methotrexate. And we are involved, I mentioned earlier, in a couple of studies. Again, it's negotiation stage, not actually recruiting yet. And a couple of weeks ago, Dr. Zhu approached me and asked if we could start looking at extracellular vesicles in the context of sarcoidosis. So things are happening. And it's good that, in a way, it's good that overall there is more interest in sarcoidosis, and a lot of the drug companies, including sort of smaller startup biotech companies, are actually looking at sarcoidosis as a disease that is worthy of attention. For probably 30 years, most of the respiratory research has been addressing asthma and chronic obstructive pulmonary disease, and that's where the most of the money has been put, whereas some of the smaller disease, now sometimes called orphan diseases, have been ignored, and I think it's good that some of the companies are now looking at sarcoidosis as an area that should be addressed. The treatment should be addressed. Just need to make more acknowledgements that are on that list, but mostly the respiratory medicine, lung function staff have been very accommodating of my demands on their time. Originally it was Dennis Wakefield and Sean and Peter and Gimberto were involved in helping set up a loose connection of interest in sarcoidosis. Elaine Kelly has been very kind in helping us with the sarcoidosis support group. And these are some of my collaborators and students over the years. And lastly, you all know that because you're here. The Foundation for Sarcoidosis Research is the US-based organization. It is Sarcoidosis Week in their view this week. And they actually have quite a good website in terms of patient support, but also information for clinicians. And if you're an interested clinician, you can actually attend their online sessions, which a number of them have been very good. WASOG is mainly for clinicians, as I mentioned, and they're meeting in Istanbul. And that's it. The nasal mucosa can be. Very occasionally we ask, and the lips can as well, and sometimes we used to ask some of the dental surgeons to do lip biopsies as well. The lips didn't show up on the pounder there, but they can be involved. Nasal biopsies, very occasionally we ask the ENTs to do a nasal biopsy too. Again, if you see some nodules, then macroscopically, then you can you'd be more likely to pick up an abnormality. But even at bronchoscopies, when I used to do bronchoscopies and in a person who might have sarcoidosis, I'd take biopsies even if the mucosa looked normal, because you can't tell just by looking what's going to turn up under the microscope, and quite frequently you'd get granulomas that way. And it just makes you happier that you're treating the right thing. And the problem is that if you see somebody who's been treated for a long time and yet never had a biopsy, it always raises that concern that perhaps it isn't sarcoidosis and it's something else. Yeah. The lady at the back was standing. None today, I'm afraid. Branko has got me busy. Well, I think you need to talk to I presume you have a general practitioner, so I think you need to discuss with them and find somebody who has an interest in.
Just watching those last few slides, it just makes me think.
We do get this question asked quite often, and we are trying to build up a register of doctors that have both expertise and influence in managing sarcoidosis. So far, we've got about 25 people that have registered, and we've got to go back to the cardiologists and the pulmonologists to try and build that number up. So the numbers are not fantastic, but I did have questions that need to take all the time, and all I can do is I can refer them to people that I know. So it's very limited. So a register of doctors would be very useful. We are working on it. So far, the numbers are small.
Gentleman, yeah.
Yes, so you mentioned about biopsies. I've got isolated cardiac sarcoidosis. So I have it in the heart, but not in the lungs. And obviously heart biopsies are not exactly the easiest things to do. Do you recommend for people who lung biopsies not appropriate?
Do I recommend? I'll slightly defer that question to Chris, but that's the value of doing things like PET scans is that it sometimes identifies other easier places to biopsy. So you can find that a lymph node might light up that's actually quite easily accessible. So that's the benefit of using those sorts of imaging.
Yeah, I've had a PET scan that's come up positive and gathered an enhancement on cardiac MRI, which is also quite diagnostic of cardiac sarcoidosis. But they've never found anywhere where they've been willing to biopsy.
Yeah, I think I'll probably leave that one to Chris because people who used to do endomyocardial biopsies, but the problem with that is that sarcoidosis in the heart is quite patchy, and so it's quite hard to, if you don't get a positive result with a granuloma, you can't be certain that you've excluded it. That's the problem now.
I'll touch on that.
Okay.
Can I ask a question? 50% of sarcoidosis patients have calcium dysbiosis, and it can be quite severe in some cases. Can you make any relationship between that and PTH and calcium metabolism, vitamin D? Because all of those seem to be interconnected with sarcoidosis. Any idea?
Well, vitamin D and its metabolites are synthesized in granulomas. And so probably the more active your granulomas, in some people, and I wouldn't say it's only about probably 10%, that you actually discover that they have an elevated calcium. Yeah. And so that's the value of actually keeping an eye on the serum calcium, but as I sort of put on one of the slides earlier, that looking for an excess of calcium in the 24-hour urine can be useful. But people do seem to find it difficult to collect their urine for 24 hours, which is a nuisance, because you get these samples that are either too small to be possible for a human to have excreted in 24 hours, and then other people say they've lost the bottle and so on. So it's not like a blood test where you know you've got it.
Thank you very much for...
Oh, one more question? Okay.
Yeah, I have one more question. Yeah, you mentioned that people often present with fatigue, arthritis, dry cough. I was wondering why, if you can explain why often people get that fatigue, arthritis, those aches and pains. Why is that? Why is it often that arthritis would be one of the things that they would present with? Not talked about when you talk about all the different various forms of sarcoidosis.
Yeah.
Where that is in.
Yes, I'd love to refer that to a rheumatological colleague. I don't know whether Elisa will touch on that. Okay. I assume that the arthritis is related to granulomas in the synovial joints, but I'm not sure whether that's true because I can't remember seeing them lighting up particularly on PET scans. But if it's generalized like that and you've got inflammation, the fatigue is associated with that. And it's, in a way, if you think when you have influenza, you feel very tired and unwell, and it's because you've got that sort of overall total body sort of inflammation going on. And for whatever reason, that produces a sensation of fatigue. And it's an important point because patients often have these symptoms for a long time, but they're so non-specific that nobody thinks necessarily of doing like a chest X-ray or looking, and certainly not for looking for sarcoidosis. Thanks.
So thank you to the organisers, particularly Branko, for inviting me to speak today, and thank you to everybody for coming. I understand there's a mix of patients, carers, specialists, GPs, quite a broad audience, and perhaps some scientists here. So I've been given a really difficult talk to try and explain the immune system in 15 minutes, so I'm going to try my best. My background is that I'm predominantly a clinician, but I do immunology research, and my favourite immune cells are the lymphocytes, but I will try and cover all the immune cells that are impacted in sarcoid, and I work at St Vincent's and at Liverpool hospitals as well, and my practice does include patients with multi-system sarcoidosis. So my task today is really the what and the why of sarcoid. And why is this important? To know what sarcoidosis is and what causes it. And also, I think a lot of you will be wondering, why me? Why did I get sarcoid? And why we need to know. And this is really because, I'm just going to move this screen around because I'm wearing multifocals and I can't see out of the side of my glasses. Why this is important is that with this knowledge of understanding what causes sarcoidosis, you can understand how to better diagnose, to better treat, and also to monitor the disease. Now, Paul mentioned about the different types of monitoring, and this can be quite variable from clinician to clinician, also with patients as well. And with that body of evidence, what we can then do is to drive things like the standard of care, so we can have an agreed upon standard. So I know somebody mentioned they didn't feel that their sarcoidosis was being treated correctly. Well, you need evidence first to be able to say, this is how sarcoidosis should be treated, this is what the expert opinion is, and this is what the evidence shows. And with that, and with your help as patients, we can use all of our expertise and experiences to then drive policy, right? And with driving policy means that you have better access to medications because there'll be funding and there'll be funded tests as well. And so that's sort of the reason why you need organisations like SARI that bring together all those pieces and people to be able to improve how we treat and diagnose and everything surrounding sarcoid, so people with sarcoid can lead better and healthier lives. So essentially, in a nutshell, what is sarcoidosis? It is a multi-system disorder. So I think a lot of people do have the lung-based diseases, but as an immunologist, I tend to see people who have sarcoid plus, so not just the lung disease, but pretty much any organ can be affected by sarcoidosis. So, apologies. So this can include your nervous system, including your brain, your spinal cord. And don't panic, because everybody's sarcoidosis is different. So if this is not your sarcoidosis, you're probably not going to get this type of sarcoidosis. But this is just to explain and to cover everybody's sarcoid. It can affect your nervous system. It might affect your heart. You might have the type where it's just the lymph nodes in the lungs or fibrosis in the lungs. Some people can get liver sarcoid or other immune organs, so lymph nodes and spleen, and skin sarcoidosis. And I know my specialty colleagues will be covering some of that. So the purpose of my talk is really to outline, how the immune system sort of malfunctions in sarcoid to cause sarcoid, and I'm going to try and weave that into the narrative of how understanding how the immune system works in sarcoid can then open up opportunities for new therapies, or have already opened up opportunities for new therapies, and these might be the medications that you're already on. And the reason we need to know this is because, as I said, sarcoidosis is very variable. If you talk amongst each other, you'll find that your sarcoid is not quite like somebody else's sarcoid. And we know that in terms of health impacts, and this is a graph of, how likely you're going to be impacted by sarcoid in terms of longevity, is that this is the plot of the general population in green. Some people's sarcoids, pretty much not much change, and some people's sarcoids are worse, right? So we need to find out who is at risk of being on this pathway, and how do we make sure that these people become more like these people. So this is the tricky bit about trying to explain the immune system in a very short period of time. But essentially your immune system is like your sixth sense, okay? When it's working well, you don't actually notice that it's working. Your body is being bombarded by bugs all the time, and it's fighting these off without you realising. That's sort of the basis of vaccinations, right? So you get your vaccine, and then when you come into contact with these organisms, you don't get sick because your immune system is working in the background. But in some people, this immune system becomes really dysregulated. So this is an image, or my image, of what a normal immune system might look like. You have cells, they're orderly, they're doing their thing. What can happen in people whose immune systems are impacted is that it might become weak and too ineffective. You may not have enough numbers, or the function might be abnormal, so they're sort of pale and sickly looking. But what happens in conditions like sarcoidosis is that your immune system essentially goes wacky and rogue. So essentially for your immune system to be able to work, it needs to first be able to tell if your immune cells are different to bugs, okay? So when that process becomes mucked up, we call that autoimmunity, which means your immune system is now attacking things that aren't really harmful, okay? There are lots of autoimmune conditions. The other thing that is really important in terms of immune functions to be effective is that it's got to be able to turn on and off appropriately. So it's all very well if you have a bug and it turns on, but once the immune system has controlled that infection, it's got to be able to turn off. And when that doesn't happen, we call that autoinflammation. And so what sarcoid essentially is, we think, is a condition where potentially this inflammatory process is not being switched off, and that's why you're getting these funny immune structures called granulomas. So the immune system is really complex. There's a lot of cells in the immune system. They have different personalities, different functions, and I'm not going to be able to tell you about, all of these cells and what they do. So I'm going to focus on two types of cells that we know are important in how sarcoidosis develops. So these are called macrophages. So we can think of the immune system in two sort of camps. So the innate cells are your first line of defense, and so macrophages are in your first line of defense. And then there's this adaptive immune system. Now, as I said, these are my favorite cells because these are really clever. So once they encounter a bug or what we call an antigen, they then develop special functions, so they can become different types of cells to meet the needs of whatever that organism is. So I'll try and explain that. Maybe I'm not making sense, but I'll try and explain that. But essentially, these two cells are responsible for creating these things called granulomas, which we believe are the problem in sarcoidosis. So granulomas are made up of these lymphocytes on the outside, and then on the inside, and probably also lymphocytes on the inside as well, you get these macrophages that are problematic and causing issues. So I'll come to how they cause issues in a second. Okay, so the question of why did I get sarcoidosis is probably one I get asked a lot in clinic. And to be honest, at the moment, we don't know. We don't have all the pieces of the puzzle, but sarcoidosis has been around for a long time, I think, like 100 years or something. So we do have information that we're piecing together, but obviously the puzzle isn't solved, and that's why we're all here today. So what we do know is that there's probably some sort of environmental trigger in a genetically susceptible person, and then this sets off a cascade of abnormal immune reactions, and that's why people get sarcoidosis. But it's really in the weeds of how this has happened in people where we will find the answers to treatment. And so it's in really the immune system, and maybe I'm biased because I am an immunologist, but the immune system cells and the proteins that they produce, called cytokines, they are already and will be the targets of current and future therapies. Okay, and so this is why the research is important. Some things are not modifiable, like the genetic hand that you've been dealt, and that's why Paul, described the genes, but we don't really test for them because once we've diagnosed you with sarcoidosis, knowing that you've had a risk for sarcoidosis isn't really helpful, because even if you've passed that gene on to, your children, they're not necessarily going to get sarcoidosis because they may not have the same environmental exposure. So some of the evidence that does point to the genetics and environment, as has already been mentioned, is understanding the differences in sarcoid patterns according to, where people are from. So these are studies of sarcoid incidence, so the number of people who get sarcoid. So if you have 100,000 people in these places, how many of those would get sarcoid in any given year? That's what this graph is showing. And so in Sweden, the maximum incidence is 20 in 100,000. Whereas in Korea, it's almost 1/10 of that, so 3 in 100,000. And in America, it's somewhere in the middle. So this suggests that there are differences, whether it's genetic or environmental. And in terms of the genetics of sarcoid, it's not what we call Mendelian, so it's not something you directly inherit. You can't just inherit a single gene from your parent or parents and get sarcoidosis. But what we do know is that it's polygenic, which means that multiple genes are involved in you being more likely to get sarcoidosis. And researchers have been studying genes for a very long time. The Human Genome Project that mapped out our whole gene was in 2004. So there's improved understanding in that period about exactly which genes are likely to increase your risk of sarcoidosis. But the way genes work is that essentially it's a code of letters, it's like spelling, and sometimes there's a spelling error that, makes the word not make sense. But sometimes that spelling error is just a bit like, is it American spelling or British spelling? It doesn't actually matter. It still means the same thing. And so that's what we're trying to sort out at the moment. But what we do know is that through these studies, these genes that are associated with sarcoidosis code for proteins that are important in the immune system. And so whether it's the T cells, my favourite cells, or the macrophages, or if it's to do at the respiratory level with the fibroblasts, which are the cells that muck up and cause fibrosis. And so these studies are still ongoing. This was a recent paper in Nature Communications. Nature's one of our biggest scientific journals. If you've got a paper in Nature, you've made it. So basically, this is a very good study. And they looked at 9,755 people with sarcoidosis, and they looked at the genes of those people and people who have no disease and made a comparison. And so it was hypothesis-free. They were just looking at which genes had changes or spelling issues in sarcoidosis versus healthy people. And they identified a whole number of genes. It's not necessary to know which genes they were, but the key findings were that they kind of came up in either immune genes to do with how immune cells are activated or turn on and off, in the way immune cells might be moving around, which is really important if you're thinking about sarcoidosis being these funny clumps of cells. Obviously, there's something abnormal about how those cells have come to be there. And also in what's called antigen presentation, which is a scientific term that means when an immune cell encounters a bug or some sort of trigger, how is that handled? So we know that there's lots of genes involved, and it sort of provides, I guess, a clue to where the scientists should be looking next to kind of, as I said, get into the weeds of how this sarcoidosis happens. So the immune abnormalities in sarcoid is complex and it's incompletely understood, but we basically sort of, in a nutshell, we know that something happens where your immune cells meet a trigger, and probably your immune cells are a little bit twitchy to begin with, so they don't settle down when they meet this abnormal trigger. They then go and talk to these cells called lymphocytes. And we know that these lymphocytes, as I said, these are the cells that can differentiate or get different sort of functional characteristics. So they can become different things. And so these cells become, we know the detail of what types of cells these become. So they become Th1 and Th17 cells, which I'll go into in a little bit more detail. And we also know that these granulomas form, and there's these immune communication molecules called cytokines. We know that they're abnormal, and we know some of them that are increased in sarcoidosis. So to answer the question of where do the sarcoid symptoms come from, they can either be due to infiltration of your vital organs, so your nerves, your brain, even your joints. So there are immune cells going into your joints. They may not necessarily be forming granulomas, but they are still there. They can cause a mass effect. So, for example, particularly in somewhere like the brain, if you have a big lump of sarcoid in your brain, then that can put pressure on nerves and things. And then the fatigue, the fevers, the weight loss is due to these pesky little things called cytokines. And some of them do cross over with the cytokines that are elevated in infection. So you can feel like you do have the flu. And so sarcoid treatment then targets these immune cells and the cytokines. So the reason that understanding this whole complex pathway is helpful is that understanding this then unlocks the key to where you can target your therapies to stop the things, the cells and the cytokines that are causing your symptoms. So now I'm going to go into a little bit more detail. I hope you're still with me because the immune system is complex. So the first type of cell I'm going to focus on are your lymphocytes. So remember, these are the adaptive immune cells. What happens is before they've met a bug or a trigger, we call them naive cells because they're floating around, they don't know what they're doing. Once they've met a trigger or an organism, these cells know what to do and they develop different capabilities. How they develop these different capabilities depends on the cytokine milieu of that interaction with the organism that's triggering these cells to become active. So these cytokines can drive cells to become helper cells with different type of helper capabilities. The main helper cell that is important in your immune system is the Th1 cell, and this is the type of immune cell that's really important for fighting bacteria, and these cells are increased in sarcoid. But I think the important thing to point out is we can't nuke these guys because then you won't be able to fight infections. So we don't actually have targets for Th1s because the downside is that you're going to become very immune suppressed. The other key cell is the Th17 cell. These are increased in sarcoidosis as well. And these are slightly less vital to the general functioning of the immune system. It does increase your impact of having what's called mucocutaneous candidiasis or thrush. But in general, you can target these cells with less impact than targeting these ones. And then there's this type of cell called the T regulatory cell. These are sort of the prefects of the immune system. They control your immune system so your immune system isn't too wacky. But in sarcoid, they don't function properly. Interesting, their numbers are increased, but their functionality is impaired. So keeping this in mind, a lot of the therapies for sarcoid are cell-based. The top list of drugs are sort of your classic therapies that target your cells, but they target cells in a very non-specific way. And through research and science, we're now able to target the immune system in a more direct way, I suppose, which are the monoclonal therapies, the small molecule inhibitors or targeted therapies that Paul had alluded to. So steroids works for everybody, but the reason we don't use steroids all the time and at high doses is because of the side effects. So steroid side effects essentially affect everybody. And so we don't use that. We need to find medications that help us to reduce the steroids. So the classic ones are methotrexate, but also mycophenolate, sirolimus. The way we pick between these, as Paul alluded to, is sometimes just to do with how much and how fast you need your disease controlled. If your disease isn't too bad, you might just be on methotrexate these days because of this study, and it'll take you 6 months to get under control. But if your sarcoid isn't causing you any problems, then that's not really a big deal. Whereas if your sarcoid is causing lots of symptoms, then we would use steroids up front. Interestingly, now remember I talked about Th17s being abnormal, and they're probably a reasonable target in sarcoidosis because you can take them out and your immune system isn't too impacted. It can still fight against infections. But actually that didn't work. So having, the science is helpful in trying the drugs, but it doesn't necessarily mean it works. But sometimes you also, with these drugs, get paradoxical sarcoid, and so we don't know why that is. The next type of cell that I'm going to cover are these macrophages. So these are the cells in the middle of your granulomas. And we know that in sarcoidosis, the M1 or inflammatory macrophages are the ones that are increased and abnormal. And these are the ones that are then driving the differentiation of your T cells into these abnormal Th1 and Th17 cells by producing these things called cytokines. They produce a lot of cytokines, but the ones of interest, I suppose, are the TNF-alpha because we can target those. But there's also like interleukin-1, interleukin-6, for which there's a target. And in the future, there may be other drugs that target these cytokines. So in terms of what we know about the current therapies that are available or becoming available, the most common sarcoid medication we reach for these days, if you're not responding to steroids or methotrexate or any of the earlier anti-cell therapies, is the anti-tumour necrosis factor alpha therapies. So there's infliximab or adalimumab. Infliximab is an infusion, adalimumab is an injection. They probably work equally as well. There's no studies comparing them, but in my experience and everybody's experience, we tend to use both interchangeably depending on the preference of the patient. Cytokines, as I said, are the molecules that immune systems use to communicate, and they do this communication by binding to cytokine receptors. That then triggers a cascade of different sort of crosstalk within the cell, and one of these pathways is called the JAK-STAT pathway. And there are now small molecule inhibitors that can block cytokine signalling by targeting the JAK-STAT pathway. And that's exciting because that's a new way to treat sarcoid. I think one of the difficulties of sarcoidosis is that when a patient doesn't respond, we don't have good tests at the moment to be able to say which drug is going to be good for your drug. I talk about these cytokines, but we don't really have easy access to be able to test them. And these cytokines are probably in your granulomas rather than just floating around in the blood. So we don't have that capability to do precision or personalised medicine to say, this is your cytokine signature, we're going to target that cytokine. And so it's useful to have a handful of drugs that, unfortunately, we do just have to trial and error cycle through them. But this is sort of a complex diagram, but to kind of bring it down to a digestible level, this is just a summary of all the different studies of reasonable quality in sarcoidosis. And they're looking at either lung sarcoid, skin sarcoid, or various other sort of smaller subgroups of sarcoid or responses. And there's been quite a lot on the anti-TNFs. There's a couple of studies that have come out on the JAK inhibitors. So remember, these are the ones that block cytokine signalling. And then there's a few other ones that are targeting other cells or other cytokines. And the way to understand this is green means that that study showed that that drug was effective. Yellow means that it's uncertain, so that's not that it doesn't work, that the evidence wasn't clear from that particular study. So there may still be potential in a particular patient that that particular drug might work. And red means that there was no benefit. And as you can see, if you look at just the range of colours, with TNF inhibition, with infliximab or adalimumab, you're in that green to yellow range, so that's a pretty good drug. And same with the JAK inhibitors. Whereas if you go into this middle bit here, we have tried a lot of other cytokines, but they're not necessarily effective, although there's a few yellows and greens in certain circumstances where we might still consider treatment. And so there's no one set pathway for sarcoid treatment because, the evidence isn't really tight to guide that type of decision. And Paul's already shown you this. This is called a forest plot, but essentially 0 means no effect. And on this slide is where there's an effect. And this, again, is similar looking at the different types of anti-TNFs. There's definitely an effect in terms of improving your lung function. The last little area that I'm going to touch on is what causes fibrosis, which is important for the lungs. So sarcoid in the lungs, if you just have lymph nodes and inflammation, that might not be causing long-term damage, but what we really don't want is scarring on the lungs, which is fibrosis. And that fibrosis is driven, again, by cytokines, so different cytokines to the ones that cause sarcoidosis to begin with, but like interleukin 10, TGF-beta, interleukin 13, interferon gamma, and also TNF-alpha have been implicated in this process. The pathway to fibrosis is really complicated. It's not just about the immune cells, so I'm not going to go into that. But Paul did mention these anti-fibrotic therapies. These are the sarcoid drugs that are currently in trial at the moment, or at least they were when this paper was published last year. So we don't actually have the answers to whether or not these drugs are effective in sarcoid. But we do know that nintedanib, so these are small molecule inhibitors that basically block these receptors that trigger growth and function of fibroblasts. We know that there were some patients included in the trial that looked at the use of nintedanib in fibrosis due to a variety of causes. So there is a chance that it does work in sarcoidosis, but basically we don't have the answer to that yet. So that's sort of the end of my talk, and essentially I hope I've convinced you the value of research and understanding something like the immune system in terms of how that's going to impact how we treat and diagnose sarcoidosis. So I'm happy to take any questions. I'm sorry I've gone a little bit over time. Yes?
Sorry, just a question about you showed slides showing, thank you, age groups by country, by gender for age of diagnosis, I think it was.
Yes.
And there was quite a difference between men and women, that it tended to be younger in men and then around menopause for women. Do we think that's, is that due to different factors, like are younger men getting it from construction work or farm work or something, and women are getting it from sort of lifetime exposure to, household fungus or just menopause makes the immune system go cuckoo or something like that?
Yeah, so I think they're all really good questions, and somebody like you should be in science, because they're sort of the questions that we need to answer, because if you can identify the trigger, then you can modify those. So I don't think we've got strong answers. I know there is association with various, studies have shown association with things like construction, weight, and differences in age, but unfortunately we don't have the answers there. And as an immunologist, I'm not across all of that data, but definitely we think that there will be an answer in there somewhere. Yes.
The lady that just asked the question now reminded me of perhaps whether there is any possible link between menopause and sarcoidosis in women. Are you aware of any studies that have taken
I'm not
place
aware
on
of
that?
any studies. Unfortunately, we don't have an endocrinologist in the room, but I think that's a really valid question.
Do you think COVID can be one of the triggers that's triggering sarcoidosis in people?
I haven't seen the evidence for that. I think, there's a lot of things that have been attributed to COVID without evidence, because COVID did happen, it was really big, and, autoimmune diseases happen as well. Sometimes infections in general, not just COVID, can make your autoimmune diseases worse, but as far as I'm aware, there's no association with COVID or COVID vaccines. Okay.
How much evidence is that early life stress and trauma can influence how the immune system became sarcoidosis later in life?
Yeah, look, I don't know any specific data on sarcoidosis, but there's definitely studies that show that there are interactions with your nervous system and the immune cells, and so definitely that is an area that should be looked into and could be a possible cause. Yep, lady in the purple down the back.
Just in response to the use of steroids, should it become sort of part of our self-management that if like I was just had a chest infection and I haven't recovered before, I'm not infectious anymore, but my sarcoidosis has recovered. Should I be increasing my steroid use at the time of the inflammation from the viral infection?
I can't give you specific advice on sarcoidosis for your condition because it really depends. Sometimes the steroids, when we are on steroids for a long time, your body's natural source of steroids becomes diminished. When you get an infection, you do need a steroid boost. And so if that's you, sometimes we do say bump up your steroids, or if your sarcoid is flaring, we say bump up your steroids. But that's something that needs to be done in conjunction with your own physician because he'll know your condition best. But we do sometimes increase the dose of steroids, but there's a lot of factors that help us to make that decision. Sorry.
We're going to have morning tea now and then have as a first speaker after morning tea. I think we'll all have a good run. We're a bit tired. A cup of coffee will be good for everybody. So please go downstairs. There's some biscuits and coffee for you there. And we'll try and get back to your 11 o'clock. Okay? Thank you very much. Thank you. That's really interesting.
All right, welcome back. As I mentioned before, I'm Chris Hayward. I'm a cardiologist at St Vincent's Hospital in Sydney. My particular area is in heart failure, and as we'll talk about, there are sort of different aspects of cardiac sarcoidosis that are relevant. And when we talk about cardiac sarcoidosis, really there are broad ranges of symptoms that patients might have. They may have rhythm disturbances on their ECG, and it's one of the strong teaching points we've got for our cardiology trainees. If you have a young patient with rhythm disturbances, you really do have to think about cardiac sarcoidosis. So anyone who needs a pacemaker, if they're under the age of 50 and needing a pacemaker, sarcoid is right up there as something that we've really got to exclude. And so sometimes we see patients who have got a pacemaker and been followed for a while and not being recognised that actually this is part of their sarcoid syndrome. Ventricular tachycardia is a nasty rhythm. It's the racing heart of the bottom chamber of the heart, and that can be quite dangerous and is a risk for sudden cardiac death. That's what the SCD stands for. And that's important because with sarcoidosis, cardiac sarcoidosis, one of the most important treatments is not medications, it's actually electricity. It's a defibrillator, and so that's the main prognostically important intervention for ventricular tachycardia associated with sarcoidosis. The reason that I've been involved with sarcoidosis is through the heart failure, and we, in our transplant program, we see patients who have had sarcoidosis for some years. It's burnt out. They may have scarring of the heart and have impaired heart function where it's not pumping strongly, and then they may end up needing a transplant. And so that's another sort of manifestation of cardiac sarcoidosis. And as I mentioned, blackouts, that syncope, or ventricular arrhythmias or rhythm problems is a manifestation of cardiac sarcoidosis. So this is just an ECG that cardiologists all get excited about. But the important thing here, just to explain, each of these red lines goes with the top chamber of the heart. And you can see there's a complete disconnect with what's happening in the bottom chamber of the heart, which is the ventricular activity. And we call that heart block, and that person would need a pacemaker. If they're a young person, then that's when we start to say, okay, this young patient has heart block, we should be thinking about cardiac sarcoidosis. One of our tests, the commonest tests that cardiologists will do, is an echocardiography. And this is the pumping chamber of the heart, the left side and the right side of the heart, left atrium, right atrium. And sarcoid often seems to affect the right side of the heart slightly more. And so in this setting, the right side of the heart is actually a bit bigger than it should be. Our next test of choice is typically a cardiac MRI scan. And the cardiac MRI scan is particularly helpful because while we can see the heart moving very well on the echo, it doesn't have, we can't see what's happening in the actual muscle, in the walls of the heart, in the tissue of the heart, which you can with cardiac MRI. And you can see scarring, which is this white change on the MRI. And that's sort of fibrosis within the heart related to cardiac sarcoidosis. And as part of workup of cardiac sarcoidosis, we always look somewhere else. Is there a sarcoid anywhere else? And in this example, there's a granuloma on the chest. It was discussed previously, should we be doing heart biopsies for cardiac sarcoidosis? The tricky thing is, and I'll come to it in a couple of slides, you've actually got to hit, one of these spots here or here, and because it's very patchy, you can easily miss sarcoidosis on biopsy, and it's not routine, and it's less than 50% likely to make a diagnosis. So we do look elsewhere for sarcoid. And as Paul was saying, PET scans are really sort of the new kid on the block in terms of imaging for the heart. And this is an older PET scan. We've got a CT scan, a SPECT, what's called a SPECT scan, and then an uptake scan. And you can see here there's just a little bit of uptake here on the lateral wall, and that's associated in the right setting with cardiac sarcoid. And it's more clear in the more recent scans. You can see uptake in the lateral wall, and importantly in this case, involvement of lymph nodes, and so again extracardiac sarcoid. This slide is probably, if I was giving a talk to my students or trainees, I'd say this is the only slide that they need to remember. It's got everything on it. We don't know what causes sarcoid, and Elisa and Paul have already pointed that out. These are our main imaging modalities, the PET scan or MRI scan. We'll talk a little bit about the immunosuppression and treatment for cardiac sarcoid. The rhythm issues are what I was describing and showing on that ECG, and this patchy fibrosis that you can see in the white. This is a cardiac specimen, a histology specimen, and you can see patchy changes there, that the fibrosis associated with sarcoid. If you do a heart biopsy, and that's what's called a bioptome, a little forceps, we go down through the neck into the heart and take a piece of tissue. If you do a biopsy and you are lucky enough to hit a sarcoid granuloma, you have the same finding as in other tissues. A summary: we don't know whether it's genes, infection, or environmental, or a combination of all of them, and then the body's immune response, as Elisa was saying. It's a very complex condition, multi-system, multiple inputs contributing to the final syndrome. And as has already been pointed out, it is different in different populations. The Japanese population is also another population that has a very high prevalence, and when you look at the literature, there are two sort of large areas of literature: the Scandinavian literature, which have very granular and good detail in their clinical syndromes and clinical follow-up and medical management, which is very, very helpful. And the Japanese literature has larger centres and better collaboration. But you can see here, these are in patients with the cardiac sarcoidosis, that you can have quite high rates on autopsy just even in the US population. And again, as mentioned previously, that's often the Afro-American, the black population in America are the ones who tend to have the higher burden of cardiac sarcoidosis. In terms of how we manage or our algorithm for managing cardiac sarcoid, always start with suspicion, so the clinical diagnosis. So it's one of those things you've got to think of. If you don't think of it, then you won't make the diagnosis. But if there is sarcoid somewhere else, it's someone else has done the hard work and shown that there's sarcoid in the lungs or sarcoid in another organ, then obviously we're going to be looking harder in the heart. Any of these clinical rhythm issues or heart failure issues is another sort of trigger for us to look hard for cardiac sarcoid. Our imaging that we've talked about, the cardiac MRI and the PET scans are really the mainstay. And then the histological confirmation is not really routinely undertaken nowadays. In particular situations we may, but largely it's a clinical diagnosis. And then how we manage the patient really depends on what the manifestations are. If it's heart failure, then we're going to treat that with all of our usual heart failure medications. If there's any rhythm issues, we'll look at defibrillators or pacemakers, and I'll come back to that in the future. And if we've got active inflammation on our PET scan, then we'll be looking at our immunomodulatory treatments, steroids and so forth. And then follow up, and we can follow up typically with the PET scan is the best way of following up for inflammation if we're chasing that down. And this is really a summary to say that we know there's differences between men and women. In cardiac sarcoid, there's differences between black and white in cardiac sarcoid. And so this sort of heterogeneous manifestation or expression of sarcoid runs in each of these sort of different organ systems that we've come across so far, but particularly in cardiac sarcoid. And so you can see that the black patients have worse outcomes, more likely to have more heart failure than white patients, particularly in America. Women tend to have a better cardiac prognosis compared to men, so that's ventricular arrhythmias, fewer ventricular arrhythmias, more likely to have improvement in their heart function or this left ventricular ejection fraction recovery. And so differences in terms of outcomes for men and women and for black and white patients. Interestingly, from the cardiac, when we look at our heart failure patients, we have sort of two broad ranges of how we think about heart failure in the transplant population particularly. It's when the heart is either not pumping strongly or when it's not relaxing properly. And so these restrictive cardiomyopathies is when the heart's not relaxing properly, and often that's because of scarring that happens on the heart. And sarcoid has a reasonable sort of prognosis compared to other restrictive cardiomyopathies. That's really to say that these other restrictive cardiomyopathies can be much more significant and worrying. But sarcoid is up there. It is one of the ones that we think of as a restrictive cardiomyopathy. So, as I mentioned, the first thing you've got to make is the diagnosis of sarcoid. This is the American Heart Association sort of statement or guidelines, and so there's a recent working group that's presented put this all together for cardiac sarcoidosis. And the diagnosis is not 100%. We have a definite diagnosis if you have a heart biopsy, but then you have a likely diagnosis or a probable diagnosis based on if you don't have a biopsy, but you've got other features that go along. So that young patient with a conduction defect would be a likely diagnosis. And we work through and look at the different sort of imaging modalities on top of the clinical syndrome and make the likelihood for cardiac sarcoidosis diagnosis. And this has been tested in, this I think was a Norwegian group, tested that algorithm in their population and they were able to break their patients up into either definite, highly likely, or probable cardiac sarcoidosis. This is a really nice study because it was over 30 years and from Scandinavia, so from Finland. And you can see in this study increasing diagnosis over the last 30 years and also looking at outcomes or mortality across that time. Obviously, the most recent cohort of patients have a shorter follow-up, but seem to have a better prognosis. This is very helpful data, but I think we'll think about it more closely. When you look at their next table, which really showed that they were doing a lot more PET scans, so they were picking up a lot more cases of cardiac sarcoidosis. The cardiac sarcoidosis may have been there 30 years ago, but without doing the test, we weren't making the diagnosis. So a lot more FDG PETs, a lot more MRI scans compared to 30 years ago. Interestingly, in association with making the diagnosis, the severity of cardiac sarcoidosis was actually less, and so they had less fibrosis and better ejection fraction, or better pumping of the heart. And so it seems like we're making a diagnosis earlier, before the disease is more advanced, and that may be why the survival is better. They looked also very helpfully at their treatment over the last 30 years. What are doctors doing in response to cardiac sarcoidosis? And azathioprine and cyclosporin have really sort of fallen off, and steroids remain the mainstay. 97% of patients are treated with steroids in their cohort with cardiac sarcoidosis. So when you summarise all of their data, you can see that over their 3 time periods, there's less nasty arrhythmias, less very severe heart failure, less struggling heart failure, and a lower incidence of mortality, despite in association with more frequent diagnoses. So very helpful epidemiology study, but really we've got to think about, is it actually the disease changed, or is it just our response to how we look at patients and how we manage diseases? And it's likely that there is this thing called lead time bias. Basically, we're getting better at diagnosing earlier, and the cases are being picked up earlier in their natural history, rather than when our treatment has made any significant difference. So we've got good epidemiology for improved diagnosis, and we're probably getting the sarcoidosis earlier. Whether our treatment's making any difference, we can't really say from that study. As I mentioned, the Japanese cohorts, they do very nice registry studies. It's a very organised sort of medical system and collaboration within Japan. And so they also, with their sarcoidosis registry, they follow, they have a sort of fairly regimented investigations and tests, and they've also been able to follow up over 15 years. They're a good cohort of 500 patients with cardiac sarcoidosis. And what this doesn't tell us what the best treatment is, but it does tell us a little bit about outcomes and what we might expect: a 25% risk of hospitalisation at 15 years, and about a 30% risk of that's fatal ventricular arrhythmias, and that's the reason that we use these cardiac defibrillators. And you can see here there is a significant risk of mortality associated. It doesn't say it's all from cardiac sarcoid. These are all-cause mortalities, and so, but it gives us a good sort of feeling of what's happening with our sarcoid patients. So what are our therapies? Well, the first thing, as I mentioned, is really you've got to confirm the diagnosis. You've got to be sure that you're going to, when you initiate therapy, you're going to do something that is going to help the patient. Steroids are still our first line, and then we do move on to the steroid-sparing agents. Typically, mycophenolate would be my next line agent. Always think about the cardiac rhythm and the heart function together. And so we optimise the heart medications, a defibrillator, which I'll come to in a couple of slides, if the heart's damaged in any way. And we've heard a little bit about these TNF-alpha blockers, the infliximab, adalimumab, which currently are not approved on PBS for heart sarcoidosis, so that's difficult. And as I mentioned, heart transplantation is where we occasionally end up and where I've seen a number of our patients. This is another Scandinavian Norwegian study, and I don't want you to take too much away from this other than to look at the range of different therapies that these patients had in their initial therapy, their second-line agents, their third-line agents, and then when they were followed up, what percentage had remission. Less than 20% of patients actually achieved remission of their cardiac sarcoidosis. 27%, so more than a quarter of the patients were refractory to treatment. So clearly, whatever treatments we're using are not curing the disease, and so we are still very early on in our understanding of how best to manage cardiac sarcoidosis. Defibrillators, this is really one of the key considerations with cardiac sarcoidosis. The ventricular arrhythmia rate, as seen in that Japanese registry of 30%, means that there's a high risk of fatal or dangerous cardiac rhythm problems in patients with cardiac sarcoidosis. And so a defibrillator is a little pacemaker-like device where the lead goes into the heart, and if the heart does develop a dangerous or rapid rhythm, it can give a shock to the heart and get it back into normal rhythm. Also importantly, second lead associated with the defibrillator there to treat any heart block for those patients who might have that heart block syndrome that I mentioned in that first slide. So my final slide, so what's missing? We're still struggling. We don't really know what we're treating. We need to do further research on etiology, the risk factors, how we can best categorise who's at risk, who's at most risk. We don't have Australian data, as Paul mentioned, and certainly in cardiac sarcoidosis we've got very little idea of what the rate of cardiac sarcoidosis is in Australia. We don't have any randomised trials, clinical trials of therapy, and Elisa put up that very helpful overview of randomised trials in cardiac sarcoidosis, and there was only one in cardiac sarcoidosis that you might have noticed, and it was of uncertain benefit. And so we have 0 randomised clinical trials in cardiac sarcoidosis where I can say, this is the best treatment for you. All we can do at the moment is say, look, this is something that might help, and this is something that we use for non-cardiac sarcoidosis. I know you've got cardiac sarcoidosis. This is non-cardiac sarcoidosis treatment that may help the heart, and that's about as good as we've got at the moment. So really we need a lot further research, and obviously one of the reasons for generating the interest and starting SARI is to really see if we can drive further research and collaboration between a number of centres. As seen in this data, 30-year data, and it's only 500 patients. It's not something that one hospital or one clinician can answer. It's something that has to be probably a national collaboration to get numbers in Australia, certainly, for us to be able to answer some of these important questions. So I'll leave it there and happy to take some questions. We have a starter right off the back. Yep.
With having a cardiac MRI, just say for instance the patient was to go in and have cardiac MRI, but they weren't actually having an episode at that particular time. Can it actually show negative that there is no sarcoidosis, and then when it comes back, it actually show that it's on the scan at that point in time? I'm just trying to work out how that works.
Yeah, so this, cardiac MRI is a very helpful test. It shows us three things. One is heart function. So, is the heart pumping strongly? So that's a really helpful thing in helping us guide medications. Is there any inflammation? So we can look for something called edema or inflammation within the heart muscle, and you can't see that on echo. That's the reason the MRI is helpful. You can't see edema on echo. And the third thing you see on MRI is scarring. And scarring is one of the risk factors for the ventricular arrhythmias. Now, if you have an entirely normal cardiac MRI scan and a normal PET scan, cardiac PET scan, then your risk of cardiac sarcoidosis is low.
Even if you still had what you were talking about before, about the ventricular block being under the age of 50, like quite young and all of those, and also having pulmonary sarcoidosis?
Well, if you've got pulmonary, yeah, so you're getting into probably the possible cardiac sarcoidosis range, but if you've got a normal MRI and a negative PET scan, so no inflammation, no scarring, then we don't have evidence that the heart has been involved with sarcoidosis. There can be other reasons for heart block and pacemakers. Sarcoid is just one of those things we've got to think about when we see that. Yep. Yep.
You mentioned the use of biologics in cardiac sarcoidosis. I know that overseas I've seen some papers discussing using biologics quite a bit. Now in Australia, those two biologics are available if you've got rheumatoid arthritis or Crohn's disease, but because we've got the wrong kind of autoimmune, unfortunately the PBS is not, those two biologics are still available for cardiac sarcoidosis patients.
That's right. Yep.
You know, there's a push to actually lobby the federal government to get those onto.
I don't know if there's a lobby. When you're going to drug approvals, there are a couple of considerations. One is the number of patients at risk. The next is the evidence for treatment, so treatment benefit. The difficulty with infliximab is that there is some benefit from the cardiac side of things. So there is an improvement in ejection fraction, say, and the largest infliximab study, the ejection fraction goes from 43% to 47%. So a slight improvement, but in the right direction, definitely. But you've also got to look at the downside, and one of that study actually showed there was an increased risk of serious infections. And so, the government says, okay, well, we can treat with this medication, it's good for the heart, but it causes a further problem. Have we decreased hospitalisations? Have we decreased overall mortality? And so we can get very focused in looking at our own organ, but I think we've got to take a bigger picture, particularly with something like sarcoid and with biologics, because they have off-target effects. And so that's the difficulty, is we don't have a randomised clinical trial showing that there is a strong clinical net benefit for infliximab or adalimumab. I mean, there are small trials and case series that are hopeful, but you won't get a drug approved on a case series. It's got to be a randomised trial. And I think, as Paul was mentioning, the importance of placebo, particularly something like sarcoid, which is really an unusual condition where you can have florid disease which can burn out, particularly with the hilar lymphadenopathy, with the lymph nodes. We certainly see cardiac inflammation on PET scans that goes away. And so you can have, a change in cardiac involvement on PET scans that may not be there subsequently without any change in therapy. And so we just don't have strong randomised clinical evidence at the moment.
So is the risk of infection mainly respiratory infections?
Mainly respiratory infections.
Severe ones?
Yes. Yep. I think. Sorry. Yep.
So I'm actually on compassionate grounds with
Adalimumab. Well done. Yep.
so that was through my neurologist because I had it quite severely systemic through my body. And so that's on compassionate grounds through the hospital and also through the pharmaceutical company. They pay for it. I'm coming up to almost 2 years in December, and I'm speaking later, so I'll let you know. But yeah.
So that's for cardiac sarcoidosis.
No, I had
Yeah. So that's where we. Yeah. Yeah.
apart from my heart, so I've pretty much got it everywhere. And it was just through the generosity of my neurologist, which is I think one of her colleagues is going to be speaking shortly from Sharp Neurology.
Yep.
She was the one that suggested after my testing that we go this way, and in collaboration with my immunologist, I have an injection on a daily basis, a weekly basis, 40 mils.
Yep.
But they're also, because I've still got activity increasing in the lungs, and I'm stage 4 there. So they're thinking of the intravenous, which is the other one.
Yep. Infliximab. Yep.
So it depends on how you want.
Yeah, so often it is you can get early access to drugs within a clinical trial, and that's one of the strong reasons to run a clinical trial, is that we can sometimes convince a drug company to give us what are expensive drugs within that context of a trial. If they think it's in their interest, they'll do that. Yep.
My main concern was, is SARI going to educate maybe, or more so for cardiac specialists and doctors? Because I have found through my history that cardiac surgeons that I've been to never ever brought up cardiac sarcoidosis.
Well, I think, I mean, part of our, that's the whole A in SARI, the advocacy. So, yeah, we've got to increase awareness. Cardiac surgeons probably aren't going to be the ones who drive medications, but cardiologists, yep.
And on that point with that lady, I have a team in Brisbane, I have cardiac sarcoidosis, and a neurologist in the public system that they have found a way to get me treatment through that system.
Yep.
After coming down from, let's say, methotrexate and all that. So I feel like a guinea pig at times. At least something's happening.
Sure.
Yeah.
Yep.
But I think that steroids do more damage than anything else to the body.
Well, they're the only ones that do we have evidence for steroids? That's a good question. I think there's one here and then one there, and then one there. Yep.
The lady in the front was asking about possible, when it falls into the possible cause of possible implication of cardiac sarcoidosis. And I just wanted to add on, she asked about having pulmonary sarcoidosis. What if there's more evidence of other organs with sarcoidosis? And there's only been, in my case, one blackout with a loop recorder insertion, no significant events.
Mhm.
How often would that then, how often would you then be screened for cardiac sarcoidosis?
So certainly, I think if you have extra cardiac sarcoidosis, have treatment as appropriate for that. In terms of, assessment of cardiac involvement, I think it's definitely worthwhile having the MRI and the PET scan at baseline, and sounds like you had an electrical study with an EP study with an implantable loop recorder, which is, probably the best thing. I assume that would happen because there was negative MRI, EP, and PET. And so that's the appropriate therapy. The good thing about an implantable loop recorder is it's there all the time, it's active all the time, it is monitoring all the time, and if rhythm is one of the manifestations, you'll get an immediate notification. Whether you need to have repeat PET scans or MRI scans, we don't have a strong sort of guideline. It's probably reasonable, every couple of years for an MRI scan to look for, but it's not covered. No, it's definitely not covered. Yep. No, it's only a monitoring thing. Absolutely. Yep. Sorry. Yep. Sorry.
Would you suggest if you hadn't had any, if you had a loop recorder in situ, would you suggest that you hadn't had any events, documented events, in the 4 years that you've had with them, because there's a certain battery life, would you suggest that you get the test after 4 years if you hadn't had any events in that 4 years?
I mean,
being treated for extra pulmonary?
I think it's my clinical impression would be after 4 years, if there's no events, that's good. And if you wanted, should I put another one in now that the battery's gone flat, let's repeat the baseline tests, MR, PET, and if they're still benign and there's no further events for 4 years, I probably wouldn't, but that's, your doctor's going to tell you that, not me. There's one at the back. There's two at the back. And then last, you'll be the last one. Okay, sorry. Yes. We have had sarcoidosis come back in our transplant patients, which is interesting because they are heavily immunosuppressed with transplantation. So yes, we have seen recurrent disease, which is there's a very interesting, completely separate question. There's a cardiac condition called giant cell myocarditis, which is thought to be separate to cardiac sarcoidosis, but I'm sure that there's some crosstalk between the two, because we know with cardiac giant cell myocarditis there's a 25% chance of recurrence post-transplant. And so I suspect, we may, there's probably crosstalk between those two conditions, and they both manifest as these granulomas, giant cell granulomas in the myocardium. Oh gosh. Oh no. We've done. I think we've done about 1,400 transplants at Vinnie's, and of those sarcoids, 20, 30, 40. Yep. We should probably pull all our data together. Yep. Sorry. The difficulty is often you're using other medications to treat VT as well, non-immunomodulatory treatments, so mexiletine, amiodarone, beta blockers, all the rest. Whether it's those treatments that are decreasing your VT versus that, it's all anecdotal and unproven. I mean, the patients who come to us with what's called VT storm, sometimes out of desperation will use it. And, we know that these VT storms can come and go, but we sometimes do use infliximab typically in intensive care, when they're they're storming away and got nothing else to throw at them. So, but it is very much, this may help or we don't know. And last question, just last question. Sorry.
I just wanted to make a plug for all of these stories to be put into an epidemiological study. So that's really what I think from SARI's perspective. Is there any thoughts to try and do that?
All the stories will go to SARI,
Yep.
and it already are SARI stories there, quite a bit of them. The ones from this seminar will go to SARI as well. And the whole seminar has been video recorded. You should go and
Yes, Peter, I've taken all your time. Sorry, you'll have to rush. Great pleasure to welcome Peter.
Okay, good morning everyone. Thanks Branko and the team for inviting me to be part of this really interesting and important sort of day. So I'm, Yeah, no, I can see it on my monitor. Yeah, okay. So, I'm an ophthalmologist. I'm currently the Professor of Ophthalmology at the University of Sydney, but I'm a graduate of this university, and it's good to come back to my alma mater. Always had a lot of time for New South Wales Uni. So about 80% of my practice is now in inflammatory eye disease or uveitis, which is a common problem with sarcoidosis. I think in the interest of time we can pretty much skip this slide. The only thing I want you to take away from this slide is down the bottom there's a thing called IWOS, the International Workshop on Ocular Sarcoidosis, which has come up with some diagnostic criteria, and SUN, the standardisation of uveitis nomenclature, which has been an important step forward, and I'll talk a little bit about both of those in a moment. So the eye can very commonly be involved by sarcoidosis. I thought I'd cheer everyone up by showing you how we test for dry eyes in dogs rather than humans, but it's the same technique. Dry eye disease is really common in dogs, and a lot of our experimental data on dry eye disease comes from dog models of the disease. And sarcoidosis is an important cause of dry eye disease, and we do lip biopsies and conjunctival biopsies to look for sarcoidosis in patients with dry eye disease. We all got taught in medical school that we should be biopsying the conjunctiva, but it doesn't really work, and unless we see abnormalities these days, we won't do that. This is one of my patients who's got I always get the wrong way around, Waldenstrom syndrome, uveo-parotid fever. He does have uveitis. He's got big swollen parotid glands and swollen lacrimal glands, which you can see on the MRI scan there. So there's a whole range of all sorts of neuroophthalmic manifestations of sarcoidosis, but the commonest by far is uveitis, which occurs in around 30% of patients. And also important to remember that sarcoidosis is a great mimicker. There are three diseases that we always worry about, syphilis, TB and sarcoid, and they're the diseases that can sort of really mimic any ocular disease in particular. So what's uveitis? So uveitis is inflammation of the uveal tract. So there are three layers to the wall of the eye: the white coat on the outside, the sclera with the clear cornea. Then there's a blood vessel layer underneath that protective layer that's called the uvea. And the reason I've got the bunch of grapes up there is to the ancient Greeks, who were the first people to sort of start looking at anatomy in a systematic way, they thought that that middle coat of the eye looked like a bunch of red grapes, so they used a Greek term for it, uvea. And the inner layer of the eye is the retina that does the seeing. The thing about uveitis is it can involve any of the three parts of the uvea: the iris that we can see at the front, and the ciliary body and the choroid that are in the back. And many of the signs that we see clinically as ophthalmologists are because the inflammation spills over from the blood vessel layer, the uvea, into the retina, into the optic nerve, into the front of the eye, into the cornea, and even the sclera. And so there's lots of different signs of inflammation in the eye that we can see. So Sun has made really two important contributions. The first is it's come up with this pretty much universally accepted classification system. And just so that you know, eye doctors, we're fairly straightforward, simple people. So inflammation in the eye can be in the front of the eye. This is the lens, the cornea, and the iris. So this is anterior uveitis. It can be in the back of the eye, involving the retina and the optic disc and the choroid. So that's posterior uveitis. The dots here are Alyssa's favourite cells. They're lymphocytes, macrophages, and neutrophils, white blood cells. And we get an outpouring of these inflammation cells into various parts of the eye when you get uveitis. So you can have anterior, posterior. You can have inflammation that's centred in the jelly that fills up about 80% of the sort of inside of the eye, called vitreous, and so we call that intermediate uveitis, or obviously everything can be inflamed, and that's panuveitis. So what I thought I would do is just show you some of the data from our uveitis clinic at Sydney Eye Hospital. So I started at Sydney Eye Hospital 18 years ago now, and we had no uveitis service. And so there was myself and a registrar. We now have 5 consultants, 2 fellows, 3 registrars. You know, we see 100 patients pretty much every week in our clinic. So it's the largest public sector uveitis clinic, certainly in New South Wales, if not in Australia. And we get referrals from all over New South Wales. So this was some data that one of our trainees put together a few years ago. So over a 10-year period, about 2,000 new patients with uveitis, and 100 of those patients actually turned out to have sarcoidosis. The eye hospital is an adult hospital. We send children to the children's hospital, so there's no children in here. More women than men. Sort of a typical, slightly older age than average for many causes of uveitis. And importantly, in the majority of patients, both eyes are involved, and it's a chronic, ongoing, grumbling inflammation rather than little episodes with disease-free intervals. So remembering our Sun classification, so about 45% of the patients had involvement just of the front of the eye. That's good, because that sort of inflammation has a much lower risk of causing permanent damage to your vision. It can cause problems which we'll talk about, but they're much more treatable than if the uveitis involves the back of the eye or all of the eye, which again it did in about another sort of 35%, and then in the middle in about 20%. And that's a pretty typical distribution for inflammation. So the other important contribution that the Sun project made was it's come up with classification criteria for 25 different types of uveitis. And the thing about classification criteria is that they will sacrifice sort of sensitivity of the diagnosis for specificity, and so we use classification criteria for designing clinical trials to make sure we have a really homogeneous sort of treatment group for the clinical trial, and that's the thing that we need to do in uveitis. It's a rare disease. And so up until the Sun project, we used to just lump all of the patients into one group, but now we have the ability to only look at patients where around the world everybody agrees that they have ocular sarcoidosis. So the take-home point from here is it can be any form of uveitis, but you need either a tissue biopsy that demonstrates those non-caseating granulomas, or the swollen lymph nodes on your chest X-ray. And we check pretty much we check everyone for syphilis, because syphilis can do anything in the eye. And if you're in a TB endemic area, it's important to differentiate it from TB infection. And certainly my Indian colleagues often have great difficulty figuring out, is this TB, is it sarcoid, could it actually be a mixture of both? So when we looked at our patients, roughly a third of them, we had a positive tissue diagnosis. In another third, they had an abnormal chest X-ray. And in the final roughly third, they had changes that sort of look like what sarcoidosis tends to look like in the eye, but they had a normal chest X-ray and there was nothing that we could biopsy. Now, with the Sun criteria, these patients don't have sarcoidosis. But with that other group, the IWAS group, they would say that most of them would have, probable sarcoidosis. And they have 3 different things: definite with a tissue biopsy, presumed with hilar lymphadenopathy, and then this other group where there's a range of different clinical signs but no real other evidence. So what are the sort of things that we see? It's important to remember eye doctors spend way too much time in small, dimly lit rooms, so we have a very vivid imagination. So we've got all these crazy names for the things that we see. But this is what inflammation in the front of the eye looks like. This is the cornea, that's the iris under there, that's the crystalline lens that gets a cataract in it. And these are inflammation cells that are sticking onto the inside surface of the cornea. And to an English ophthalmologist a long time ago, he thought this looked like little bits of mutton fat that you'd get from a roast lamb. So these are called mutton fat KPs, or more correctly, granulomatous KPs. You can also get little granulomas on the iris. These are called Keepy nodules, and you can also get others. This is an image where we've got a mirror and we're looking into the junction between the cornea and the iris, and this is an area where fluid drains out of the eye, and there are some changes here and little granulomas in that sort of image. Is a way, can we turn the lights down a bit? Is that possible? Because, as I say, eye doctors like having the lights dim. So when you have inflammation in the vitreous cavity, the jelly in the middle, we get things that we, with our vivid imaginations, call snowballs, little collections, granulomas probably of white cells floating in the vitreous. They can settle down here at the edge of the retina, particularly inferiorly, and form snowbanks. And these are really collections of granulomatous inflammation in the vitreous. In the back of the eye, we get all sorts of different spots of different sizes, and I'll show you a better image of that in a moment. We can get inflammation around the blood vessels and get this sort of cuffing of, again, white blood cells and lymphocytes and macrophages leaking out of the vessels. And we can also get swelling of the optic nerve at the back of the eye. This is a much more modern sort of image that we use now. This is a camera called an Optos camera that allows us to get a single image of pretty much the entire retina in one frame. We don't need to dilate your pupils to do this, so we can do this on young babies and children, and it's really revolutionised how we can examine the back of the eye. And you can see in this patient with sarcoidosis, there's just a myriad of focal scars scattered throughout the back of the eyes, and this is one of the common patterns that we see called multifocal choroiditis. And this is about 20 to 30% of our patients who present like this eventually end up with a diagnosis of sarcoidosis. Now, inflammation in the eye causes basically structural problems with various different parts of the eye depending on where the inflammation is. If it's in the front of the eye, it can cause cataracts. It can damage that drainage angle and give you glaucoma or elevated intraocular pressure. If it's involving the back of the eye, it often causes waterlogging and swelling in the macula, what we call CME or cystoid macular edema. So we have this fabulous imaging device called an OCT, optical coherence tomography, where we can get a cross-section scan of the retina and look and find all sorts of things that we didn't realise happened before until we had these scanners. But we now use OCT scans to follow the thickness of the macula to see if our patients are responding to treatment. Some of you might have friends or relatives who are having injections for macular degeneration. We use OCT scans to follow those patients. Cataracts, what I tell my patients is we're pretty good carpenters. So if someone's got a lens that's gone cloudy, we can take that out and replace it. We can replace your cornea. If your pressure goes up, we're pretty good plumbers. We can always make your pressure lower. We're terrible electricians, so we have much more trouble dealing with retinal disease and retinal problems. So we treat those very aggressively to try and minimise the damage, because we can't repair or replace those parts of the eye. So what sort of treatments do we use? So it's pretty similar to what everyone else has said. The good thing is that in the eye, pretty much anything that you can swallow or inject into a vein, we've tried to inject into your eye or around your eye or make it into eye drops. So we use lots of topical steroid eye drops for inflammation in the front of the eye. This thing called an Ozurdex is a little self-dissolving pellet that we can inject into the vitreous that's full of steroid that then slowly dissolves and releases the steroid over about 3 months. And that's very good for treating macular edema. But like my colleagues, we use a lot of steroids. We use a combination either of methotrexate or mycophenolate as steroid-sparing drugs to allow us to get the steroid dose down. And we're very lucky in uveitis now. Adalimumab is approved on the PBS for vision-threatening uveitis. So more and more of our patients, we transition and escalate their treatment up to a biologic, particularly adalimumab. Humira has changed the outlook for my patients, and it's made my blood pressure much better, and I'm less likely to have to see Chris. So Humira has just revolutionised the outcome of our patients with all forms of uveitis, but it's very effective in sarcoidosis. So basically, as you can see, most of our patients do quite well on treatment, but a significant number, far too many, lose vision, and sadly, some become really severely visually incapacitated and become legally blind or sadly completely blind. So I thought I'd finish off by just showing you one of our complex patients that we've managed through the clinic, who presented with a really huge sign that something bad was happening, but it took a while to get through all the clouds and figure out what was actually going on. So this is a lovely patient, a 71-year-old woman, who every time she bent over, she would lose half of the visual field in her right eye. And she realised that this was not something that she should ignore, so went to see her GP and was sent in urgently to see us at the eye hospital. Her only really past eye history is she'd had some laser treatment for a retinal tear a few years ago. She had a family history of glaucoma. She had a sort of fairly typical collection of diseases. She had rosacea on the skin of her face, osteoarthritis. She'd had a hip replacement. She had gastroesophageal reflux. She had benign positional vertigo, and she had an overactive bladder for which she was on some medication. The most important thing when we're trying to sort out someone with uveitis is to take a history, because usually the answer's in the history. So we go back and ask a whole lot of questions that some of our patients think, why is this crazy eye doctor asking me about my back and my skin? So, the important things is she'd had a couple of funny sort of semi-syncopal episodes where she'd almost passed out. She came from South Africa, but there was really nothing to suggest that she had exposure to TB. She works as a part-time university tutor, lives with a husband, drives a car, doesn't smoke, doesn't drink, has no tattoos. You might think, why is an eye doctor asking you about tattoos? There's a thing called tattoo-associated uveitis, and some of those patients actually have sarcoidosis. And so and now 30% of the adult population of Australia has tattoos. So we always ask our patients today, have they got any tattoos and are they inflamed? And that can be very embarrassing when your eye doctor wants to have a look at your tattoos. We always have to ask about at-risk behaviours, IV drug use, sexual partners, things like that. My family thinks working as a university tutor is probably an at-risk behaviour these days. But and as Paul mentioned, pets are important. This patient does feed parrots, but she doesn't actually have them. So basically, the front of this patient's eye was fine. Vision was normal. There was no signs of any inflammation. She'd survived to 21 without someone removing her early cataracts, which is excellent. So that was all fine. I can't see on there, but hopefully you can see that there's this funny area in this eye around the optic disc, which isn't there on the other eye. And that's what we could see when we looked into her fundi, and these are those big optos angiograms. This one sort of highlights it a little more easily. It's actually sitting under the retina, sort of the retinal blood vessels roll over the surface of it. That's the sort of spot welding that she'd had done for the retinal tears. That's just old scarring. And this is an odd and an unusual appearance. And on one of our fancy OCT scans, we can actually measure how thick and how swollen the optic nerve is. And her right one was really quite swollen compared to her left. So there's something strange going on around the optic disc. So we've got lots of toys that we can play with. So when we shine different bluish lights on the eye, it makes things change colour and autofluoresce. And it's white here, which tells us that the insulating layer between the retina and the blood vessel layer is being irritated, and it's hyperactive. So that tells us again something's bad. And then we can use all sorts of dyes that we can inject intravenously and then follow the transit of them through the retinal and the choroidal circulation. So this is, for all practical purposes, normal, but in the choroid, the blood vessel layer underneath, there's this huge filling defect where there's something blocking the blood vessels. So something bad in the choroid here, and it doesn't really look typical of any of the things that we see. We did a whole lot of tests. Some of the tests here we've done because we suspected we'd need to immunosuppress this patient, but essentially we couldn't really find any obvious cause. Normal chest x-ray. So basically the next step is an MRI scan, and to try and get more detail and more information about what's going on. And essentially the summary is that they found they could confirm there was something around the disc and in the back of the eye that was larger than we thought clinically, but fortunately it wasn't extending along the optic nerve and there weren't any other sort of areas of abnormality. But the radiologist said this is a strange and unusual appearance, and in an older person, whenever there's something that looks a bit odd, we have to always worry that it could be some sort of neoplasm, some sort of tumour, and in the eye the common one we have to worry about is lymphoma. So we were concerned that this patient might have a lymphoma. So at the eye hospital in our uveitis clinic, we have a rheumatologist who comes every week to our clinic because, as I was saying, we manage a lot of patients now with systemic immunosuppressive therapy, biologics, and so you don't want an ophthalmologist running your Humira therapy alone. So we have Tony Samuel who comes to help us and helps us look after all of our patients. Tony was worried about the syncopal episodes and thought we should sort of look into that a bit more, and we in our meeting agreed that she needed a PET scan, as we've spoken about. The thing about the PET scan is it showed that there were spots all over the place. So there was, there were lots of lymph nodes. The eye lit up with the PET scan as well, and luckily for us, there was some lymph nodes. There were some lymph nodes that they thought were easily biopsy down in the femoral region, but they were very concerned that this was a cancer, so presumably a lymphoma. So the next step, obviously, was a femoral lymph node biopsy, and fortunately for this patient, it was diagnostic and showed that, in fact, she had sarcoidosis, not a lymphoma. And so then pretty much everything made sense. And so obviously with a diagnosis of sarcoid and cardiac symptoms, we got the cardiologists involved, and there was evidence of cardiac sarcoid, and basically, I won't go through all of that. We know cardiac sarcoid's a bad disease. So essentially, the cardiologists were hoping we'd be able to access Humira adalimumab, which we could legitimately through the eye pathway. And so she was started on high-dose steroids, started on methotrexate. She got some side effects from the methotrexate, which meant we could escalate her to Humira, which we did. And she's really done very, very well. So, you know, her eye disease has regressed and is now stable. Her vision's normal. Tony Samuel's happy that she's doing well, and Chris is happy that her cardiac sarcoid's doing well. I think you have put a defibrillator in her as well. But essentially, she's done very well. So I guess the thing that's really made all of this work so well is the fact that we have this multidisciplinary clinic where there's a number of uveitis specialists, but at the eye hospital I can get a medical retina specialist, a VR surgeon, an oculoplastic surgeon. So we can really get sort of holistic eye care, and importantly through Tony Samuel and rheumatology, we can get sort of pretty much holistic general medical care. And that's, I think, one of the key changes that's happened that's allowed us to look after our patients so well. So to sort of finish off, to me, you know, 21st century uveitis treatment, get the correct diagnosis, preferably a tissue diagnosis if you can. For complex patients, a multidisciplinary clinic is critically important. We now have the sort of therapy that means we can have a zero tolerance for inflammation in the eye, so we get the eye under control. Once it's stable and under control, if there are things like cataracts or other surgical problems, we can deal with them with minimal risk. And in terms of our sort of principles of management, we try to get patients down to a minimal dose of topical steroids, and although we'll use oral steroids to get vision-threatening inflammation under control, our aim with the steroid therapy is to get the dose to zero, certainly to less than 7.5 milligrams if we can. Most of the time, the drug we tend to use is methotrexate. We use mycophenolate if they get side effects from the methotrexate. And because we can access a TNF blocker and there's good evidence that it's more effective than the other drugs, we'll escalate patients to a TNF blocker if we need to. And we can use sort of local injectable treatments if we need to sort of improve things. So although sarcoidosis is sarcoid uveitis rather is a common problem, I think we've got good treatment. We've developed a good pathway for being able to look after our patients and our complex patients. And the best thing is that we have access to biologics, which absolutely has changed the outlook for our patients. So I'll stop there and happy to take any questions. Yeah.
I just wanted to ask you, what kind of involvement have you seen of the lacrimal gland?
Yeah, it's not common, but usually it's symptomatic. So the patient will get an obviously swollen lacrimal gland and what we call dacryoadenitis. And essentially, if it's a young person, we will usually initially think that it's infective, so viral type cause. In an older person, we're always worried it could either be a lymphoma or what we call a pseudotumor. So we'll scan the patient to define the problem. If there's no high-risk features, a trial of steroids, and if it goes away, it goes away, and if it doesn't, we biopsy it.
And in the context of systemic sarcoidosis?
Yeah, well, it's probably one of the less common sort of things that we see in a patient with sarcoidosis. But as I say, sarcoid can do anything. So we always have a sort of a high index of suspicion that it could be sarcoid. And the key thing, as we've all said, is a tissue diagnosis if you can. And it's a fairly low risk, very small incision and take a little biopsy.
And the other thing I had a question about
Yeah.
When that PET scan was done, is the PET scan, and this is sorry about my limited knowledge, but I know with the heart you need a specific, like a cardiac focus PET scan. But sarcoidosis, one of the biggest issues is that you have so many organs. So is there PET scans that do everything?
Well, there were pulmonary nodules, there were multiple lymph nodes, and there was a big enough area of abnormality that they could actually see that it had some abnormal, glucose uptake.
And that was on like the whole body in that sense?
Yeah.
In the one scan?
I think so. That's, yeah. Yeah.
So, two-part question. One is, how would you know you had it, like are there symptoms if you had uveitis?
Sure.
The second half of the question is, I just go to Specsavers every 6 to 12 months and just tell them I've got sarcoidosis, and they tell me if they think I've got uveitis. Is that sufficient? Or expert?
Yeah. Oh, look, the second question first. It's always hard to know. I mean, most Specsavers stores now have one of those Optos cameras. So as long as they do an Optos image, and that's normal, they're pretty good clinically at looking at your eye and saying it's normal or it's abnormal. I think if it's abnormal, you need to be referred on, or if there's any spots on your sort of Optos imaging. In terms of symptoms, pretty much most patients with uveitis, if not nearly all of them, have symptoms. It might be something non-specific like blurred vision or just gritty, uncomfortable eyes, but it can be sort of, fairly rapid loss of vision or blurring of vision and floaters and sparkling lights and all sorts of things. So it's usually symptomatic. Uveitis in children, on the other hand, is most commonly no symptoms. So we screen children looking for uveitis in at-risk groups. Yeah, sorry.
I had a removal of a OSSN 5 months before I was diagnosed with sarcoid. Are those two separate issues?
OSSN? Yes. Yeah. So
because and I still get, even though I'm on the TFN blockers now, I still get a lot of inflammation in the eye, the right eye that I had the OSSN removed.
Yeah. Yeah, so OSSN is ocular surface squamous neoplasia. So it's basically an actinic sort of cancer. And essentially, one of the things that we do for all of our eye patients that we put on immunosuppression is 6 to 12 monthly dermatology checks, because skin cancer is such a problem for us in our part of the world. Some OSSN is related to HPV infection, and so that can sometimes be treated with topical interferon. I can't comment on your particular case. The other thing that gives you... Yeah. So if when we look at pterygiums, are just a little fleshy growth on the nasal side of your eye, and it's a sun exposure related problem. And when you send pterygiums off to be looked at by the pathologist, somewhere between 2.5% and 5% of them have patches of this ocular surface squamous change, and that could be related to sun exposure, or it could be HPV infection.
I'm sorry, we've got to cut it there.
Sure,
We have one more
sorry.
speaker. Dr. Turlow is next. So thank you very much. Sharp neurology. Thank you.
Hi everyone, my name's Turlow Montague. I'm a neurologist at Royal North Shore Hospital, where I also work in the neuroimmunology service, which is a clinic run by some neurologists with a special interest in neuroinflammatory diseases, as well as immunologists. So I'm going to give a brief overview of the neurological involvement of sarcoid, which is really quite a vast subject because the nervous system itself is a large organ, and every aspect of that can be involved in sarcoid. And the reason I've named this talk often first, often missed, is that although neurosarcoid is in and of itself rare, in those who develop neurological involvement, it's typically the first manifestation of their disease, and it often goes undiagnosed for a prolonged period of time. So I'll give a brief overview of how neurosarcoid can present, as well as looking at a couple of cases and take-home messages. So in terms of the entire sarcoidosis population, it's estimated about 5 to 15% of patients will get neurological involvement at some point in their disease. And as mentioned, about 70%, so the majority, will have a neurological symptom at onset. It can affect any part of the neural axis, so that refers to brain, spinal cord, nerve roots, peripheral nerves, and even muscle. And so because of that, it's a highly varied presentation. And that results in diagnostic delay, which can unfortunately lead to permanent disability because neurological recovery is often incomplete. It's typically multifocal, which means that in a single individual, different aspects or parts of their nervous system is affected. And it often runs a relapsing course, wherein you get flares that can then remit for periods of weeks or months, even before treatment is commenced. All the historical literature in relation to neurosarcoid has quoted cranial neuropathies being the most common presentation. So that refers to things like unilateral or one-sided facial weakness, visual loss from optic neuritis, and it's estimated that about 55% of people with neurosarcoid will have cranial nerve involvement. However, more recently, it's been appreciated that probably small fiber neuropathy, which refers to the very small nerve endings throughout the body, are probably involved as much as, if not more so, than cranial nerves. And I'll touch on that a little bit later. So this is sort of an overview of the nervous system and how it can be involved in sarcoidosis. So first of all, looking at the brain itself. So you can get what are called parenchymal lesions. The parenchyma refers to the brain tissue. And here you can see an MRI scan looking down into the brain from the top, and there are multiple discrete white patches that reflect inflammation. It can also cause stroke, and the mechanism of stroke in sarcoidosis is different to the sort of very common stroke you see in relation to vascular disease. Stroke in sarcoidosis can occur because of inflammation of the blood vessels themselves. So with sarcoidosis, you get the granulomas forming around the vessels or even within the vessel walls. And it presents quite a distinct picture, at least radiologically, of stroke than is typical in the general population. So this is what's called a susceptibility weighted image. And on this sequence, blood deposition shows up as black. And so often in patients who have central nervous system involvement of their sarcoid, you get multiple little what are called microhemorrhages that reflect kind of compromised vessel walls bursting. And this is a digital subtraction angiogram. So this is an invasive angiogram that gives us a much clearer picture of the vessels. And this demonstrates, as pointed out by the red arrows, multiple areas of narrowing, which is what is the outcome of chronic inflammation. And the end result of this can be stroke, which can present quite acutely with one-sided paresis, for example. Another common central nervous system manifestation is meningitis, and it's often not the very acute onset meningitis picture you get with infections, but rather a much more indolent process, and you get slow thickening and inflammation of the covering of the brain itself, and that can present with headaches, with low-grade fevers, or even altered mental state and confusion. Moving away from the central nervous system now, everything in the peripheral nervous system, which is as the nerve root exiting the cord, right to the distal nerve endings, they can be affected in a multitude of ways, and it can really make it very difficult to diagnose neurosarcoid and mandates a very high index of suspicion because the type of neuropathy, the pattern of involvement can be very varied and mimic various other types of neurological disease. Hydrocephalus refers to swelling of the brain, and that's a result of chronic meningitis wherein fluid is not resorbed effectively. You can get neuroendocrine involvement, which is pituitary disease, dysfunction of endocrine glands subsequent to that. You get cranial nerve palsies, which I mentioned, like facial nerve weakness or optic neuritis, and a very dramatic and actually not that infrequent presentation of neurosarcoid is longitudinally extensive transverse myelitis. So this is a very long inflammatory lesion of the spinal cord. And you can see there within the white, which is fluid, there's a darker region. And this is the cervical cord showing a very large sarcoid-related myelitis. So that's really kind of all the ways neurosarcoid can manifest. Oh, and I've just mentioned there additionally, there's a very characteristic MRI appearance when sarcoid affects your spinal cord. That's quite a useful diagnostic clue, which again we'll look at in a little bit. So looking at the first case of an individual that had quite a subacute presentation with dizziness that occurred when standing and exerting themselves. And this progressed over weeks to limitation in mobility and gait unsteadiness, and on examination and initial presentation, actually focal weakness in the left leg. They were initially worked up as an outpatient with some preliminary investigations that were unremarkable, and there was kind of a lot of uncertainty as to the basis of the symptoms. Legs continued to give way, and there was now bladder dysfunction. The patient was admitted and was found to have severe postural blood pressure problems, which is actually quite a common feature when there's neurological involvement of sarcoidosis, and relates to dysfunction of the autonomic nervous system, which is the involuntary aspect of your peripheral nerves that regulates physiological functions like sweating, heart rate variability, and also blood pressure changes. There was ongoing bladder incontinence, and an MRI brain was done on that basis. And this demonstrated some chronic changes that were really thought to be insignificant. There was a single little hemorrhage that I demonstrated in the initial scan, but overall the findings were thought to be relatively benign. There was an additional history of weight loss that prompted a PET scan to investigate for malignancy, and this did demonstrate lymph nodes, as we saw earlier from the ophthalmology talk, wherein there was FDG-avid nodes in the chest that resulted in biopsy with features of sarcoid with non-necrotizing granulomas. For that reason, in addition to the biopsy, the patient had a lumbar puncture, which is wherein you obtain spinal fluid for further examination. And this was a very inflammatory picture with high protein, inflammatory cells, and even an elevated ACE, which has sensitivity in neurosarcoid, quoted around 60%, but in reality is something that we rarely have seen. A subsequent MRI was undertaken of the brain and cord, and this time contrast was given, and I think this is an important point to make in regard to neuroinflammatory diseases, that really without contrast, the sensitivity of MRI is actually very low. And after giving contrast, the patient's spinal cord meninges did light up. There was a few foci around the lumbar spine, as you can see arrowed there. And this reflected a very active inflammatory process of the spinal cord meninges. Because of those other features, a whole sort of array of tests was done to assess the autonomic nervous system further, including tilt table testing, a gastric emptying study which demonstrated that their gastrointestinal function was slowed, and nerve conduction studies to assess the peripheral nerves, which didn't demonstrate any abnormality. So with this constellation of symptoms and signs and the investigations, the patient was diagnosed with neurosarcoidosis, with a leptomeningitis and an autonomic neuropathy, which is a small fiber neuropathy, and notable absence of any large fiber nerve dysfunction. This case highlights a few sort of important aspects and complexities in neurosarcoidosis. The first thing that, in fact, it can present in a very non-specific way. It's not uncommon that people have insidious onset of vague symptoms that are difficult to actually attribute to the nervous system. And that if we're only looking for the very classical stroke-like signs or motor deficits, we can often miss neurological illness. It also highlights the importance of contrast-enhanced imaging in the nervous system. And that's often something that we note is not done in the community or is done very late. And it's a very important diagnostic clue, and a very simple thing to do routinely with MRI. I think it's worth mentioning as well, in this case in particular, that the central nervous system vascular bed is probably more involved in neurosarcoid than we've appreciated in the past. And there's been post-mortem studies recently that have demonstrated that a lot of patients who have neurosarcoid do have evidence of small vessel inflammation within the brain. And this does result in small infarcts, which are strokes within the deep brain tissue. And that can present clinically with just fatigue, with brain fog, with some minor cognitive disturbances that, again, can go relatively unnoticed. And so for that reason, there was a sort of a recent review paper on neurosarcoid that did recommend that we routinely also use black blood imaging if someone has evidence of central nervous system sarcoid. Black blood imaging refers to a particular technique on the MRI scanner that allows us to look more at the vessel wall. So the blood comes up black on that picture, hence the name, whereas the vessel wall comes up white. And that can be a much more sensitive test to find inflammation of brain vessels. And I think an important aspect of this case and an important point I wanted to raise altogether in regard to neurosarcoid is that small fiber nerve dysfunction is quite common, and it's probably underdiagnosed, and the symptoms are very nonspecific for a lot of people. So the small fiber nerves are really the very distal nerve endings at the end of the large fiber nerves, and they're below the sensitivity of most of our testing. So if you do a nerve conduction study, that will come back normal, but your small fiber nerves may still be getting injured. And they're responsible for pain and temperature sensation. And so people typically describe a very kind of whole body burning or patchy burning pain affecting the limbs of the trunk. They can also get extreme sensitivity to heat or to cold, pins and needles diffusely. And the autonomic dysfunction refers to things like feeling lightheaded when you stand up, fatigue, bladder dysfunction, needing to urinate more urgently or more frequently, as well as having digestive issues. And there was a Dutch study recently out, and it was patient-reported outcomes, but basically they found that in those who had a diagnosis of neurosarcoidosis, 86% of them had symptoms that were suggestive of small fiber neuropathy. Now, that wasn't followed up with formally diagnosing small fiber neuropathy, but it does indicate that there's probably a burden of disease there that is under-recognized. And in terms of why this occurs, so although the majority of the pathology in sarcoid is related to the granulomas, in terms of small fiber injury, it's actually a result of the pro-inflammatory cytokines that were discussed earlier that over time result in injury of the small fiber nerves. And so because it's not granulomatous itself, it's sometimes referred to as a parasarcoidosis phenomenon. And therapeutically, there's an interesting point here because this phenomenon in neurosarcoid is very poorly responsive to the steroid-sparing agents like mycophenolate and methotrexate. And although we're dealing with very small numbers in observational studies, there does appear to be much better outcome from using IVIG, which is intravenous immunoglobulin, pooled antibodies that are infused, as well as the TNF inhibitors, although access issues for both of these treatments are an issue. The other thing worth noting is that diagnosing small fiber neuropathy in Australia is actually very challenging because no lab in Australia is accredited to do skin biopsies to assess intraepidermal nerve fiber layer, which is really the diagnostic test for this. So we're really relying on patient history and a few additional sort of ancillary tests to support this diagnosis. I'll look at this second case just to demonstrate how neurosarcoid can really mimic other neurological conditions. So this is a 50-year-old with right hand numbness that evolved over a few months. It then progressed to the left side, and by June, they were unable to get out of bed. They had significant impairment in gait, reduction in walking distance. When they were first assessed, they had what's described as an asymmetric spastic paraparesis. So they were weak in the legs, the left side more than the right, and that weakness was associated with significant stiffness of the legs. They also had numbness up to the mid-trunk, a sensory level at the thoracic 7 level, and impaired sensation in the lower limbs. So this gentleman got promptly investigated given how severe the presentation was, and they had a contrast MRI of the brain and spine. And on the right side, you see a side-on view of the spinal cord moving from the brain all the way down. And you can see in the upper cord, there's actually swelling, a lot of edema with thickening of the cord and high signal underneath that. And that's all related to the inflammatory lesion from sarcoidosis that's causing his weakness. And you can see on the axial view, which is looking top down, that the left side of his cord is almost completely taken out by an inflammatory lesion. So a really nasty presentation. These patients we have to routinely work up for other causes of myelitis because sarcoid is a rare cause and there are much more common things that do cause it. And we looked into all of this stuff for this man. And the only things really that returned positive were some protein, which is non-specific inflammation, and interestingly, oligoclonal bands, which are antibodies that are confined to the central nervous system. And now these are a hallmark of multiple sclerosis, which is a potential condition that neurosarcoid can mimic and prove to be a diagnostic challenge given its positivity in this case. So this person was treated with IV steroids for 5 days, very high dosing, followed by a steroid taper. But I'll just take you through their imaging in the months following. So 5th of July, hopefully you can appreciate the significant lesion there with some reduction in intensity of the abnormal signal only a week later after the steroid treatment, and almost complete resolution of the inflammation. However, with steroid tapering, the disease relapsed and came back with a vengeance. They again developed this very aggressive cervical cord lesion and associated deficits of weakness in the arms and legs. So the patient was pulsed again with more steroid, and again, after a few weeks, there was some reduction in at least the length of the lesion, but still a lot of inflammation there. And I just wanted to show this scan to demonstrate that characteristic finding of spinal cord disease in sarcoidosis, which is that you get this sort of linear inflammation just under the pia meninge, which is the inner meninge. And this is sort of a half a trident. If you can, maybe with the eye of faith, see that there's sort of this curve around the dorsal or the posterior aspect of the cord there that travels around the outside. And that's not a very common sort of finding in myelitis and is highly suggestive of sarcoid. And I suppose this case again really emphasizes how important neuroradiology is in diagnosing these conditions and differentiating them from mimics. So this patient additionally proceeded to FDG PET scan, and part of the reason we use that very frequently in neurology is because we can't rely on tissue of diagnosis of neural tissue. And so we're looking for something else that we can biopsy. And this patient, again, had some lymph node involvement in the chest. And these were biopsied and demonstrated some non-satiating granulomas. So we proceeded to treating this person with infliximab straight up, which was through compassionate access through the hospital. And the reason we do that often in neurosarcoid is because of how aggressive it can present. And also, the stakes are very high. Permanent disability, including requiring walking aids or even wheelchair, can occur very quickly, and therefore we often kind of take a top-down approach to treatment rather than escalating from the perhaps lower efficacy drugs. And that was achieved a great outcome in this man. He made a full radiological recovery and a near complete clinical recovery with only some minor residual left-sided weakness. This is just the paper that refers to the trident sign. Very small numbers to go off, but quite a nice feature when we managed to identify it. And this was another paper that just sort of demonstrated some features we can rely on to differentiate sarcoid myelitis or sarcoid spinal cord disease from other causes. Particularly interesting is the prevalence of constitutional symptoms. So 21% of sarcoidosis patients had associated weight loss, fevers, night sweats, whereas in the non-sarcoid myelitis patients, that was quite uncommon. And additionally, there's some radiological features that can be very helpful, particularly that sub-PL enhancement. And persistent enhancement beyond 2 months of treatment is characteristic more of sarcoid than other conditions. So taking all of that into consideration, a few key points in relation to neurosarcoid is, first of all, to maintain a low index of suspicion for neurological involvement of disease, because it can be subtle, non-specific. And it can also be out of keeping with what we consider as classical neurology. It's not necessarily one arm, one leg, length dependent, affecting the foot more than the hip. It can present quite differently. Another thing to bear in mind is the involvement of the small fiber and autonomic nervous system, which is an under-recognized aspect of neurosarcoidosis. Neural tissue biopsy is often not feasible, and therefore we rely heavily on high-quality ancillary testing, with a key emphasis on good MRI imaging and neuroradiology. And just to sum up, as is the case really in sarcoidosis involvement in any system, but differentiating it from other neuroimmunological disease is challenging, and referencing again this concept of it being a great mimicker. And I think that's everything. Yep. Thank you.
Hello. You mentioned optic neuritis. What is the difference symptom-wise with uveitis?
So optic neuritis usually presents with pain behind the eye, and particularly pain on eye movement, and quite subacute or rapid visual loss, so over a period of hours. There's also often color desaturation, particularly with red, and so those are features that favor an optic neuritis. Both are typically unilateral, but in sarcoidosis in particular, you can get a bilateral sequential optic neuritis where the second optic nerve gets affected in the days or weeks after the first.
And my second question was, with the inflammation of the blood vessels, is that associated with headaches or not really?
Yes, so headaches can manifest in neurosarcoid for lots of different reasons, and that can be a symptom of meningitis, which is the sort of the casing of the brain being inflamed, but certainly vasculitis can present with headache also. And it's tricky because some of the constitutional aspects of the disease also provoke headache. So yeah, again, a non-specific symptom, but if it's persistent, we would have a low threshold to investigate it.
I'll take the last question, then we'll have lunch. Are you going to stay for the doctor's forum after lunch?
I can't stay for the forum.
Okay. The last question is, would you be able to differentiate CIDP from neurosarcoidosis?
So not always, but you can rarely get...
Chronic inflammatory demyelinating polyneuropathy. Sorry, it's another very similar condition.
Yeah, demyelinating neuropathy in sarcoid is very rare, particularly the very symmetric pattern you get with CIDP, but it has been described. And I suppose CIDP is more common, and we would generally proceed with treating someone who has a symmetrical demyelinating neuropathy as CIDP, and if they had treatment failure or sort of progression of their neuropathy despite standard CIDP therapy, only at that point in time would we often biopsy or do like a whole body PET scan or something, yeah.
Okay, well look, I think we'll just finish off there. Lunch is served downstairs. After lunch we'll have a rapid doctor's forum, and then we'll have the patient section where the patients present their case studies, and then we'll have a patient forum, then we'll have a strategic discussion about SARI and what we plan to do. So let's go and have lunch. By the way, if you want to take some photographs of each other or of anybody here, you can take the photographs and send them up to SARI. We'll put them on our website just to demonstrate this event, okay? Thank you all for coming back reasonably on time. This next section here will involve 4 doctors, because a couple of our doctors had to leave, unfortunately. Paul is the 4th one, so we have 4 doctors here. Chris will be the MC that will run the show. The idea is that this is an open forum for patients to ask doctors questions they may not have had a chance to ask earlier on. We'll probably try and keep this within about 20 minutes or so, and then go on to the patient stories. Then after the patient stories, we're going to have the patient forum, and then we'll have a talk fest about how to move forward with SARI. Okay? Thank you very much.
Excellent, thank you, Branko. So I think Branko's just set aside a free-for-all. So what do the youngsters say? AMA, ask me anything. Yeah. So, well, ask them anything. Yeah. Paul left. He couldn't handle the pressure. Yes. Yes. Yeah. We have a question. Do we have the microphone? Yes. Yeah. All right. Yep.
I'll take this around.
Yep. Thank you.
Hang on, can you just wait for that so it can be recorded?
Just a question for the I-Man.
The I-Man.
Peter McCluskey. Very, very good presentation. Thank you. I want to know how often we should go to the opticians to try and detect any change in a timely manner, please.
So, look, I think when you're first diagnosed, it's important to get an ophthalmology check, because we know that about a third of the patients with sarcoidosis will get some eye involvement. Paul and I have this arrangement where the pulmonary sarcoid patients, because that's the group that most commonly gets ocular involvement, I see a significant number of them every 1 to 2 years. I think it's important, if you have any eye symptoms, that you get them checked out by an ophthalmologist. And the sort of symptoms are, change in vision, double vision, blurred loss of vision in one eye, red eye. Dry eye disease is the hardest area, because about 30 or 40% of us have dry eye disease anyway from living in a big, dirty, polluted city like Sydney. But sarcoidosis can cause dry eye disease, but it's very complex to sort of sort that out. So I wouldn't worry about dry eye symptoms, but an obvious change in your vision, redness, pain, they're the sort of things that you should get checked out.
That's good advice. Yes.
Is there any contraindication in using contact lenses if you've had uveitis associated with sarcoidosis?
Sorry.
Contact lenses, if you had sarcoidosis, uveitis.
Yeah, there's really no particular contraindication. So the commonest, one of the common reasons that patients can't tolerate contact lenses is they've got dry eye disease, but most dry eye disease can be treated sufficiently that it's okay to wear contact lenses. The best ones are the soft lenses, daily disposables, because the major risk with a contact lens is infection in your cornea, and so if you use daily disposable lenses, that's the sort of the safest option.
Excellent. Yes.
Hi, my name's Julie. I'm a patient recently diagnosed. I just have a general question for all the doctors about when you've got a multi-system disease, and we're still just figuring out all the different systems, who is best placed to manage that? So my access route was via skin, but other systems have come forth, and sort of not really knowing who's the holder of all this. My GP's lovely, but has said really upfront, actually I don't know anything about sarcoidosis, but I'm willing to learn. And so I find that I need to be like the holder of all of the different reports and information. So just wanting to know where's the right place for it to sit. Thank you.
That's a very real question and a really important question. I mean, as specialists, we would always say, the first port of contact is your GP, quite reasonably, and I was talking with Branko earlier today, not a lot of GPs could come today, and I suspect that's because they feel that sarcoid is a specialist type condition, because it isn't common, and it's hard to expect them to know everything about the each of the organ involvement. So, look, your GP is the one who will be able to refer you on, but often you go with what your symptoms are to start with, and then, if you go to a skin specialist, they'll have an idea who, the local lung specialist or heart specialist or immunologist, rheumatologist is who, if you have any of those symptoms. And so, I think probably the only one that you don't really need to have symptoms but warrants follow-up with is eyes. So if you have lung, you should see eyes as well.
Sorry, just to add to that, so it is easy to get the referrals to all people when you find you've got it in different systems. It's then just knowing, is it a rheumatologist or an immunologist or I'm currently seeing a
Pulmonologist, yep. Lung person. I mean, yeah, you talk to the specialists. I mean, the specialists are often, they will know, and they will cross-refer between, as Peter was just saying, he cross-refers with Paul, so the lung patients go and see Peter. So often the specialists will know, where to go.
But I mean, I can add to that as an immunologist. So I do deal in multi-system disease. So frequently the patients will come to me from other specialists. So they don't come generally from GPs. So the GPs will generally refer to whoever is responsible for the organ involved in whatever your first diagnosis is. And then oftentimes they'll be on refer to an immunologist for a general review. So we organise the multi-system review to identify other organ systems, so we don't really depend on the GP to do that. We would do that and then refer on. Now, some GPs do like to do the referrals themselves because they've got really good relationships, so that's a discussion that, it's situation-based, whereas some GPs would prefer that I do the referrals. So, there are certain clinicians who are more expert in sarcoid than others. We all have our subspecialty areas. So it really depends on the skill set of the people that you're seeing. And then we often take a really multidisciplinary approach to treating sarcoidosis. And it also depends on, what your GP wants to do. So some GPs, as you say, like to sit back and let the specialists deal with it. Some GPs like to be the coordinating person. So I think it's very situational. But definitely, if you want sort of a more multi-organ approach, the immunologist or rheumatologist would be able to do that.
That's good.
And I think I would just back up what Alicia says, in that we usually try and determine which organ is the one that requires the most attention, and therefore the treatment is dictated by that organ, basically. And so if it's, for me, respiratory, then I would be usually prescribing, but if it's cardiology or there are multiple organs or we want some unusual treatments, then we ask our immunology colleagues to help us.
So I'm wondering, I've got all the scans and blood tests I have now are showing that they're all coming up clear, although I'm still on medication, but I'm still getting very bad fatigue and very bad headaches, which I'm getting treated for with topiramate. So I'm wondering, why does that happen, and how long is that going to last? Do you know? Because I know that's not just me. A lot of people have that problem.
That's an Alyssa question.
Look, I agree. Fatigue is a really difficult symptom that affects a lot of people with sarcoid. Sometimes it is because of the cytokines that are causing those symptoms, but if you're on treatment and, we often follow things called inflammatory markers, if they're flat, then we don't have good answers in terms of exactly what's causing the fatigue. Oftentimes it's what we call multifactorial, so there may be physical immune things, there may be psychological aspects, particularly if you have chronic disease. We know that, that can lead to depression and fatigue. And we also know other people have completely unrelated reasons to be fatigued. So it's a bit like the genetics. You might just have one cause of fatigue, but you may also have lots of different causes of fatigue, and it's really about, optimising where you can those causes. And then sometimes it's just about treating the fatigue itself. So what I say to my patients is, well, we've looked absolutely everywhere, we've tuned up as much as we can, now we just need to focus on the symptoms. And so some of that may be things like, improving your sleep, your exercise, your diet, but there's unfortunately no single answer to managing fatigue. And it's often a very individual thing. But really you need to be open-minded that it's not just the sarcoid causing the fatigue, and to tune up all the other aspects of having a healthy lifestyle can be really helpful.
We were talking at the lunch break about the fact that there are some places that have the sarcoidosis. You go to a sarcoidosis clinic and you see everybody there. So, Peter, you were saying that Anthony Samuel comes to your clinic. Is there any capacity to have a sarcoidosis clinic where you could see? Because it is really, if you've got to go to 6 different people, that's 6 different places. You've got to take 6 different times off work, and then the fatigue sets in because they're all in different places.
I think that's a really good point. And we would love to also have a combined sarcoidosis clinic. I think in terms of really what's holding it back is funding. And so if we can have groups like this and patient advocacy, and you have a care standard to say actually that's what the standard should be, and do some studies around that to show that if people go to a multidisciplinary clinic that their outcomes are better, whether it's the patient-reported outcomes or the sarcoid outcomes, that's when, hospitals and government will start to listen and fund these clinics. So it's really a funding model.
Discussion after this. It is an action item.
Very good point, Kathy. And years and years ago, when I was still training and I was at Brompton Hospital looking after cystic fibrosis patients, the patients would come and they would cycle through respiratory, they'd go to the physiotherapy, dietitian, the liver specialists, and if they were being looked at for transplant, then there'd be a transplant doctor there as well. So they would come from a long way away, and they would cycle through all those specialities in one morning, and it made it much more efficient. And as far as we could determine, it had a beneficial effect on their survival.
Mm.
With patients that are fortunate enough to get biologic treatment, is it usually given just for the period of a flare, or is it something that they most of the time have to be on it for years? And I understand that everyone is different, but kind of like in general terms.
Certainly, I can tell you from an ophthalmology point of view, one of the biggest problems we have is figuring out when is it safe to stop treatment. And when we are trying to stop, say, adalimumab now, initially we used to just stop it and see what would happen. But there's increasing evidence that a safer way to do this is to start to increase the interval between the injections. So we go out to 3 weeks, then to 4 weeks, 5, 6, whatever, and slowly over quite a prolonged period, just wean the patient off that. But the frustrating thing is there's no blood test or eye test that I can do that says, yep, your disease is in remission, it's safe to stop the treatment.
Yep, so again, it's very individual. The things that we take into account is which organ is involved. So if you have an organ that is difficult to assess whether there's a flare or not, such as neurological disease or quite a more vital organ, then generally we tend not to stop the treatment unless there's side effects, because the risk of a flare can be, I guess, worse in one area than if you have a risk of a flare in the skin, for example. So it might be reasonable if you have skin sarcoid to see how you go off the treatment, because if it flares, you're going to be able to see it. Whereas if it's in a hidden organ or a vital organ, it's a little bit trickier. But it is very patient dependent, and a lot of patients with chronic disease do get treatment fatigue. So sometimes we will do a negotiated cessation, and as like Peter said, to kind of stretch it out. And, you know, I think you need to treat it dynamically. So if the disease looks like it's coming back, or, you know, we might restart or we might try a different medication. But unfortunately, there's no answer to that. And so it really depends on, for me, I say, well, how well are you going to tolerate a flare if it comes back? And if you've already got a lot of organ damage to begin with, then the risk of a flare causing something that really results, you know, in a negative impact on your ability to enjoy life, then maybe it's not worth it. Whereas if you have very mild sarcoid and you're a bit sick of taking the medications, then we might negotiate a period off and see how you go. So it's really a discussion that, I mean, I have with my patient to decide what's safe, what are the boundaries we're going to put around you know. So that unfortunately there's not a one-size-fits-all answer to that.
Maybe if I could ask Chris a question, because you raised at one point that with adalimumab, whatever it's called, if you already have heart failure, adalimumab could precipitate the heart failure. Could you elaborate a little bit on that?
Yeah, so one of the tricky things with established heart failure, the TNF-alpha blockers increase the risk of hospitalisation for heart failure. And that's been demonstrated in rheumatoid arthritis patients. And so that's a black box warning for TNF-alpha blockers for rheumatoid. So if you have significant heart failure, then you shouldn't be on a TNF-alpha blocker. Often from the cardiac perspective, if you have significant impairment in heart function, often the cardiac sarcoid is burnt out, it's scarring, and so there isn't an active inflammation component. It is just damage that has accumulated over time.
Damage.
So, yeah, so there isn't an active role for TNF-alpha blockers there. Acutely, that's why we sometimes do use infliximab in intensive care, where there's an acute inflammatory or VT storm that we're throwing everything at the patient.
Okay.
My question was just in regards to the multidisciplinary approach. A lot of the papers that I've read talk about that, and they say that the respiratory specialist is often the coordinating care doctor, but only from the viewpoint of it being the most... sorry, Professor Paul. But only
we're very relieved, thank you.
Yeah.
Yep.
You can go home now. Only from the viewpoint that is the
commonest,
most common and majorly sort of affected. But are we going to talk more about that in the next section, about how we can get around to something like that, having a...
No, we're talking about a number of issues.
Okay.
The issues of an integrated clinic was one of the action points we were going to bring up anyway.
Okay, so I'll wait till later.
Yep.
Fantastic.
Just probably one for you, Chris. The current likelihood of having an MRI after implantation of a device. I did have one back in 2019, and more for other sarcoidosis related after 2 years after initial diagnosis, but more recently my cardiologist wanted to perform one, but I found ringing around Sydney, St Vincent's did the one in 2019, but it doesn't appear to be an option these days. Just wondering what you're hearing.
Yeah, no, it is an option. It's just got to be organised. Often it's got to do with changing the programming if you've got a compatible ICD pacemaker device, because some of the older leads, particularly, and older devices are not MRI compatible. But most of the current ones are, but it is a matter of coordinating with the technician so that they can deprogram and reprogram on the day. And that just is something that is done. We have a fellow in the imaging centre who will do that. It's a matter of booking in and coordinating.
That is pretty routine. It's an extra few $100 cost. Oh, yes. Because a technician needs to program, reprogram.
Yep.
One more maybe, and
yep.
then we can call
yep.
it quits. Oh, you got one.
Yep, sorry about that. I hope you don't mind. I've got a couple of questions. One is a couple of cardiology ones for Chris. You mentioned about MRI compatible ICDs. So mine's MRI compatible, and I got one MRI before diagnosis that showed very, very positive late gadolinium enhancement. And that was good enough for my cardiologist to say, bang. But they did a follow-up one 6 months after my ICD implant. You couldn't see my heart at all. It was just like this black hole in the middle of it. Is there any point to getting a cardiac MRI once you've been diagnosed?
Often not, in that if you've got the diagnosis and that's been made, you've got a defib, and that's the therapy, you can monitor function with an echo, an ultrasound of the heart.
Yeah, that's what
you can monitor inflammation with a PET scan without an MRI.
Yep.
So yeah, MRI is more accurate for cardiac function. It may or may not show progressive scarring, but that doesn't change your therapy necessarily. It's more to do with your cardiac function and your medications for heart failure and your inflammation and medications for inflammation if you've already had the diagnosis made.
Sure, thanks. So it sounds like I'm getting appropriate care.
Thank everybody. And sorry, last question, very quick.
So I had pancreatitis at the beginning of my journey, and the first person I spoke to today had also had pancreatitis as part of sarcoidosis, and pancreatitis is supposed now to be 1 to 3% of sarcoidosis, and we've not addressed that here.
That's Peter's specialty, I think. No,
I know where the pancreas
you
is.
know where the pancreas. That's. I certainly wasn't aware, as a cardiologist, of the pancreas involvement. At least, is that something? Are you?
I mean, it's incredibly rare. I've got one patient, but that's I mean, as I said, sarcoid, you can get any organ involvement because the granulomas can be anywhere. By and large, the treatment is along the same lines of the steroids, methotrexate, and then moving on to your biologics. So when we see... Well, the only way we can do that is by biopsy, but sometimes if there's an organ, that's difficult to get at, or if the biopsy is going to cause problems, like in the heart, we rely on other indicators. So a PET scan might show somewhere else that is easier to biopsy, or if you have other features of sarcoid, like a raised calcium, a raised ACE, those can provide alternative evidence of granulomas. But when we make medical diagnoses, we have people where we say, well, this is definitely sarcoid because you've got biopsy-proven evidence of granulomas. But we have many patients where we would classify them as probable sarcoid, and that's because you haven't got any other reasons that are better than sarcoid to explain those features. And then we would treat them along the same lines as sarcoid, and then if they respond to standard sarcoid treatment, you've got enough evidence to be fairly confident that that's what you have, but always in the backs of our minds, we're always open to the fact that it could be something else. But unfortunately, medicine is imperfect. So there will be patients where you're just not going to be able to get your full hand of evidence, particularly if somebody's been on steroids, up front for a while. If you go and biopsy on steroids, you may have missed that opportunity to get the granulomas. But oftentimes we're really, juggling whether or not you need to be treated straight away versus do you have time to wait to undergo all this testing. And again, it's very individual. So, with medicine, you become comfortable with a little bit of uncertainty, which I know for patients, that's not great. So, it's something to just sort of wrap your head around, but sometimes we just have to, I guess, accept that you're never going to get that full hand of testing for whatever reasons. But if you're responding to the treatment, then it doesn't really change what we do.
That's an excellent answer.
Well, that's a really good.
Shall we do one more?
Very last one,
question.
non-negotiable, last one.
I didn't have an occasion before. I wanted to ask if sarcoidosis might cause pretty much regular seizures.
seizures accompanied by high temperature, above 38 up to 39, long sleepiness, loss of ability to talk, more or less very upsetting. And I'm currently given anti-epileptic drugs, which don't help. So the seizures continue, and I'm very confused. And I suggested to have a lumbar puncture, but you just said that it's not very diagnostic. I'm afraid as well.
I think unfortunately, Turlo is not able to stay. Our neurologist, he certainly, there was some evidence for lumbar puncture on some of the markers that he mentioned, but definitely that's a very specialised neurology question. I can't add anything more.
Maybe seeing Dr. Turlo from Sharp Neurology could be a good idea.
Yeah.
I think we really have to wrap it up for the moment. I want to thank all the doctors, the wonderful doctors, for spending so much time with us. You're very welcome to stay, but if you're not going to stay, we understand that you're busy. But, thank you again. Thank you all. Okay, so we're going to start now the patient feedback session. Ken will be the first speaker, and it's again about a quarter of an hour, 10 minutes and 5 minutes, and then we'll have a patient forum at the end, and then we'll start our round table.
Thanks, Branko. Thanks for the invitation. My name's Kevin Norton, and I'm a professor here at UNSW, but I'm not here as a professor. I'm here as a patient. I have sarcoidosis, and I'd like to tell you my story, which is quite a long one, long in terms of time, not time I'm going to take today. My brief overview of my life: I've been an athlete, a professional athlete. When I was younger, I played at the highest level of football in South Australia, AFL. Before the AFL, it was SANFL in those days, but it was the highest level. I have 3 kids. As I said, I'm a professor, and let's take you through. What do I need to hit here? I do this for a living, actually. But top right, green. What am I shooting? There we go. So if I go back, I'm 67 now, ready to retire in a few weeks. But if I go back to when I was 32, I was exercising after I finished my professional career. I studied as a phys ed teacher originally, went on to do a PhD over in America, and became an academic. But at about 32, after I'd retired, running, active, all the rest of it, I actually laughed at that time. I said to my wife, listen to my lungs, and they were really quite squeaky and stiff. And I thought it was just, I don't know what it was, but it didn't impact me in any way. But then it started making some wheezing sounds, and then I felt terribly nauseous over a few weeks, months. Terribly nauseous and lethargic. So it was diagnosed soon afterwards when I basically was, felt terrible. And at age 33, they did a biopsy, confirmed that it was sarcoidosis. Lung function was impacted a little bit at that stage, but not very much. Went on steroids about a year at 50 milligrams. That's an older version of me. I wasn't 33 then, but I really did blow out at that stage with all the steroids. And that little diagram just indicates it went up and down over the years. But basically, once that first year was up, and I was working and a dad and doing all that sort of stuff, and I was still active, very active. I tried to, have a normal life other than the sarcoidosis, which would flare up from time to time, and I would pretty much self-regulate with some increased or decreased corticosteroids, but I never went off it. So I've been on them for 33 years now, at about 5 milligrams now. Along the way, things were pretty good, but I used to do challenges every year. I went in a bodybuilding competition one year, and I went in, which I won, I might add, for the over 50s. But I ran the New York Marathon. I was really, enjoying life as much as possible with that constraint of, better not overdo it. I better be mindful. But I started to get. It was actually the time I was training for the marathon, and I was on the tram going to work, and I thought, I'm going to have a heart attack. I'd done a long run the day before, and it was just so aching in my heart that I went to hospital, emergency. I said, I'm not sure, but I think I'm having a heart attack. Anyway, they did a few tests and said, oh, your heart's inflamed, and, you know. So I said to the cardiologist, do you think I should go on the marathon? He said, yeah, just take 50 milligrams a few days before of prednisone. He said, you'll be fine. So anyway, I finished. I didn't drop dead, obviously, so that was that. But it progressively got worse, and I knew something wasn't right. And so one day I rode into work and I collapsed. I'd ride my bike in and push it a bit, but I collapsed, and people took me to the med centre, and they said, oh, something's not right. ECG's not good, but we're not sure what it is. So eventually, a cardiologist in Adelaide, this is all in Adelaide, said, look, you know, we can see that you've got cardiac sarcoidosis. There's nothing we can do for you. It didn't offer any different medication, nothing. I thought, well, I didn't know anything about it, so that seemed reasonable. But my daughter was working over in London, and at the University College London, they have a cardiac sarcoidosis clinic where they see 400 patients a year from right around the world. It cost me £8,000, but I went over there and they did various studies, and they showed that, yeah, indeed I had, at that stage, right ventricular granulomas, and they put me on methotrexate, and straight said, you've got to go on it straight away, which I did, and it sort of settled a bit, but it's gradually getting worse. I can sense it, I can feel it, it's hot, it gets hot, particularly if I exercise too much. It gets hot in my chest, it rubs, it feels like there's friction in there, a bit like my lungs actually when I first started. But anyway, so along the way I've probably seen 6 cardiologists, 3 respiratory physicians, and self-regulated as much as possible. But the important thing here is that I've tried to keep a very active life and a healthy life. I've been monitoring that as best I can because that's my work. Nobody could tell me what, as really today has proven, nobody can say what it is definitively, and that we're probably a long way away from that. But it was interesting, and someone mentioned it this morning, that after September 11, there were papers published, many papers, not just 2 research articles showing there's a really big spike in the cases of respiratory sarcoidosis, or general sarcoidosis, I think. And it got me thinking, you know, what around the time when I was 30, we came back from the US, we bought a place up in Newcastle just after the, and I'm not saying this is cause and effect. All I'm saying is it's an interesting time sequence, but particularly after this, we bought a little old cottage, and that's me. I had a hair then. I'm not trying to hide a bald head now, but I had a bit of skin cancer taken off, so that's why I'm wearing the hat. But what you can see, this was a dusty, dirty, and for 6 months we renovated this place. Now you say, well, I got sarcoidosis within months after this, but my wife didn't. So, you know, it's obviously an environmental genetic combination. Whether this is the environment, I don't know, I can't say for sure. But it certainly probably didn't help, and going back in time, I would probably have a mask on, for sure. But in my work, I test people in this area. We do CPET testing. I'm a physiologist, an exercise physiologist, and so I've had the opportunity to be interested in it, to test myself. But not only that, when I was an athlete, we also tested ourselves, and others tested us, I should say, and as a student in the area, I tested myself. So what I'd like to suggest is that, yeah, there's my activity. We every year with a bunch of blokes, we would do things, the Kokoda Trail, the Machu Picchu Trail, just keep active and try and have attention to detail in that area, knowing that I had to be careful and put the brakes on sometimes. But getting back to my testing, I just finish up with 3 graphs, and this is pretty rare data, if I don't mind saying so myself, because I was a phys ed student and then in physiology, we would test ourselves for a range of different health-related, performance-related measures. And this one here is pulmonary function, and you'll be aware of that, most of you, that you would do this, the FFV 1%. This is a percent you can blow out of your lungs, percent of maximum that comes out in the first second. The blue line up there, if I can just show it there, this line here, or grey, whatever you see it as, is an evidence-based population norm. So that came from published literature. That's the norms across males aged from about 18 up to 80, I think. It was a pretty random survey, about 2,500 people. But there's my data there. Yeah, it does seem all over the spot, all over the place, depending if I've got an infection or if I'm training or whatever, just technical error. But there's my line of best fit. And you have to say, you know what, you're ageing at about the same rate as everybody else. So don't be too concerned. It's a little bit lower, but no big deal. And my lungs haven't really seemed to cause me too much of a problem. Moving on to the next one, as I said, I always tried to keep relatively fit, and this is just like a measure of skin folds or body fatness. You've got the average here of males across the same age group with a sort of 95% in grey. I've always been reasonably lean for my age, and again you'd have to say, well look, you've always been lean, you're still reasonably lean compared to the average, and that hasn't changed. You're ageing and getting a little bit fatter as everybody else in the population does at about the same rate. But what's been interesting is this last one. When I was, this is a measure of fitness. So this is what you get in your CPET tests, a measure of fitness. And because, as I said, I've been able to measure myself, you know, before I was diagnosed with sarcoid, right back when I was a student and an athlete. And, you know, I was ageing probably with repeat measures here, probably a little faster, but I started higher, so maybe approximately the same as everybody else in the population. But around about the time that I collapsed and had cardiac sarcoidosis diagnosed, you could see it really drop very quickly. My ejection fraction was down to 35%. Had a lot of pain. You know, to walk as much as possible, but not too much more than that. And it's continued to go. It's probably a little bit less than average now. So that's my story. My philosophy is, I suppose, work with what you got. Attention to detail and every other health aspect that you can monitor. Probably the best person to monitor you. I know the question was asked. I reckon you yourself, you're probably the best person to know how you're sitting and how you're travelling. And if you're unsure, obviously you go to the medicos because you know who knows what organ's going to be next. And just enjoy what time you've got. Thank you.
Maybe one or two very quick questions, and we'll go to the next one.
Just wanted to ask, did you ever notice any difference in diet and alcohol, like food and alcohol, as to whether it helped or worsened?
Some foods, and certainly alcohol, will, yeah, some foods, if they're inflammatory, like licorice and things, all the things that I love, I got and red wine. I don't drink red wine. Anything that's inflammatory for me, I get an ache in the heart, in median side. Not so much red meat, but alcohol. I don't drink a lot of alcohol. I never really have, but yeah.
Thank you. Thanks, Tom.
Thank you. So I guess the interesting thing about my case isn't medical, it's more systemic. And so I was diagnosed and I'm treated in Taiwan. In case you need a refresher in Taiwan, it's a small mountainous island, about half the size of Tassie, that has roughly the same population as Australia. Very dense, but healthcare is a highly respected industry. And I think it shows that around the time they were getting their democracy ready, the healthcare system got in about a year earlier. There are a lot of similarities between Medicare in Australia and Taiwan's national health insurance scheme. It's a single-payer system with universal coverage. The only people that miss out are those citizens that live overseas. And the coverage is very comprehensive. It goes beyond Medicare, so you get free dental and mental health and all of these things we wish we had in Australia. And because the Taiwanese healthcare system was invented in the late 90s, they had the opportunity to look at a dozen other systems around the world and cobble together a system out of the best bits. And as a result, it has the lowest program administrative cost in the world. There are some differences, however. So where in Australia we gatekeep access to specialists with a very extreme comb, in Taiwan, basically, if you have something that you think is maybe a little bit more severe than what you'd go to a GP for. It's not just a cold and a flu. You look up your local hospital's website, self-diagnose, work out which department you need, maybe look at the doctors, and then you can book in with the specialist. Often the same afternoon, maybe the next day. The longest I've ever had to wait for a specialist appointment has been a week. And there are some downsides to that, of course, for the specialists. They see many more patients in a day. But there's also more of an onus on the patient to really make sure they take advantage of the session. If you want to be a successful patient in the Taiwan healthcare system, you have to prepare. You've got to do your homework. You've got to come up with a list of questions you want answered by your specialist. One of the designers of the healthcare system in Taiwan quipped, we've designed a health system, not a sick system. And so preventative medicine forms part of the system. So there are a range of free health checks for various groups, but there's also a vast cornucopia of out-of-pocket health checks that you can do. And it's like buying a complicated phone plan. You have these names like Premier Flagship, Premier Top, and it's up to you as a patient to work out how you would like to spend an entire day in the hospital. Do you want a colonoscopy? Do you want an MRI? It's all in your hands. And these are really great value for money. So just the top line there has 80 different tests from blood work, urine and stool. They've got cancer markers, renal function, lipids, thyroid function, electrolyte balance, diet, and you can buy just that line for about 500 Australian dollars. It's common to have health checks in Taiwan around significant life events. So when I was getting married, my wife and I decided that we were going to choose the Premier Flagship program for 40 plus. Which is the second column there, and I added an extra audiology exam for good measure. And you'll notice that all of the packages include a chest CT. Ostensibly, this is for lung cancer screening because Taiwan has a higher rate of incidence of lung cancer, but it's great if you're looking out for pulmonary sarcoidosis. And so basically, you've booked in a full day, or if you're a hypochondriac, a 2-day thing with an overnight stay. But they throw in lunch and pajamas regardless of whether you're staying overnight. And so you get more than 100 serious tests across a dozen different specialties over 8 hours for around 2,000 Australian dollars. And so throughout the day, in between tests, you have meetings with doctors from different departments, specialists, and they brief you on the results of the tests that have had the results ready. So in my case, I had a lung specialist who was the deputy department head assessing my chest CT. And I was lucky because my doctor had seen sarcoidosis before, 10 different cases. And it's very interesting that even with this low-dose chest CT that was not designed to find sarcoidosis, it's just cancer screening, you'll see that you had sarcoidosis as an option alongside lymphoma and the other kind of scary cancers. And so at this point, you exit the out-of-pocket health check because you found something and you re-enter the public system. So my doctor then took charge, arranged a follow-up CT with contrast to have a bit of a better look. That also pointed out the same thing. So we went for a biopsy. So this was happening at a large local hospital, but it wasn't equipped to do an EBUS TBNA, only a more invasive procedure. So I was given a referral to the National Peak Facility for Cancer, the National Taiwan University Cancer Center. And the interhospital referral program in Taiwan is a nationally standardized system. Basically, you get an A4 piece of paper, you go to that clinic at that hospital, knock on the door, give them a bit of paper, and they will see you. It's very streamlined and efficient. But my doctor also called and knew the doctor at the cancer center that was going to be receiving my bit of paper and introduced the case, as well as working out which hours he was working, just to make my life a bit more convenient. So Boxing Day 2023, under general anesthetic, do the EBUS TBNA. So I should point out, the CT during the health check was November, had the TBNA at the end of December. Then you have to grow all the cultures and work on the blood work and rule out everything that is not sarcoidosis in order to get a diagnosis. So basically 16th of January was when the confirmed sarcoidosis diagnosis was made, all those non-caseating granulomas and all that good stuff. And then treatment began. So I was referred back to my local public hospital, and by then my doctor had read up on all of the latest sarcoidosis research papers and explained the plan. Basically, we were going to go for prednisolone because it seemed like the least worst option, and just see if that worked. And this started a regular cadence where the NHI system in Taiwan allows doctors to request CT scans every 3 months for free without much effort or justification. They just log in and book them from their computer. And so we'd have a CT scan every 3 months, look at what the granulomas were doing, and work out what we wanted to do with the prednisolone. And so this happened over a period of about 18 months. And luckily, I responded well to prednisolone. And so we tapered down from 20 to 15 to 10 to 5 and eventually to nothing because I was having some side effects. Like the former speaker, I was also a sponsored athlete at 32, so I had a very active lifestyle, but I was putting on weight. 5 kilos in 6 months, much lower immune system. But we had a conversation about whether to basically keep at a low rate of prednisolone or go off entirely, and because of the side effects, we determined that it was better to just cancel the drugs and then move to a monitoring approach. So now I've had more than 6 months without any change, growth in anything in the lungs. That's technical remission. And we move to 6 monthly scans and then hopefully in the future 12 monthly scans. So when I think back about my experience and also my limited knowledge of the Australian healthcare system and try and draw out some conclusions that might be helpful as we talk about SARI and what we might like to do in the future, I think one of the big things that really helped in this case with a fast diagnosis, fast treatment, and a happy outcome was the health checks. Basically, I was not symptomatic enough that I would have gone and sought a doctor for the symptoms I had, night sweats, fatigue. It was only in hindsight, having got the diagnosis, that everything made sense from a symptom perspective. I think you can't argue with the raw statistics. Specialists in Taiwan see many, many, many more patients, and as a result, they see more sarcoidosis patients. Therefore, they're more likely to be able to make the diagnosis. I think the national peak facility for these kinds of diseases was very helpful. Getting a referral there to a facility that was streamlined, that was able to run all of the tests for the weird and wonderful things you need to exclude for these kind of rare diseases was great. And as a patient, I think one thing that was really helpful was this regular cadence. I knew I was going to see my specialist every 3 months at least for a scan, and we're going to have a conversation about what we're going to do with the treatment plan as a result. There's limited time to go through everything in great detail, so I'm going to pause there and see if anyone understood any of that.
Thank you.
I'm just wondering if someone could let us know about how often, like we're talking about monitoring in the CT scans, but I also understand that there's a fair bit of radiation that's involved. So when you're looking at the benefits, and should it be every 6 months if it is that it is active to keep monitoring where things are at?
Maybe Professor Thomas would know that.
Yeah.
Frequency of scans. What do you reckon?
Well, it depends. It depends really on what the last scan showed. So if the last scan was stable, then you would extend the time period. If the last scan shows something's happening and you've altered the medication accordingly, then you might want to do it earlier. But generally, we try to reduce the amount of radiation that people get. Nowadays, the CT scans are almost at the level of a chest X-ray. So they're gradually decreasing the dose of the newer scanners that is required. So in the end, we probably won't do chest x-rays. We'll probably just go straight for CT scans. But certainly as time goes on, the radiation dose is going down.
Yeah. They've actually forced a lot of the CT and X-ray machines to be put into pension. Sometimes they're sent off to New Guinea, which is a bit sad. One interesting point about this that I actually mentioned to Tom, I was actually invited to Taiwan for the opening of the new National Health Service there. And it was an extraordinary experience because Taiwan didn't decide to bring in the American multinationals. They ran a national competition to develop their own National Health Service, got 4 universities they paid them millions of dollars to do it. They developed a system, selected a system, implemented a system, and my experience of it was extraordinary. You turn up at a hospital there, they log you in, you become active, you go to most departments, there's not even a chair because you don't stay there long enough to sit down. It is quite extraordinary. So it was very interesting the way that you describe it, very much my experience, my short experience of Taiwan. But it is interesting that we in the Anglo world think that we're doing wonderful things, but some of the things that are being done in Asia nowadays are quite extraordinary. I'll give you one other example. I was with the CSIRO and I was an invited speaker there and we spoke at lunchtime. Then we said, okay, you can go off now, you're going to go and see Seoul. And I had a shirt on and my jacket and it was sub-zero temperature. And I was in sub-zero temperature for the next 8 hours being shown around Seoul. I got back to my hotel room and I was getting pneumonia. I was really very ill. Called up my SOS from there. They said, oh, you've got a Samsung University hospital around the corner, go there straight away. I went there straight away, same thing. I walked in, I was treated amazingly well. Everything happened in the space of 1.5 hours, multiple scans, multiple echocardiograms. And then they didn't want me to go home, of course, because I had pneumonia. I said, look, I'm sorry, I've got to go home, so I went home. And when I landed in Sydney, I got a phone call from them asking me how was I. This was Samsung University Hospital in Seoul. So organisationally, the way they do things in hospitals in parts of Asia are quite extraordinary now. I'm not saying everywhere in Asia.
Yeah.
Obviously, this is...
Just as a comment on that, so in Australia, I'm used to, if you need imaging, you will get a referral to an imaging place and then maybe a few days later, maybe a week later, you get a call to come in to the person that referred you about the imaging. So my average hospital visit for these scans, get there about 8 o'clock, CT's done by 8:25, go and get a coffee, then you see a doctor who's already got the scans. Like
it's very quick.
Yeah.
So there are procedural aspects here. But anyway, the next speaker is, who's the next speaker? Thank you very much. Jean Tonu. Thank you very much.
Sorry, everybody, I don't have slides. I'm just going to read my story. My name is Jean Tonu. I'm a 54-year-old mother with 3 children in their 20s and a wife to a wonderfully supportive husband. I'm currently employed as a claims assistant at Avant, a medical defence organisation for medical practitioners. My journey began on New Year's Eve in 2017 when I presented to the hospital with a sharp pain on my left side of my back and significant swelling in my left arm and hand. Like many patients with complex conditions, I quickly discovered how challenging it can be for hospitals to reach a diagnosis. Initially, I was suspected I had a dissected aorta. After many blood tests and several scans, a very young, wide-eyed resident informed me that I had stage 4 lymphoma, a cancer. The following morning, I was reviewed by my haematologist and pulmonologist. It wasn't until further investigations, specifically a bronchoscopy biopsy ordered by my pulmonologist, that the correct diagnosis was confirmed, sarcoidosis. Initially, my sarcoid was confined to my lungs, and as part of my standard treatment, I was placed on prednisone with regular blood tests and lung function assessments every 3 to 6 months, along with periodic CT scans and to monitor scarring and lymph node activity. Over the following years, the activity of my sarcoidosis fluctuated, I was eventually prescribed mycophenolate. My subsequent blood work and lung function tests showed improvement, and it thought that the disease was burnt out. It wasn't until 2023 that I began to recognise the seriousness of my condition. I first noticed skin lesions appearing on several parts of my body. Shortly afterwards, I experienced complete hearing loss in my right ear. With my ENT prescribing another round of steroids, my hearing returned. However, subsequent hearing tests revealed that I had in fact lost a degree of hearing in both ears. Not long after, while at work, I suddenly developed significant vision issues. Initially only able to see the first 3 words of a sentence I was typing, and then only half of my manager's face. I was transported to hospital by ambulance, where once again the challenges of diagnosing this condition were clear. I was reviewed by a junior registrar who recently completed his medical degree and who understandably demonstrated a limited understanding of sarcoidosis. Then a further evaluation with an optometrist, and I was sent on my way. Following a referral from my ophthalmologist to a neurologist, a comprehensive series of tests, PET scan, CTs, lumbar puncture, bone biopsy and full spine MRIs with and without contrast. It was finally confirmed that I had systemic sarcoidosis affecting multiple systems, including nodal, pulmonary and bone involvement. I'm currently under the care of 5 amazing physicians, and through my neurologist and the generosity of the hospital and pharmaceutical company, I manage my condition with a weekly injection of Hemira, which I'm currently receiving on compassionate grounds. This has slightly reduced the activity and made it more manageable. However, it continues to increase in my lungs. Given this, my pulmonologist and immunologist recently presented my case to the multidisciplinary team at Royal North Shore Hospital, with a plan to monitor closely a suggested change in medication if the lungs don't improve, along with a full suite of allergy testing. Recent bloods requested by my immunologist earlier this year have returned results suggesting the need for further investigation for VEXAS syndrome. VEXAS is a newly recognised clonal autoinflammatory disease caused by somatic mutations in the UBA1 gene, characterised by systemic inflammation, bone marrow failure and multi-system organ involvement. It predominantly presents in males over the age of 50. With 5 years of research and the familiar story of no medical trials, the American College of Rheumatology recently issued the world's first guidance statement for diagnosis and management of VEXAS, developed by the International VEXAS Working Group expert panel and published in Arthritis and Rheumatology. Once again, this highlights the complexity of sarcoidosis, particularly the overlap of inflammatory biomarkers and clinical features with VEXAS syndrome. At present, my immunologist is still awaiting the results of my DNA testing, with clinical suspicion that these results may return positive for sarcoidosis. I now have regular appointments with both my immunologist and pulmonologist. Both collaborate closely with other specialists involved in my care. One of the biggest lessons I have learned from this journey is the importance of maintaining open communication with your physicians and paying close attention to your body. If you notice any changes, even if your next appointment isn't due, contact your doctor. Don't hesitate to request a referral to a specialist in the area where symptoms are emerging. Even when tests and results appear normal, this condition can continue to progress quietly throughout the body, so early reporting and specialist input is essential. Interestingly, this condition appears to have links with my wider family, with my cousin recently diagnosed with pulmonary sarcoidosis and my niece concurrently managing severe Crohn's disease. Although Crohn's primarily affects the gastrointestinal tract, both conditions are characterised by non-carcinating granulomas and T-cell type 1 inflammatory pathways. Unfortunately, there is currently no diagnostic genetic testing for sarcoidosis, leaving an element of uncertainty regarding potential risks for my children. As we all know, sarcoidosis is a rare and often misunderstood condition, which can lead to frequent misdiagnosis. This not only causes unnecessary anxiety for patients and their families, but also complicates treatment and limits access to appropriate support. I feel incredibly fortunate to be under the care of physicians who are knowledgeable and passionate. Although I have been told that my condition will not go into remission, I'm currently functional, and that in itself is a significant milestone.
Jean, thank you very much. That's an extremely complex example of how complex sarcoidosis can be, and you have our sympathy for having to deal with such a complicated set of symptoms. Any questions from the floor? I think we're all speechless. It's very, very difficult. Well, I think it gave us the full spectrum of what can happen with sarcoidosis, from trivial to major to death. That's the reality of sarcoidosis, I think. Thank you very much. The next speaker is, Jeanette, who's well known to us. She spoke once before, I think. Didn't you? No, you never spoke before? I'm sorry, I thought you spoke at our opening session.
I can talk a lot. Hi everybody, I'm Jeanette from Brisbane, and I'd like to share with you my sarcoidosis journey. It's a little bit hodgy-podgy. If I had like sort of pictures up there, my brain would have put down all these things going here, there and everywhere. So it's probably better just listening to what I would like to share. So when I first heard the word sarcoidosis in January 2022, I had no idea how deeply it would reshape my life. What began as a pain behind one eye quickly led to a series of tests. A brain MRI, CT calcium score, CT chest, followed by a bronchoscopy. You might think they're all a bit odd, but anyway, that's the way it went to start off with. Conclusions from the respiratory specialists were lymph nodes were too firm and difficult to biopsy. Pathology results were not diagnostic. The lungs were permanently damaged. The disease had likely been active for decades. The diagnosis was chronic pulmonary sarcoidosis, and I was referred to an ophthalmologist and for an echocardiogram. I was prescribed prednisone short-term, followed by methotrexate. Moving back a few months before that, my GP had previously referred me to a neurologist just regarding the results from the brain MRI. And his words were to me, sarcoidosis can be tricky. And then I thought, well, I look back now and I thought, he was not wrong. So the discovery of this disease was unexpected and life-altering for not only me, but my family. At 63, I was an educator working in a hospital school. Absolutely loved it. I was working with some patients in oncology. And so I was planning for retirement on my own terms. My respiratory specialist at the time advised me not to return to work. So I opted to take leave, which ended up extending to 2.5 years. At which point I finally came to the realisation that returning to my teaching profession was just not possible. Working with children with constant infection exposure, it just wasn't advisable. My fatigue, my breathlessness, medication side effects and endless medical tests and appointments were really consuming my life. During the first 2 years, specialist appointments resulted in lots of tests and changes to treatment. So after 6 months, they decided to cease my methotrexate after there was no change in CT scans, and I had COVID. But then 3 months later, they had to reintroduce everything again. First of all, a short course of prednisone again, followed by methotrexate because there was a return in symptoms. So following that, during that time, I had 5 CT chest scans, 3 brain MRIs, a bike exercise stress echocardiogram revealing a wall motion abnormality, a stress test echocardiogram, a sleep study, 24-hour ECG analysis, and finally a cardiac MRI. Despite consultations with 2 respiratory specialists during this time, both reassuring me my sarcoidosis was probably not active, but I was not convinced this was the case. I reflected back on my health history, SVT episodes in 1995, a right bundle branch block diagnosed in 2011, bone lesions in my spine and hip discovered in 2013, and I had chronic sinus infections. And during these years, I'd seen an oncologist, a hip orthopaedic surgeon, ENT specialists, an immunologist, but no one was able to solve the puzzle. So it wasn't until I joined a sarcoidosis support group online in 2024 that I'd found what I'd been missing. I'd been community, shared experience and knowledge. Knowledge is power. So through other people's stories, I learned about SARI, about specialists that had expertise and an interest in this complex disease. So I realised I needed to be an advocate for myself because no one else could do it for me. So armed with my 30-year timeline of my medical history, I travelled interstate here to Sydney to seek some second opinions. Those appointments put the jigsaw puzzles finally together. The most significant outcome was confirmation of that I didn't need a PET scan. The only test that would confirm in my case whether my sarcoidosis was truly active or inactive, or whether it was still causing damage. Previously, no specialist had ever mentioned the word PET scan. So in May 2024, the PET scan finally gave me answers. No cardiac sarcoidosis present, active sarcoidosis in my lungs, and activity in my hip bone which needed to be reviewed. So after years of uncertainty, I finally had validation. My symptoms were real and my disease was active. So with the support of my GP, I began seeing a new respiratory specialist in November 2024. My methotrexate was adjusted and I'm now due for a PET scan at the end of this year to reassess disease activity and guide future treatment. I am fortunate my daughter works in health, and with her medical knowledge, she's helped me to navigate the complexities of sarcoidosis to provide me with the best quality of life. And this has been achieved by my daughter assisting me with research, coming to some appointments with me, coming interstate with me, and also to be not only support but advocate for me. Sarcoidosis is hard work. And retirement for my husband and myself has come with extra challenges. This is where I do the truth part. Learning to adapt to a lifestyle that includes a chronic health condition is not easy. Juggling medical tests and appointments, including budgeting for medical expenses because they are expensive. Flexibility with trip planning, like, getting on a plane and wearing an N95 mask and people looking at you as if you're, what's wrong with you sort of thing. All those things, so limiting exposure to infection so you don't become unwell. Adequate provision for rest as well. And careful choice of social activities. Sometimes you just, need to know your limits. Also, physically, what you can and can't do. Like, I can't climb up a big mountain like I used to. So in the past 12 months, this has included appointments. I've also had an appointment with a psychologist because I believe that mental health is an extremely important part of dealing with conditions like sarcoidosis, and we need to be proactive in making sure that our well-being is well looked after. It's called, sarcoidosis is called the snowflake disease because, everyone's experience is unique and it can impact the quality of life in ways that are often invisible to others. I keep hearing the words from my old friends and colleagues, but you look so well. And so when I look back and I reflect on my journey, the things that it's really has taught me is the importance of listening to your body, the merit in seeking second opinions when necessary, the value of community and shared knowledge, the power for self-advocacy, the need for resilience, and compassion for people living with chronic illness. I share my story to encourage others to persevere, to trust their instinct, and to speak up when something doesn't feel right. A correct diagnosis can change everything, your treatment, your quality of life, and your hope for the future. Sarcoidosis awareness and advocacy for this rare inflammatory disease is vital. Our voices really need to matter, and together, you know, when we can make a difference. I truly believe we can. I'd like to share or finish up by sharing the words from a recent text from my cousin in Victoria. To say that this disease has had a profound impact on my life is an understatement. I wonder what my life might be like for me had I been diagnosed earlier. And you're probably thinking why I'm talking about my cousin. My cousin had a cardiac arrest 6 months ago, and she was, luckily the emergency services, I think it was the fireys came, and of course she went to hospital and she was there I think for about a month, and her diagnosis was sarcoidosis. And that's my journey. Thank you very much.
Thank you, Jeanette, and thank you very much for bringing up mental health. I'll let you into a little secret. We tried to find a mental health specialist in sarcoidosis in all of Sydney. I asked around to 3 different hospitals, does anybody here specialise in supporting sarcoidosis patients? The answer was no, 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 no. And as a result, we had no mental health speaker at this forum today. So thank you very much for pointing out that this is an extraordinary experience on the whole family. My family's experienced it, yours has. Every sarcoidosis family experiences this. The loss of function, the complexity, the lethargy, the lack of energy, the change in life, the financial cost of PET scans $1,000, having your pacemaker measured and your Medtronic person being there $560. All these costs are quite phenomenal, and it's one of the issues that we'll be trying to bring up a little bit to see whether there's some way of being able to assist patients that have to experience this cost. But the mental health support aspect of it, both to individuals and families, I think is a very big contribution you've made, and thank you very much for that. Another round of applause. Thank you. And last but not least, Jenny Reid.
Good afternoon, everyone. My name is Jenny, and I've had sarcoidosis for 15 years. At the age of 37, I was diagnosed with stage 3 melanoma. My son was 4 and my daughter was 6 years old. I had radical neck dissection surgery. Following surgery, I was recommended to go on a clinical drug trial to receive a drug called interferon. I received the drug intravenously 5 days a week for 7 weeks, and then I self-administered every day for 7 months. At the time, the oncologist said the treatment could cause an autoimmune disease. We decided to go ahead because there was no other real option at the time. A couple of years down the track, I had a routine PET scan. The scan showed that it looked like the melanoma had returned throughout my body. The doctor did a lymph node biopsy and the result came back as sarcoidosis. The symptoms of sarcoidosis have been many and varied over the years. In summary, the symptoms have shown up in my lymph nodes, skin, eyes, joints, muscles and lungs. It has also caused fatigue, neuropathy, sleep issues, heart palpitations, balance and dizziness problems. My oncologist initially referred me to an immunologist. Naively, I thought that the immunologist was the only specialist I would need to guide me on my health management for sarcoidosis. How wrong was I? I have in fact reached out to many different professionals for advice on how to deal with the symptoms of sarcoidosis. These include an immunologist, rheumatologist, dermatologist, cardiologist, endocrinologist, neurologist, gastroenterologist, specialists for the eyes, lungs, ENT, pain management, GPs, dietitians, natural holistic therapists, acupuncturists, massage therapists, physios and hydrotherapy. Over the years, I was on and off prednisone and was recommended to take Imuran, methotrexate, Plaquenil and a number of other drugs. I actually got the scripts filled but never took them because there was conflicting advice as to the effect of these with melanoma at the time. I took doxycycline many times for the skin and Endep for neuropathy pain. I took vitamin D supplements and Mobic for the joint pain. I feel, however, that there is no clear advice on if and for how long I should take vitamin D and its effect on other functions of the body. I saw an integrative doctor at one point. He recommended low-dose naltrexone. I stayed on that for 10 months. There were benefits with fatigue, joint pain, energy and general well-being. Unfortunately, I had to come off that due to high blood pressure. I'm currently taking hormone replacement therapy and vitamin D on and off. I've used hot and cold packs for pain continuously over the last 15 years. I've been very, very fortunate throughout my health battles to have the incredible support of my husband, children and wider family and friends. Over the years, I've researched and read so much. I found FSR, which has really been a lifesaver in so many ways. I got all my information there from webinars, podcasts, and attending the summit every year. It was invaluable. I also benefited from the website Inspire, where I read stories from patients going through sarcoidosis. That was very helpful on an emotional level. Unfortunately, sarcoidosis has a low profile in the community and with health professionals here in Australia. I felt like it has been a very lonely journey for me. I look forward to the day when sarcoidosis has a higher profile, wider community awareness and treatment options are improved. Nevertheless, I became stronger and developed a positive and strong mindset over the years, which helped me. I had to get out there and find ways to help myself. So that's what I did. This has been a massive tool in my treatment. The best thing that has helped me over the years is exercise, stretching and movement, swimming and walking. It is hard, but I pushed myself because I got results from it. The results were relieving muscle and joint pain. It helped my body to move to get through each day. I do rehab Pilates, which has given me incredible benefits. I've been doing it for over 10 years. Breathing techniques, magnesium baths and massage, especially lymphatic massage, have also been helpful. But with lymphatic massage, does, however, tend to stir things up, but overall I think it's been helpful. Diet is a big one. Eating the right food. I have eliminated certain things. I follow an anti-inflammatory diet and gluten-free. I've always had a healthy diet, but in my research into the effects of diet on sarcoidosis, I have refined my diet specifically to address potential triggers for sarcoidosis. I believe that changes to my diet have had a huge benefits for my overall health. More recently, I've been investigating the potential benefits from wellness treatments such as hyperbaric chambers and red light therapy. I do not have any conclusions on this at this point. Over the years, I have noticed that I would suffer greater bouts of sarcoidosis in certain circumstances. After my interferon treatment, my oncologist said, "It will be very interesting to see how you go during menopause." I can tell you from personal experience that sarcoidosis and menopause are not a good mix. They have similar symptoms, but when you are dealing with both sarcoidosis and menopause, the symptoms are much worse. I've been on hormone replacement therapy for 6 years, mainly for bone density, joint pain and hot flushes. Of interest and separately, I read a 2024 Swedish study where hormone replacement therapy was linked to a 25% increased risk of contracting sarcoidosis. I wonder therefore whether hormone replacement therapy could be a trigger for flare-ups in people who already have sarcoidosis. I also personally believe that mould and stress trigger flare-ups of sarcoidosis. In 2022, I had tests done which showed that my body had high levels of mould. I was also under an exceptional amount of stress at times, caused by factors outside of my personal health, but also with the ongoing worry that my melanoma may return. I have long believed that this stress was an additional trigger when menopause, mould and stress are combined together. I believe they were a significant trigger on sarcoidosis for me. If there was one goal that might come out of this symposium, I think we need health professionals, someone like a clinical nurse specialist, a sarcoidosis-specific guide and support person. This person can come on the journey with you and coordinate treatments and referrals and review results and track your health with you. This would be a wonderful improvement to try to bring all the different threads together. Thank you.
Thank you, Jenny. Well, Jenny made another contribution to the whole panel, and that is she's an example of a citizen scientist who is desperate to find a solution, can't find solutions in except a medical dogma, and goes out looking for her own solutions for better or for worse. Now, a number of us have done that already. There were other speakers when we had the opening that did the same, and quite clearly this shows the desperate need for something better than prednisone, which is still the mainstay of almost everything. It is an amazing drug, prednisone, it really is, but it has very bad, strong teeth to it, which in the longer term can cause you major damage. So I think that we'd like to open up. Could all the speakers, the 5 speakers, please come to the front and sit at the desk here? And so can all of you collect your thoughts for 5 or 10 or 15 minutes and ask a few more questions, then we'll start up the forum about what we can do about this as SARI and what initiatives we can think of to help everybody in the next phase of their lives. So thank you again for having shared your story with us. Open to the floor. This time I'll give it to the gentleman up there because you're sitting in the front. I'll give you a second. Have you got one? No.
Oh, I do. I haven't learned that lesson. My question.
No, but they can't record unless you've got a mic.
Good point. My question is for Ken. I'm actually, is it Ken? Ken Norton or Kevin? Sorry.
He's the boxer.
Yes. Sorry, it's actually on the paper as Ken, so I wasn't sure. So my name is Craig Jones. I'm actually one of the admins on the Cardiac Sarcoidosis Facebook forum, and your mention of chest pain actually struck home a very, very hard and big point. A good 25 to 50% of all the people on that list have said at some stage that they experience quite regular chest pain. I certainly do. And there are a couple of people waving at me going, they do too. Has anybody actually really investigated what is causing that? I mean, it obviously can't be a heart attack or a significant cardiac event because otherwise we would know about that quite quickly. But it seems to be very common, and I'm wondering if anybody actually has got any research or has looked at that.
Just while you're getting that, I wouldn't say it's pain. I'd say it's an ache. It sometimes is quite an intense ache, but it's not really a sharp pain or a pain. I generally call it an ache.
Yeah, I suppose the only other comment is you can have discomfort from inflammation of the heart itself, so a myocarditis or pericarditis, so the inflammation around the heart. That can be other reasons for discomfort. But sometimes you get discomfort just because the heart is struggling, not pumping as strong as it should, and so in that situation you can get some heaviness or vague ache type thing. Not pain, but yeah, vague ache.
Thank you. Sorry. You're here.
This question's actually to everyone, and it's something that Jenny brought up about alternative therapies. One was that you spoke about was red light therapy, and the other was about lymphatic massage. Has anybody else here tried red light therapy other than Jenny and myself? No?
Yeah, I can say something about it. I work with a company that develops some red light therapy products, and the evidence, we're going to produce a medical evidence document for it, and the evidence for red light therapy in reducing pain and improving skin lesions was quite significant.
Yes.
Very positive.
And also energy. It seems to have something to do with being able to boost from being lethargic.
And
that's my
yeah.
experience.
And the company then settled, instead of going to a medical device, decided to have a wellness device because it was so much cheaper to have a red light facial mask, for example, that improves skin texture. So there is some quite good evidence for red light therapy for a whole host of different conditions, including more rapid healing, for example.
And you can actually get like the
whole body,
red
yeah.
light therapy for under $1,000. So it's cheaper to do that at home than what it is to go to places and pay weekly.
There may be some other risks with it, but short-term use of it seems to be quite positive. There was medical literature.
So my brother's a naturopath and I work as a nurse, and he uses a similar therapy it comes from Germany, and it's sort of like a red light, it's more of a laser type therapy, and he's been doing it with sinus, and his results, they say that a treatment in that hay fever can be put aside for at least 6 months, and so far he hasn't had any returns in 12 months. So it means they're not using any antihistamines. So there's some real stuff behind that, yeah.
Laser medicine is developing very early days.
Yeah.
The medical evidence for it is still a bit weak, but it's still developing area of medical research.
Yeah.
I was involved as a technical specialist for a company doing some of that research.
Yeah.
So there is evidence for it. It's not mumbo jumbo.
Yeah.
But it
So
still has some way to go.
I had some light therapy. I don't know, I was at John Hunter and they did some light therapy for my sarcoid in my legs, but by then it had got too deep into the veins that it wasn't actually going to be effective. So, but for a little while it held off some of the symptoms.
Laser therapy is now being used for the microbiome with Parkinson's quite effectively. Okay, any further questions?
The question before about the gentleman with chest pain, was that only in the context of cardiac sarcoid or just general? Yep.
Initially was diagnosed with isolated cardiac sarc, but it's escaped through it's been at random times spleen, bone marrow, bone and skin.
Okay. The only reason I was asking whether it's just because of the cardiac is if I don't know if there's a connection, but my physiotherapist mentioned that it could sometimes be costochondritis. Is that like chest pain, like around the rib cage? Is that something that's connected to sarcoidosis generally? Could that be a cause of chest pain?
Okay. They said to me, we think it's costochondritis. And I go over there, my son loves the cartilage at the end of my nose, the tips of my ears. Which is obviously, in the tips of the ears, it's utterly harmless. It's just when you wear headphones, you work all day, it's really irritating. But, it just seems to love my cartilage or something.
Any further questions on the sarcoidosis? Yes.
Yes, sorry. Just noting that all the female speakers, the name starts with J. I'm wondering if there's a causal link. Thank you.
Is it Jean, the lady in the middle? Yeah, I was interested. I've also just got sarcoid diagnosis with hearing loss as well. And that's the first time I've ever heard anybody else mention that. Was that picked up by the ENT or the hearing? Does anyone else know that that's a thing?
So it happened over dinner, and I went to my GP. Happened Friday evening, and my GP wasn't there on a Saturday, so I saw him on a Monday. I straight away, I told him I couldn't hear anything, told me to close my eyes, clicking, couldn't hear anything. He then referred me straight to see an ENT. He rang up the ENT specialist, told them I was coming. Went in, had to wait a while because I was just an emergency step in. I had the hearing testing done, which showed quite a loss of hearing. Went in. The ENT actually first said to me, "Have you had an infection just recently?" And I said no. And I waited for him to have a clearer look, and then I said to him, I have systemic, I can't remember whether I was diagnosed with systemic at that. No, I wasn't. I have sarcoidosis in the lungs. And then he told me that he just read he just read something in the medical books that there is a link between hearing loss and sarcoidosis. So he put me straight on to very, very, very strong steroids for 5 days. That hearing that I'd lost did come back, but then I went and had testing afterwards, and it was picked up that I had lost a degree in both ears of testing. Currently I have permanent tinnitus, and it's very loud, so it ranges from cicada sounds to clicking as well. I can get clicking while the cicada sounds are still going, so they're never turned off. And then clicking, and then also a really high-pitched sound. So there's no cure for tinnitus. However, I did look into, which I wanted to ask one of the doctors. This was quite interesting. There is, let me just find my questions. There is clinical evidence that transcranial magnetic stimulation and deep brain stimulation can improve chronic tinnitus. Haven't taken that path as yet. I believe it's safe and well tolerated, which is what a lot of the studies show, although it's not a permanent solution. It lasts around 6 months. So I'm actually going to change my ENT because I want to find somebody that's more specialised in sarcoidosis, and then ask if I could trial that and see what the results are. Yeah. I've got a lot of things going on.
That is again, one of the many rabbit holes you go down with sarcoidosis.
Yep.
I mean, my voice is the way it is because I have a laryngeal involvement, and for a long time all my ENTs, it's all to do with ageing.
Yeah.
My folds aren't closing because I'm getting old, but I was old last week and the week before that. And it didn't change, but it's changed now. So, there are many rabbit holes that we can go down with this sarcoidosis, and the neural aspects of it, I think, are probably the ones that are least well understood.
Yes.
I mean, and the tinnitus that you're talking about, some of the other very subtle neurological conditions, we know they're linked somehow, but neurology is such an unknown piece of a specialty that I think listening to Dr. Turlow was actually quite an eye-opener, because there seemed to be some quite deep knowledge there that I certainly wasn't aware of. So all I can suggest is to talk to a neurologist about this and see how far they've gone down this rabbit hole.
Yeah, my neurologist is actually a colleague of doctor that we had here today. She's amazing, from Sharp Neurology. Dr. Sophie Chatterton.
She was supposed to be here today but couldn't because of children issues.
Yes, she just had her second child. Yeah. And she's moving up to Port Macquarie, I think, shortly. She was the one that I actually found her myself, just Googling, and I went to her, and my first appointment with her, I was in tears because she recognised. I didn't even have to tell her anything. She just straight away, she said, "How are you not sleeping well? Do you have brain fog? Do you?" There was so many other questions she asked, and I couldn't even answer. I just started crying, and she realised that how bad, because I walked in the door and she said, "You've got a lot of things happening," and and I cried for about 15 minutes in there with her, and she was so good. She then went into testing my reflexes, and I've lost most of my reflexes on my right-hand side. That's when we decided to go and get a PET scan, which I lit up like a Christmas tree, from my brain to bone involvement in my 6-point something granuloma in my left femur, 3 points in my spine, 2 in both hips and 1 in my shoulder. And then I went on to see a haematologist, and I see an immunologist every 3 months at Royal North Shore Hospital, who Sophie works with. And so I just get a phone call, which I've just recently got, and just book in every 3 months. And that's when my bloods came back earlier this year with indicators for Vexus, and Dr. Boyle didn't even know what that was. So we had to look that up. We think it's the sarcoid flaring up again, because I'm not a 50-plus-year-old man.
You are a complex case.
But I am a complicated case, and that's where the compassionate Hemira comes in.
Sure.
And she then submitted my case to the hospital and to the pharmaceutical company, and then I've been told I'll be on that for 5 years, and then we'll see where we go from there.
Any side effects from that so far?
Constant going to the bathroom. A really upset stomach all the time. But the flushes at night have reduced, so that's a positive.
A few pluses and minuses.
But I don't really have a lot of side effects to it, other than it just upsets my stomach, and I take the injection every Monday. It's 40 mils. Take it every Monday, and I work from home on Monday because I know I'm going to go to the toilet about 5 times. So I stay at home, and then just through the week it reduces, and I do feel nauseous a little bit.
Okay.
But it's better than
all the rest.
Not being on it.
Sure.
Yeah.
Well, look, I think we should probably follow up and get on to the next phase, which is a really important one, to talk about SARI, what we can do with this very complex story that we've been listening to for the last many hours. But maybe a couple of more questions at most. Are there any questions? One up there.
I'm just really interested in the non-medical treatment modalities. When I presented twice at ED with chest pain, which I really needed to determine whether it was cardiac or not. On one of those visits, the ED director suggested that I could try some Chinese medicine, and I'm just wondering if anybody in the room has tried that, and has there been any improvement?
Chinese medicine is without doubt potentially very powerful, but we don't understand it well enough. I don't understand it. I'm not sure many of our clinical colleagues understand it very much, but it does. I have seen evidence of it in China and elsewhere where it can be remarkably effective, but we don't know enough about it, I think, to say much about it. Maybe going to a Chinese practitioner and find out about it. I have a Chinese GP who was totally pro-Western medicine, had women presenting with UTIs that were completely intractable to modern antibiotics. Out of sheer desperation, she went to a Chinese colleague and said, "What would you do?" He prescribed some medications, and all of the female patients got over their UTIs over the next couple of months. Yeah. And he was a person who was totally pro-Western medicine. So look, there's a lot to it, but I don't know anything about it, and most of us don't, unfortunately.
I'll keep everybody updated then.
So one last question, then we'll go back into...
I was going to...
Oh, sorry. Sorry, who's got it already?
The guy, Chris.
Oh, sorry, please. I didn't see you there. Go, Tom.
Yeah, I was just going to ask a question for Ken, and thank you very much for preparing those graphs. I think that was really heartening, just thinking about the future and those kinds of things. But I was wondering specifically about, with the benefit of hindsight and those cardiac symptoms that you had, which dropped that graph off quite severely, do you think you'd advise us to do anything different to prepare for something like that? Or do you think there's anything you would have done different had you known?
Well, just to get the chronology right, while I was training for the marathon, I was only 52 or something. That's when I was starting to get a bit of ache. And my cardiologist said, well, he didn't know I had sarcoidosis. He said, go in the marathon, should be right. 5 years later is when I collapsed and was diagnosed. In terms of, I wouldn't probably use Chinese medicine, if I could say it personally, with a heart. I would if it was a knee or an ankle or something. Heart, no. That's my opinion. Non-medical, non-cardiologist opinion. It's a bit of hit and miss, isn't it? So I'm very mindful of the most common way cardiac sarcoid patients' lives end is sudden cardiac death. So Chinese medicine to me is not on the list. I have found it difficult to get a cardiologist who really understands, and having said that, I come from Adelaide. Just a quick example, we've looked around with my GP, who happens to have cardiac sarcoid as well. So we're both in the same boat, very strange, but he said, oh look, I'll go to this guy, I think he might be okay. And I rang and I said, have you got experience? This is after spending so much money and time in London, a follow-up a year later or something. Yeah, I've got experience. And when I got there, I took my wife, and when we sat down, I said, how many have you seen? He said, I've seen one. And he died 3 months later when he was playing tennis. So there's not a lot of experience around, at least I haven't found it. So hence one of the reasons why I went to London. But I'm sure they see a few more here. It's a bigger city. And so if I was living permanently in Sydney, I'd be at your door talking to you, might even do that. But I wouldn't be doing anything else other for my heart or brain or any of those organs or eyes. Perhaps for joint pain, it might be worthwhile, but that's just my opinion.
Well, I think we should give you all a thank you. Just a little one?
Yeah, just to follow up on that, in my case I've got very aggressive neurosarcoidosis and I was struggling a lot with steroids, so I completely agree. I wouldn't do Chinese medicine just for management of everything. But in my case, I did acupuncture and the acupuncturist advised me about diet and everything. That certainly helped reduce and work out through that period of time. But I think it can be used as an addition rather than a replacement.
No, I think they're very good points. Okay, so let me just take a few minutes now to talk about SARI and why we set it up and what the objectives were. And really it's sarcoidosis, advocacy and research initiative. The advocacy part has become more and more important because the research has proven to be very difficult, in that we have applied for 2 major grants, multi-million-dollar grants. We're not successful. And we applied for a smaller grant. We're also not successful. We were looking at doing national registers like the Danes have done and the Scandinavians have done, and are using very effectively to carry out very good research. Because once you know who your population is and you know where the patients are, you can do a lot more. But that also hasn't been that successful. So we do have to think about how we can make SARI more effective as an advocacy group. And of course, to do that, you need to have an influence in government in Canberra. So before we go about how we do the advocacy, let's talk about what sort of advocacy we're looking for. What sort of issues have we raised here? We've raised the issue of complexity, the fact that this is a really complex condition. It needs a multifactorial team of specialists to support it. The multifactorial team of specialists is not necessarily available in one location. It would be really good to have a sarcoidosis centre maybe in every city in Australia. We do that, we start to hit the medical politics. Where does it go? Does it go to POW? Does it go to RPA? Does it go to St Vincent's? So there's the question there of saying having a sarcoidosis specialty centre would logically be attached to a hospital, and you'd have to overcome that problem. And I'm going to ask both Chris and Paul to maybe comment briefly on the politics of that. Maybe if you could say something about it. Otherwise, I suppose you could always say we could try and set this up as a private specialty centre funded out of Medicare. There are things like that. Dr. Barodi set up a gastrointestinal research centre in 5DOC, funded fully out of Medicare, basically. So there are ways and means of doing this. So maybe one of the points of discussion is we need to have a centralised facility where there is a large number of allied health specialists, medical health specialists, people that can actually manage a patient holistically from beginning to end, provide support, social support, mental support, etc. Maybe that is one of the objectives that we should have as advocacy. The other aspect of it is simply that of research. All of us involved in SARI are researchers. We are really dedicated to research. And we do have quite a number of ideas that we are pursuing. Paul has mentioned that he's in some discussion with some drug companies interested in certain particular drug therapies that may be worthwhile. All of these research topics require money, and quite big money. I mean, the one grant we put in that was meant to be a randomised controlled trial involving a couple of hundred people, involving multiple therapies, control group, etc. It was $3.4 million. And that means you need to go for an MRFF, the Medical Research Future Fund, NHMRC. And the question there again is, what sort of background support do we need to succeed with that? Do we just need to broaden, for example, the clinical base of SARI, bring in the Kumars and the Subrayas and the other people from the other major hospitals, put together a critical mass of clinicians so that we make SARI into not a university initiative, but rather a national initiative of some type, or at least a state initiative. So question again, this is a very strongly political question because every university looks after its own patch, as you know. Okay? So there's some of the other questions. And then there's the general question of saying, let's raise some cane. We know, for example, that once endometriosis became spoken about, and of course endometriosis, 1 in 7 women get endometriosis. My daughter-in-law has it, and I know how bad it is. Well, they raised cane. They caused a lot of, questions were raised in Parliament. They got members of Parliament to speak on their behalf. And lo and behold, the government came out with a $70 million fund to fund endometriosis research. $70 million. No competitive funding, no nothing. The government said, we're going to give $70 million to this particular group or this group of people to research this topic. And that was called basically by advocacy at the national level. Now, I've been in touch with some of our parliamentarians, including people like Zali Steggall, for example, who's a very smart woman in my area. And she's quite willing to go to bat for people like us. She's an independent, so she's not necessarily part of the dominant group, but nonetheless she can act as a bit of a point person in Parliament. And what you need to do is to get a few people in Parliament to start talking about this, to start saying, well, we actually don't have the numbers here in Australia. We don't know whether it's 10,000 or 25,000. But, sarcoidosis is causing a lot of pain for a lot of people. And by the way, we're going to give you a portfolio of patient stories. These stories we have through SARI, letters that I've received from all over Australia, and there's quite a large number of them, from as far as the Gulf of Carpentaria to the Kimberley, etc. And these are the patient stories, which is why we need to do something on behalf of this population that has been neglected for 100 years. I think Paul pointed out that nothing's been published in this area since 1950, approximately, something like around that time. No, 1970, I think.
Oh, in terms of Australia?
Yeah, in terms of Australia, virtually nothing's been published, and certainly no research has been done of any significance in Australia. I mean, that is pretty parlous. So I think we can start to agitate at that level to say, We want to do research. We have the capacity to do research. Here's a team of people that are involved, dedicated, experienced, and we broaden that team up. And we get somebody to start talking about it in Parliament. And then to support that, we have a letter writing campaign for all the local members of Parliament and all the members of the state federal government. Find out who your local member is, start to send them your story and say, I'm an example of it. This is one of 25,000. And I'll give you the stats because I'm using the stats from from Denmark. And based on those stats, we are about 25,000 patients in Australia that have sarcoidosis, based on those stats. I don't know whether we should follow the Korean stats or the Danish stats, but we're going to use reasonable stats where an upper class, wealthy, European type country, it's fair enough to use Danish numbers. So, the numbers are reasonable. So I think we should put together as SARI a document that all of you individually can use, edit it to make it appear not to be cookie cutter, rewrite it a little bit, and then send it off to your members of Parliament. And then at the same time, we can go around and try and see if we can get a few point people, like Zali Stegler is a person I know that I think she's very open to this. All of you may have particular contacts. Anyway, so these are some of the ideas. I want to stop talking because I want to hear your ideas. These are some of the things that we need to talk about to make sure that SARI becomes a significant force in this area, that we get something done.
Are you aware of any politicians that actually suffer?
I've asked our foundation people, our university people, they found one person that's very wealthy that is sort of interested, but they haven't come good with anything so far. I'm a bit disappointed, I must say. I've been talking to our people for quite a long time. They haven't come up with anything significant. I've been talking to the foundations. I have the Tyree Foundation that is quite interested, but they've currently put $2 million into the university to set up an e-health centre. So they can't quite do it now, but they're certainly possible. So I think the private foundations would be a source of modest funding and support.
People with vested interest, though. There must be, your word infiltration's going to, like if someone's going to be more passionate.
You're right, totally. If you could find a multi-millionaire who's got sarcoidosis, a member of Parliament, Sorry. Open to that sort of shenanigans. I think we've got to do some shenanigans. Okay, think up a few interesting stories to get some attention.
Has there been any suggestion of any fundraising events or anything?
That's what I want to say.
Yeah.
What we're trying to do here with this forum as well is I would all of you like to put yourselves forward to be part of a patient forum of a SARI community forum. Okay? Yeah. And write to me that you're interested in being involved. I will help to set up a chat group for the whole group. Tell me whether you are local or tell me where you live so that we can sort of do things locally if necessary and we will then start to do things like some sort of fundraising.
Yeah.
I mean, the sort of fundraising that I know is long distance running events, things like this. You can't do it anymore, but maybe you know how to organise it. Maybe you know how to organise it. Fundraising. Yeah. Smallish things that raise a few $1,000s is great. I mean,
absolutely.
Parties that. When I was a fencer for many years, and we used to have illegal gambling nights. We used to invite the police force, because half of them were fencers, to come to our gambling nights. So we were totally safe, but we would raise $3,000, $4,000, $5,000 on that night. Yeah. And so there are things that we can do. There could be a series of constant little things that we keep our energy going, and then we mobilise the resources we've got in your energy. It can't be just us. All the people in SARI are really busy clinicians. They've got flat out, efforts. And I'm retired, but I'm also flat out busy all the time. But I can do things to help coordinate things. That's my role. Okay. Tom.
I was talking philanthropic. Steve, you brought it up.
I just wanted to find out about the past efforts. So the NHMRC is the obvious funding agency to go to for this, but hasn't been successful. Have you? Yep.
Both times we weren't successful. The second time, we got reasonably good results back, but we were definitely remiss in not having included a health economic evaluation of outcomes,
Yep.
and we were knocked back. But we were told that we were unsuccessful 2 days after the deadline for submitting the next year's round.
Excellent. That's
and
great.
And they wouldn't allow us to resubmit, which would have been very, very easy to do.
Indeed.
So this was really bloody-mindedness on the part of the NHMRC. And now we haven't seen, that was a special round on rare diseases, I think it was called. It was a clinical trials on rare diseases.
Yeah.
It was tailor-made for us, which is why, but we got onto it a bit too late and we did leave this one section out and we got clobbered for it.
No worries.
So,
I'm just wondering whether something like an NCRIS grant, research infrastructure, it's under education rather than health and welfare, and it would seem to be appropriate if you want to do something like set up a patient registry.
Yeah.
look, any sort of detailed ideas like that, put down on a half a page or 2 pages to allow us to then pursue it further, we'd like to look at it. I mean, there are really wonderful sources of funding in Australia. We don't know all of them. I'm very heavily involved in a national group called Advocacy, the Academy of Technological Science and Innovation, and I in fact share the Health and Medical Technology Forum. But this is not quite in that sort of, this is really pure clinical research, so we really have to look at clinical research opportunities and ways and means of... Could I just go back 2 steps? Paul, Chris, could you say a few things about the whole politics of doing something like this and what do you think about it?
No, thank you. You're well done, Branko, dragging us all together. I think it's the only way that things are going to move forward. A couple of comments. I think it needs to be a national approach. I think any research grant that we put in the future should be multi-city. I mean, we had just local people. Any of the research grants, you have an 8% likelihood of being funded. And return on investment for the time it takes to write a research grant and the likelihood of success is terrible. The registry, the Department of Education grants, I think is an excellent idea because they are slightly different. They're not sort of technology or medicine focused. And there's quality healthcare. There's also, I think that also falls under the Education Department of Education. So I think that is the appropriate forum for a registry, and I think that is certainly something that is worthwhile pursuing.
Some input into that, Tom? Do you know about it, or do you have some input into the process?
I previously ran a $50 million NCRIS funded program, so I know a little bit about
there
it.
You I think that's some insights. In terms of running a nationally funded sarcoid centre, I think there are 2 differences, both from Kevin and from Tom, sorry. The NHS is able to, run an outpatient service very well, and so, that's how they can get, specialists to sit in one room and run that. And the Taiwanese health service is absolutely fantastic and recognised to be fantastic. And I think Australian health service does not function the same way. The Centre for Digestive Diseases is a procedurally funded Medicare thing. So if we were all proceduralists churning over procedures, you use the excess funds to run a centre. As clinicians and physicians, unfortunately, as a non-procedural physician, I can assure you, I'm one of those people that drives, normal cars, and so, so I think that's, that's probably not the way. A privately funded national centre is not going to happen. You need some other source of income that will be able to subsidise it, and with gastroenterology as a procedural specialty, then you have the funds coming through. I think they were the main comments that I wanted to say. Yes, I think we need to think nationally. I think, the other big point that I want to say is that patient advocacy is really powerful. And I think one of our failings on our research grant application is that we didn't have as strong patient advocacy as we would have the next time. Just even running this symposium demonstrates interaction, community involvement and consumer participation in formulating research, and that is looked upon very, very much more highly than individual clinicians driving their own pet theory.
We've got to make sure that we put all of our ducks lined up in a row.
Yep. But I'm saying we're a lot better now with this. You've got to think beyond RPA Westmead. You've got to think Fiona Stanley. You've got to think the Alfred. You've got to think Prince Charles. So you've got to actually take a national approach and pick out the important people in each of the major centres around Australia. Because, when you look at Denmark, very small country, smaller population, but very small country, they can have a centralised sort of system and awareness of, the risk of a hospital, and the Karolinska in Sweden, they have a big population in very specialised and very concentrated area. In Australia, we've got to take everyone from around the coast.
I think if you get the statistics from around nationally, you have to be able to help everybody nationally as well. You know what I mean?
We've tried to use statistics on sarcoidosis. They're almost non-existent.
How about just doing a local phone call to the GPs?
Bodies, we try to find out. We did get some stats on the number of sarcoidosis patients that attend emergency departments. We have primary diagnosis of sarcoidosis or secondary, but it's not primary statistics. We don't.
What about a questionnaire of all the people that, say, for instance, who are here or know someone else who has sarcoid? Have the questionnaire, all those results come together, that be submitted as part of a application for a grant, because it's then showing that there's more. There's people from all over Australia here.
Capitalising on what we've got and what we've put together is going to be a key part. Whether we do that for a questionnaire or by putting together the results of this forum and all the patient stories and putting a nice storyline, producing a nice package that says, this is our patient outreach, this is our advocacy activity. Sure, we can try and have a look at something like that. Sorry, Paul, you were about to say something. No?
I'm happy just to follow on from Chris, really, and I'd agree with what he said. I think that the return for investment in terms of NHMRC is very low. 8% is success rate is really quite sad in this country. The other issue that Chris alluded to, in that if you have a centralised healthcare system that doesn't differentiate between inpatient and outpatient care, it can work better, as in the NHS, and you're not being paid per item of service. Whereas here, certainly in New South Wales, there's a push to try and remove public outpatients, and they're trying to actually reduce the number of staff in Prince of Wales. I'm sure it's going on elsewhere in the outpatient departments, and close things down, which will impact me as well as other people. So the idea of actually having a specialised clinic is a good one, and it would be most appropriate, but it's in the background of a more difficult financial situation. And
so where do you think that clinic would be?
Maybe I could ask somebody sitting behind me who knows about genetics clinics. How did it work? How does the genetics clinics...
So in New South Wales, genetics sits outside of the... it sits both within the public health system, but also has a separate organisation, subset in New South Wales Health. I could ask somebody in that centralised service whether a specific group that was such a mix of different specialties, so it doesn't fit under respiratory, it doesn't fit under cardiology, and that's the sort of service that they do. They do statewide services. So if you could, maybe that's the first step, is to ask people about the likelihood of setting up a statewide service, because like cardiac surgery is a statewide service, isn't it? No, I don't even know. Transplant is, okay, yeah. But for that you need the health economist to be able to help you. So really what you're missing is a health economist, but also an implementation scientist. You need somebody who's going to say, again, if I got those two questions to me, then I could look into the implementation science people. There's somebody at UNSW who's a Scientia person who's worked in implementation science in lots of different things. And New South Wales Health has implementation public health grants. The problem is that they get given to the person who's got the most, in asthma or something where they're going to affect many thousands of people, or diabetes. It's not really for the niche groups. Have you talked to the rare diseases?
Well, that's the grant we're applying for. And that was the first time we saw something that was called rare diseases. And
So,
we latched onto that.
Yeah, New South Wales, in the University of New South Wales, there's a specific group called Rare Diseases, the Rare Disease Forum. So I might reinstigate my attendance at one of those, because I'm at the stage of retiring, so I'm pulling out of things. But
Any sort of strategic input like that would be available. We can follow up.
there's certainly the Rare Diseases group at University of New South Wales. I think the person, Adam Jaffe, is the key person, but there's not a lot of adult people involved in that, so they might be keen to have some adult input in that. So that might be another way of going forward. No.
She's a very big mover and shaker, but more in the medical devices area.
Yeah.
But she knows how the system works. So
Yeah.
she works with me very closely
Yeah.
on this forum. So I do have access to her. I can get her to help me understand how the NSW health system works.
Yes.
The right questions. So the right questions, Chris, that you were talking about was the possibility of setting up a statewide service like a genetics institute, something like this.
So it doesn't even have to be statewide. So what happens so I'm involved in a number of national groups, and what you do is you set up a sarcoidosis management meeting where you bring your most troubling cases to the national meeting. So there's 3 that I'm involved in. One is, anyhow, it doesn't matter what they are, but that then gives you the kudos to be able to say, we already are part of this national meeting. And it's really, you might have 19 people from all over Australia that come to the meeting to have their most difficult cases discussed. So that's the sort of model that I think would work best, rather than having the patients go to that, having the doctors taking the patient's report. So in paediatric oncology, they have that for their transplant, they have that for their, the cancer genetics in paediatrics have a national meeting. It's run under... No, I don't. You'd have...
Melanoma Institute is like means so much to me. Professor Long and the beautiful Professor Scolia. Professor Long was the first doctor I saw for melanoma years ago, and I had the honour of meeting Professor Scolia as well along the way. Amazing. Oh, I feel like I've built that building at Wollstonecraft, but anyway, they're incredible people down there at that Melanoma Institute. Yeah, amazing people.
They have a discussion board where they have around various institutions. So there's a sarcoma, a statewide sarcoma group that it sets up as an MDT in a certain space and then goes forward. So you might say you'd have to have a model first for all of the specialists here to have a meeting, which then you would you'd have to have something working before you sent it to any other state. But that is a really good, it's worthwhile doing. Like in respiratory, you do that for, what's that thing that the one that they discussed me at?
Pulmonary fibrosis or pulmonary hypertension, we do interdisciplinary meetings.
So that's the sort of thing that I think if you can start it, because there's lots of other examples, if you can start...
There needs to be a parallel pathway. So what we've got to do is we've got to prioritise where we have to put our energies and try to work out sure I will, I'll come to you in 1 second. We've got already on the table probably about 6 or 7 ideas about what to do. And of course they can go forward in parallel to a certain extent, but we also have to marshal our resources to make sure we give the appropriate resources to those that we want to push forward hardest, earliest, and put some on the back burner and others accelerate them. And some you can do slowly in the background, writing to your members of parliament, causing chaos a bit in part. That can happen almost as a background activity, but other things need to be very carefully thought out. We can't afford to go wrong. If we go to any one of these national meetings, we've got to have all the clinicians tied up, the patients tied up, all the social groups tied up. So I think that's going to be probably quite an important way to move forward.
And another person who's working, Mike Freelander, who's New South Wales parliamentarian, he has stood behind a lot of, so we got a drug that was for a rare disease, and it got through Parliament very quickly because the patients all wrote. The patients went to Canberra with the clinicians and spoke to the various clinicians there. But that takes a lot of organisation. That's a really hard thing. But he was behind all of that. And if you find most of the medical things that have got through Parliament, Mike Freeland has been behind them. So he's a really important federal Parliament.
Now that brings me back to one of the very first things that was brought up by everybody. We all now know how important PET scans are. I've had, I think, 8 of them. And they're each about $1,000 each, and they're not nice things to do, but they're really valuable because they give you quantitative information, virtually unique quantitative information. So one of the things we can do fairly early is to sort of agitate about putting it on the medical benefit schedule, particularly for sarcoidosis, as a legitimate way of tracking and managing of sarcoidosis. And I think even on that could be a Trojan horse to get a lot of other specialists on side. In other words, that's the way we could reach out to every specialist doing sarcoidosis, all the ones that couldn't be here even today, the ones from Westmead, from RPA, from everywhere else, and say, do you want to work with us to try and put this case forward to Parliament? That would give us something legitimate to work with, quite valuable for sarcoidosis patients, and it will give us a relationship with these doctors that then take them to the next step, whether it's research next steps or organisational next steps. What do you think about doing something that is a fairly high priority?
Yeah, I think that's fairly easy. We've got contacts now with cardiac society.
Certainly the nuclear medicine fraternity is keen to expand its the Medicare numbers, but not just for sarcoidosis, but for other inflammatory disorders. But it would be worth trying to contact them.
I actually went down the track with parliamentarians a few years ago, and what the big thing that really started it was my daughter's a type 1 diabetic, and she went and saw our local federal member with her story, and he was so taken by it, he invited her to Canberra, and he said, I would like you to come to Canberra for the day and share your story. And because we were involved, or she was very involved with the Danny Foundation here in Sydney, who were very involved with type 1 diabetics, and they were trying to get continuous glucose monitoring to everybody, not just certain patients. So we all went to Canberra for a day, and what we had to do was we made appointments with our local members. So I made an appointment with my local member, and so we did for the whole day. There was probably about 40 of us, and we just went to Canberra, and they gave us a spot to all hang out, and then we all went off, and then we had a meeting with the Greg Hunt, who was the Minister for Health at that time, and spoke with him, and we actually had a great outcome. We got CGM for, they announced it in the next budget, I think it was for pregnant women and for people with a disability, but it was those people who turned up with their stories and, actually, really showed what they had to live with that made the difference. And then with 2 years after that, we got continuous glucose monitoring for everybody in Australia. So it can be done. But I think the big thing is personally, I was going to go back to the same parliamentarian, but he lost his seat. I'd already organised, I had a Sarcoidosis T-shirt printed and everything and was ready to go, and then he didn't win his seat back. And I went, oh, damn. So I'm happy to start again with my new federal member, but...
Yeah, hi. Just a bit of a plea from interstate patient and all of the interstate patients. I really like hearing the idea about a national centre, because I think the state-federal system in Australia really does people with complex diseases a disservice. And also I think for SARI, there's so many more voices beyond Sydney and beyond New South Wales. Yeah, so just even things like, I know like the Sarcoidosis Australia Support Group was really excited, hoping that this might be available online, because there's a huge amount of interest, because, it's the first sort of branch that's been... which is incredible, and I think it's such a good start. So it's not a criticism, but just for the clinicians to think nationally when you're thinking about accessing patient voices for your grants and accessing parliamentarians and writing to parliamentarians, it's a national problem.
She's been trying for the last 10 minutes to actually say something. She grabbed the microphone just then. Yeah. Sorry.
Thank you. Thanks. So what I think it's really important is just to start from really basics, and like all these initiatives, of course, are really good, but a lot of money will be involved. But we have, in every single specialty of the doctors that have been involved in here, there are national conferences where they all meet. We've got them all in one room. So what I was thinking is that maybe if, some small ethics project where a simple questionnaire, one slide presented at the end of the presentations, where they can do a QR code and be prompted that if they have patients with sarcoidosis or an interest for sarcoidosis, for them to, answer a couple of questions. That would help to get basic statistics, and also would help to have that list of specialists that are interested in managing these kind of conditions. And the other thing is that being a national conference, then you could have target teams where you could do multidisciplinary approaches in different states as a starting point. That's my suggestion.
We tried to do something similar. We developed a QR code, a URL, and we got the Australian New Zealand Cardiac Society and the Thoracic Society. The idea was to ask specialists, do you have experience with sarcoidosis? Would you like to be registered as a doctor with expertise? And we got a reasonable result. We got 27 doctors responded, basically. But you're right, if you could get something that was super easy at a conference, we may get a few more to do.
And just basic numbers, because that will raise awareness, and you can go with that information to the politicians and everything, just saying,
So what would this QR code actually, where would it point you to?
So sometimes when you're doing, research-based questionnaires, you could have it as a, SurveyMonkey questionnaire or something like that, and then all that data could be analyzed into graphs, and then you can have those graphs to add to your grants, to everything. And even things like asking how many patients do you look after with sarcoidosis, from an ethical perspective, is way easier than approaching the patients directly, just for privacy. Yeah.
Talking about the 25 doctors that have got interests or specialty those 25 doctors, they're not actually listed on your website.
Not yet.
They should be. I'm sure that all the people in here would be.
They're all over Australia.
I know,
Yeah.
but
Yeah.
I guarantee you that there is probably 50 to 80% of the people in here that have actually travelled to see someone who's got some sort of skill in sarcoid. Is that roundabout right? I know I have.
So anybody here has experience with websites, maintaining and running websites?
I actually go to scientists. Not so much of the website stuff, but
Because currently our website runs on the university system, which has a unique website that nobody else knows how to run. And for me to get anything on the website, I need to go through both the head of school's PA, who's a friend of mine, because I used to be head of school, so she used to be my PA. I go through her for help, and I go through a lovely guy called Jason, who helps to put things on the but it's not easy for us to do. So one of the things I'd like to do is to sort of make this website easier to be managed by anybody. What do you use? What technology do you use for websites?
I actually, for myself, I'm using a third party. I'm doing data analytics.
Mm-hmm.
Which
Okay, when I ask you to contact me in terms of being willing to be on this community, on the SARI community group, if you could also identify any skill set you've got that's particular. You know, I'm a good writer, I'm a good publicist, I've got great connections all over the world, I know how to run SARI, I know how to run the money markets, I know how to do Bitcoin, whatever it is that you think you've got special skills in, tell us, okay? Just to put that little bit in your... So please, those of you that want to be involved, and we're not going to go much longer, we've been going to 4 o'clock, it's time for us to leave. I'm buggered and most of you are as well. But, you know, we've gone a long way today, I think. It's been a great day for me. Thank you ever so much for coming. All of you that participated has been wonderful. Yes?
Quick question. I talked a lot about fantastic ideas. There seems still a bit of a disconnect with GPs. A bit of a disconnect between what GPs know and the specialists that already know something about sarcoidosis. And there's also lots of specialists that don't know much about sarcoidosis. And so it's fantastic, all this idea of setting up a national group and so on. But how do we get the information to other doctors across the country about sarcoidosis so they're aware of it and so they know who to reach out to if someone comes to them with sarcoidosis?
Look, we failed this time with GPs. We won't fail again. We failed this time because we didn't have enough time to really go through all the processes. They're very bureaucratic. You have to go through the RACGP. You already have to... I've done this before for telehealth, so I know how to do it, but we just didn't have time to do it this time. You've got to go through the RACGP, talk to them, bring across the specialist, talk about what we've done already, tell them that we are desperately keen to get the GPs involved. How do we do it? Get them on side. So we will do that. As I said, it was a failure, and this time around, my failure, I did everything possible. I emailed every primary health network, I emailed every community health centre, every local health district. We got very low response from GPs. Okay.
I'd be happy to donate a day a week to go around to every GP in Sydney and ask them. I would happy to do it that for a day.
Mm.
Going to GPs.
The GPs.
I have sarcoids. I need help.
Yeah. So to co-opt your help would be a very good idea as well, but we will at the same time do a two-edged sword. One approach will be to go to the RACGP, get them officially from the very top, very much on side to say, yes, this is an issue that needs to be addressed. Our GPs know sweet bugger all about this stuff, and our patients tell us that, okay, and use them to do something, and then to at the same time use every person here, everybody that's actually come to this conference or that goes to SARI to talk to their GP. So I'm going to have to summarise all this stuff into a document that I will send around to you. When I send that around to you, it will be a draft document. I'm sure I'll forget something. My memory is not that great. So please feel free to scratch all over it, add to it, modify it.
Can I just make the comment that whoever was talking about making sarcoidosis T-shirts,
Yeah.
if you've done that, could you send it around to everybody or
Yeah, I wouldn't recommend this brand though. It's a bit squeezy on me, but I wore it to the supermarket the other day.
Yeah, maybe there should be like a bit of a competition where everyone sort of presents options, and then everyone predicts which one they like best.
Yeah.
Yeah, so do I. I've got a few of the American ones. I've been donated to the American. They've got t-shirts for the whole family. FSR.
Well, we want to do our own thing. We're Aussies.
Yeah.
And the Americans on the nose.
Medicare, that's a good place to start with our local politicians and what have you, because now they have cut PET scans to 1 every 2 years for Medicare.
Sure, I think it's not just that. That's not completely, there's none.
1 every 2 years.
For what disease?
That's Queensland.
For what disease?
Cardiac sarcoidosis.
So in Queensland you can get
one. Well, I shouldn't say that.
No, I couldn't.
Not cardiac.
I pay for mine myself.
Going under the.
I mean, Medicare is a federally funded thing. So when you go into our St Vincent's PET scan, they say, oh, this is not medically funded.
I had to pay the fee. I have to pay the payment next time too.
A certain amount, like 800 or something.
So somebody subsidising. Maybe it's a state subsidy.
Yeah.
Is it?
South Australia, the same.
Queensland.
Well, Medicare. Federal.
Medicare is federal.
Yeah, so
it must be subsidised by the state.
Don't know.
I don't know, but they will pay on 1 every 2 years.
I think it depends on the item number. What's
Well, maybe there's obvious.
What's the item number?
You didn't pay for any of that?
No.
How do you do that?
I think the first one was because the CT scan came back saying over so they got it that way. I have no idea how she got the second one. I was very sick at the time, but I have no idea.
Clinically,
Just got it through. She said, turn up.
So this might be where interactions with GPs might be able to go a little bit further. So I have a mate who's a GP, and when I was telling him, oh, scans for sarcoidosis aren't covered, he said, oh, no worries, I'll just code it under this other thing. And so I believe that's what's happening right now.
Yes. Yeah, no, not really.
Yeah.
Yeah, it's the item codes. They sometimes put a different item code and they can get away with it. It depends how much they...
If you paid attention to my slides, there was a little comment at the bottom of the gallium scan referring to the coding.
Yeah.
To the which?
Coding for PET scans.
Okay, well, look, obviously the PET scan aspect of it, we need to look at it, and there may be a few ways to skin this cat. But all I know is that I've done 8 at St Vincent's Hospital, and I've paid for each one of them over the last 12 years.
Over the last 6 years, I've done 12, and that's the first time I've had to pay that amount of money.
Well, you're smarter than I am.
I suppose it's my cardiac specialist.
Sure, okay. Well, look, there's a few things to do. What I'll do is I'll try and summarise the result of this session, which was this, what I call our strategy breakout session. There's quite a large number of items on it. I will try and send those around in some sort of priority order, and I want you all to firstly email me. See, one of the problems I had is when I tried to send people only give me their mobile phone number. I actually paid money for a program that allowed me to email to an SMS number. Did any of you get that message? No? No? So what I'm saying is, firstly, email me your interest in being involved in a community group to support SARI and the wider SARI activity, which we have to take national. I will then make sure that probably over the next week I want to organise the video conferencing of all of this to be complete and done and edited. That will go in. So in a couple of weeks I will commit to sending you back a document with all the dot points that I can remember of things that we were going to do in some sort of priority order. So if you can then come back to me and edit those dot points, I will then produce a second document that will be a little bit like our working sheet for our immediate next few weeks, months, whatever.
With contacting members of parliament, it should be sort of set up like a campaign with a time frame. So therefore, it's not that one person just sends one next week and then someone sends one in 3 months. Like if there's some sort of correspondence that's going out to everyone and says, this month we're hitting all of
Sure.
yeah, the local members or what, so then everyone
I think for
takes that
every
step,
activity that we have, we set up a working group from this working group
Yes.
that takes control of that. It's not going to be the Branko show. It's not I'm meant to be somewhere on the sidelines. Okay, so everything that will be done with a working group, you people. Okay, and I'm happy to sit there and help in whatever way I can. Get access to your resources that I'm very good at doing. But you know, it will be a working group, and the working group will say exactly how that happens. Okay. So I'm just about done. I think you're all just about done. So I think I want to finish off by thanking all of our speakers again. Thanking all of you for lasting till 4 o'clock in the afternoon, which is a fine effort. Thank you to the